Surgical Oncology, Head of the Department at IMS in Sum 2, Dr. Makaran Kochikar. The first talk for the day is Augmenting Prostate Cancer Diagnosis with AI, Real-World Insights, Challenges and Solution by Ms. Shreya Kumar.
Get access to this? Can we want to? Oh, okay, perfect. Thank you. Diagnosis, and today in my talk today I'm going to be. Yeah? Okay, sure. Yeah. Hello? Yeah, okay. So in my talk today, I'm going to be talking about some of the deployments that we've done where we've deployed Curative's AI solutions in India as well as with other labs globally. We're also going to talk a little bit about some of the learnings that we've had along the way. We'll be doing a live demo of the solution as well. So from the talks yesterday, we saw some of the amazing advances in pathology. But I think everyone would agree that histopathology is still faced with a lot of key challenges. We all know that there's increasing cancer incidence on one hand. However, we also know that pathology is such a critical science with 70% of clinical decisions involving pathology, despite which there is studies documenting that there is a dwindling number of pathologists across the world, leaving 47% of the world's population with little to no access to diagnostics. And there have been studies documenting that for certain types of cancers, the concordance between pathologists in diagnosing certain types of cancers is as low as 55%. So the idea behind Curative was to be able to apply technology to bring in some objectivity in this clinical diagnosis. So as mentioned here, this is our mission statement, our vision. Our vision of the company is to be able to empower healthcare professionals across the globe with our AI-powered solutions. So to this end, we've built various clinical AI solutions that I'll be talking about in more detail. So I think everyone's now kind of familiar with the idea of digital pathology. So you have your conventional pathology where, once the tissue sample was processed and placed in a microscopic slide, you would have pathologists look under the microscope and assess the specimen. But, okay, I don't know, this keeps moving, I'm sorry about that. So, but now with digital pathology, there are lots of scanners where these microscopic slides are now scanned using slide scanners. And after they are digitized using slide scanners, they're then uploaded into image management systems. And some image management systems are augmented with AI solutions like ours that analyze as well as grade tumor regions. Two main concepts that I wanted to go through before we move into what Curative does and move into our solution demo was firstly, what a WSI is. So a whole slide image basically is the process of scanning entire pathology slides to create very high resolution digital replicas. So one of the questions that we get asked commonly is, can we use images from the microscopic camera to run AI on it? So the answer is no, because we would need a whole slide image in order to run AI on it, because a whole slide image presents a wealth of information. So you can compare a whole slide image to kind of like Google Maps. So think of the various zoom levels that Google Maps provides, and also the different information Google Maps provides about the various layers. So think of the terrain information, the street information, landscape information. It's very similar to that. A whole slide image provides a lot of detail about the tissue image that helps us build more accurate deep learning models. And another concept, again, this was discussed yesterday, so it might sound like a bit of a repeat, but again, deep learning. Deep learning is a very important concept that is being used now to develop these AI models. So you can think of deep learning as similar to, say, a junior pathologist resident, right? So the way these models are built is that you would take a junior pathologist resident when they start learning pathology. The model is presented with thousands of images that are labeled. Then after that, like how you would test a resident, the model is tested. And when it makes a mistake, we actually have expert pathologists point out the mistakes and correct them, which is called fine-tuning of the model. So that's what we've done, and I'll talk to you a little bit more about how we built our deep learning models for pathology. And so basically, so this is the digital workflow that we just talked about. I mean, something that you're all very, very familiar with. Once you've processed the tissue slides, place them on glass slides, then the next step now in a digital workflow, as I mentioned earlier, is going to be digitizing these slides using a slide scanner. And then, and after this step, after step 3, is where curatives expertise really comes to play. So we've developed AI modules. So the one that you see here on screen is actually a prostate module that does grading as well as detection of tumor regions. So what the GIF basically shows you is the AI has annotated the tissue image. It has identified benign regions. The green areas was benign. It'll just show up now, yeah. So the green areas are benign. The light blue are grade 4, and the darker blue are grade 5. And once this analysis is complete, a detailed numerical report will be generated by the system, and then this will be provided to the pathologist for their review. So our solutions can be categorized into 3 buckets. We've created an image management system. Basically, what the image management system allows you to do is help you manage images, share images with your colleagues for second opinions. It'll also let you see the AI results, as you see there. We have a built-in viewer in the image management system. And it also creates a numerical report that I'll be doing a demo of shortly. And then in the center, what you see here is our AI modules. We've created some tumor-specific AI modules as well as some generic modules. And on the right, this is our pathologist analytics network. This is quite unique to Curative. We have about 400 plus pathologists in our network today across 22 different countries. We leverage this pathologist network to not only build our own AI modules, but also to provide ad hoc clinical services. So this is just zooming into our AI portfolio, which is very core to our company. We've been able to build some pretty high-performing AI modules. As you can see, I mean, yesterday, again, we discussed about AUC and how important it is to define a module's performance. So our specialized modules, we've built one for colon. The colon module basically identifies between high-grade and low-grade dysplasia. And the prostate module does detection as well as grading of tumor regions. And the lymph node module does micrometastasis detection and we've tested this on breast, colon, and gastric. And we have a module for MSI prediction for colon cancer, as well as an image analysis module for IHC Ki67 staining. So I'm just going to do a quick demo of our solution. I'm just going to pull it up. Just give me a second, please. All right. So our solution is a web-based solution. So just like signing into your Gmail account, you just open up your Chrome, give in your credentials, and it'll take you to this page. So this is our image management system. And in the home page of the image management system, you'll see the various cases that a pathologist has. We've basically tried to mimic a slide tray that a pathologist is used to seeing regularly. And here you see information about every case, the patient ID, patient name, case description. We've made the user interface as simple as possible. So you click on the blue button and then you can create a new case. This can be automated if we integrate it with your LIS. So it's made easier for you. So once you add some basic patient information, you just go next, and then you can upload slides here. So for the purpose of this demo, I want to show you a case that, sorry, just. Yeah, so here it is. So once we click on the case, we'll go into the various slides within that case. And here you see that this particular case has 11 pathology slides. And then there are some key functionalities within this page. You can analyze on a case level as well. And it will also provide an AI summary. And finally here, there's also information about the patient. I'll come to the AI summary in a bit. I'd like to show you some of our AI annotations first. So under the Pathology Slides tab, you see a preview of the slide with the slide label as well as information about the slide itself. And once you click on the preview, all right. So this is the image itself. There is a mini map here. You can navigate across the image. You can zoom in, zoom out using the image viewer. You can also create annotations and use this tool to measure areas. So what I'm going to do now is I'm going to run the AI analysis. Okay. So this particular AI module is a detection AI module, so it only detects detects tumor, so it doesn't grade. I'll show you the grading in another slide. So what this has done is now it has detected the various regions, and you can see that we are not using a probabilistic approach. A lot of our competitors use heat maps. But we are using, you can see that there's a very clear demarcation of the tumor areas. And there are certain regions that you can see here. These have been highlighted as orange. So these are ambiguous foci. These are regions that the AI does not know what to call it as. So it wants the pathologist to take a second look. Now, we can also generate a slide level summary. So this is basically a numerical representation of what you just saw in the slide. So this tells you exactly how much tissue area was there within this particular image, how much of it was benign versus malignant. In this, it says that all of it was benign in this particular slide. So let me show you a slide where it has a little bit more tumor in it. So in this slide, let me display the annotations again. Okay. Yeah. So here you see various colors. So green has been identified as benign. Yellow as grade 3. And then the cyan as grade 4. And you can just go through the various detections. So for example, if you click here, it will take you to the first, pattern 4 detection. And then you can move from one detection to another. Just similar to what you saw in the earlier slide, there is a numerical summary of this as well. So it'll tell you how much tissue area it's detected, how much of it is benign versus malignant, how much of it was identified as grade 3 versus 4. Right. And finally, before I end the demo, one thing that I want to show that we've gotten very positive feedback on from pathologists is this case level summary. So in this particular case, we analyzed, there were 11 slides, of which 5 of them had tumor. And then you can also see the tumor distribution here in the tissue. So it says that, there was, 77.3% stromal tissue versus glandular 158 millimeter square, and then within the glandular it tells you how much was tumor versus malignant. So obviously these are not calculations that any human can do. It's only something the machine can do. And then now this is an interesting feature where it's also So this will let you toggle. For example, if you just want to see just the tumor regions, you don't want to see the benign glands, you can kind of deselect this, and then you can see how much of it is pattern 3 versus 4, which slide has how much pattern 3 versus 4. And again, this is a case level summary of what you saw earlier in the slides. All right. So we wanted to talk a little bit about how we built our modules. So you saw the module in action. So and you saw that there was a very clear demarcation of tumor regions. And that's because we used a strongly supervised approach to build the module. A lot of our competitors use a weakly supervised approach, but we took the more tedious route to build this model because we wanted to make it more accurate and more robust. So basically what we did is we got data from various sources, various biobanks, and after that, we leveraged our PAN network. So with our 400 plus network of pathologists, these pathologists help annotate our entire data set. And after annotating it, they also went through several rounds of QC. So there were a couple of very senior pathologists overseeing the process to ensure the quality of the annotations. And after that, we went through a cycle of modeling and experimentation to pick out the best model. And then we did an internal clinical validation. And with our prostate module specifically, we've done multiple external validations. So we validated this with Rajiv Gandhi Cancer Institute. We've done a validation study with Cleveland Clinic in Abu Dhabi, and various other validations as well. So this has helped us build models of high accuracy, sensitivity, and specificity. You saw some of the sensitivity and specificity data earlier. And also a pretty robust model. So far from what we have seen, the model generalizes quite well. So for example, we tested the module in France, where they do saffron staining, which is not something the model was built on at all, and I believe this is quite unique to France. And the model actually performed pretty well even with that data. This is just a little bit more about the validation studies that we've done. This one on the right, we presented this at ECP a couple of years ago in Dublin. I'll just give a brief summary of what we did. We had about 10 pathologists review 150 WSIs from 150 different cases. And then they reported on these WSIs. And then there was a washout period of 2 weeks, so they forgot what they reported. And then we got them to see the AI result for the 150 WSIs and re-report on the same cases. What we were able to see is that there was an increase when it came to sensitivity as well as specificity. So there was when you look at the error reduction, when you keep what the doctor saw as the baseline, there was almost a 51% error reduction in terms of sensitivity and 100% reduction when it came to specificity. And in the deployments that we've done so far, I just want to highlight some of the common challenges that we've seen. In speaking with clients and doing these deployments, what we've seen is one of the questions that we get asked a lot is that a lot of hospitals. Okay, sorry, am I running out of time? Okay, oh, we're fine. Okay, thanks. So that a lot of hospitals do not prefer cloud deployments, and they would prefer to have the server in-house. And we've done this with Singapore General Hospital as well, where Singapore is heavily regulated. And so one thing that we've ensured is that our architecture is flexible and that we're able to support both on-prem as well as cloud deployments. And of course, our field is heavily regulated. So we have the Class C IVD HSA for our prostate module, and then we also have our certification for QMS, risk management, as well as all of the other InfoSec management certifications in place. Another issue that we see commonly is slide quality. So obviously when, you know what they say about all machine learning modules, garbage in, garbage out. So if it's a poor quality image, most times the AI module does not even work. So one strategy that we've been thinking about is building a QC tool so that it screens all of the images that comes through the tool, and if it's not matching a particular quality, we just reject it. And finally, last but not the least, most important is adoption. I mean, by the end of the day, an AI module is not worth anything if clinicians are not adopting it. So one thing that we've tried to do in the past is to try and get our users involved in all of our clinical validation studies so they build confidence on the product. And we've seen that once they're involved in the clinical validation studies, they see how the model is working, then there is more incentive to adopt the solution. I'll just go through this quickly. I think just a few things that we do differently from our competitors, because it's a question that we get asked a lot. It's like, there are so many AI companies, what are you guys doing differently? One thing is that we have an image management system as well as AI modules. From an accuracy standpoint, I just talked about how our model has been built based on a strongly supervised approach, which allows us to do a clear demarcation of tumor regions versus heat maps. And finally, we offer flexible architecture, so we're able to do cloud deployments as well as on-prem deployments. And in the case of India, this is especially important. We have developed our solutions here in Asia. So to some extent, we're able to offer our solutions in a more competitive price compared to many of our competitors. So what we've seen with our AI adoption so far is it does not have to be baptism by fire. You don't have to start, using all of the biopsies that you get don't have to get scanned, right? What we've seen is the transition happens bottom up. So for example, a lot of our clients just start using AI as a second read. So they select certain images that they want to get a second opinion of. And then slowly, as they build confidence in the product, the vision, yes, eventually is to ensure that all of the WSIs are scanned, and then the AI is run overnight, and then in the morning when the pathologist sees the results, all of it is, neatly pre-analyzed for him or her to review. Okay. So I think, oh, 3 buzzes. Okay, yeah. I think in summary, I mean, well, we have a few deployments. We've done deployments in India with core Diagnostics, Metropolis, Rajiv Gandhi Cancer Institute. We have clients in the US as well. Mayo Clinic we did a project with, and in other parts of the world as well. Now more in Asia. Yeah, I think I've run out of time anyway, but thank you all for listening.
Thank you so much, Shreya. Any questions, ma'am? Sir?
Thank you, Dr. Shreya. It was wonderful. I think yesterday, the highlight of the talk of yesterday was AI by Dr. Mameen, and today, I think on the second day also we have started. Now, one thing I just wanted to know is the basic prerequisite to get you the information is a slide scanner. And I think we briefly talked about it. I think, is that sort of in a quality of a slide scanner which sends you a slide? Is that an important sort of parameter? Or is it something, all the scanners are more or less same? Because I feel that's the very sensitive issue. If you don't have a good scanner, I think the material what you're going to get, the image is going to get, is not pretty good. What's your view on that?
So certain prerequisites exist. So we would need like a 40x magnification of the image in order for the AI to run. And it has to be one of the standard formats that we support. But to a large extent from what we have seen, as long as the slide is scanned properly, even with like very low throughput, even a single slide scanner versus say the most expensive Philips slide scanner in the market or Roche, we've seen the quality is somewhat, it still works on the AI and we don't see a huge difference. But we just have to ensure that we get that 40x magnification and a format that is compatible for us.
Thank you so much. We will quickly like to invite the co-chair. We have slight change in the session now. Makran Kochikar sir will be talking on non-muscle invasive bladder cancer management principles and recent advances. So please, I would like to request Dr. Rajul Shah to co-chair the session for the talk. And I will kindly request all of you to keep the question answer sessions for quick 2 to 3 questions maximum because we are running short of time. Yesterday it was a little delayed because of the extensive discussion. We can have the discussions later in between the breaks. Thank you so much.
Good morning, everyone. Let us talk about the management principles and recent advances in non-muscle invasive bladder cancer. Greetings from both the hospitals where I'm working for the last 28 years. The bladder cancer has gone into tremendous amount of evolution, I think right from doing TURBTs to the diagnosis, to a lot of new technologies what we're using in terms of diagnosis, treatment, and sort of even using a nanotechnology and the newer advances. That's going to be the basis of my talk. Many times we are asked to talk about the conflict of interest, and I think there is nothing conflict of interest, but I think all my talk is based on whatever work we have done sitting on NCCN panel, and also I'm sure you know this group called as International Bladder Cancer Consortium. It is a group we have been for the last so many years, and recently we had a meeting in Texas making a guidelines for intermediate risk non-muscle invasive bladder cancer. So let us talk about the management principles. I personally feel the battle of the bladder cancer is won or lost in its first assessment. What I mean by that, if you get the first assessment right, you are absolutely right on the track. If you get it wrong at the beginning, it's a long and protracted journey at times, and it's a point of no return. So it's extremely important we get our first assessment of a bladder cancer completely right. So let us start from the evaluation. When the patients come to you for evaluation, we also look at the risk factors, smoking, tobacco, comorbidities, because that has an influence on deciding what treatment we're going to offer to the patient. I think I make this point, urine cytology is a must, because if urine cytology gives an idea, patient has atypical cells, malignant cells, then your look towards sort of doing cystoscopy or management is entirely different. Biomarkers, I've done a lot of work. I did my original thesis in London on BART-BTA test and MBT2, but it's almost going out of practice. We are not using it in day-to-day practice now. Imaging-wise, I think when the patients come to us, we are happy with just a basic one good ultrasound, but CT-IVU is extremely important also not to miss the changes in the upper tracts, but also look at whether they have a concomitant disease in the upper tracts. Many times we use MR urography in renal insufficiency and pregnancy, and we talk about VIRADs or sort of MRI, like an MRI for the prostate, but I don't think we have reached a stage where we can use this to replace the pathologist to tell us whether there is a muscle invasion or not. I mean, you can predict it, but I don't think we have reached that stage. And PET scan at the initial workup for non-muscle invasive disease is not really important or required. Urologists planning the treatment, I think it's like a checklist, like a pilot. You have to have a checklist, and that's why you would not miss anything, what I was talking about, your first assessment. What we do is, I think we have lost the image there. Yeah, so basically, I think it's a standard TURBT. Standard TURBT is much more easier to do. You can plan your resection very well. And nowadays, there is a trend for doing en-bloc resection. But remember, though it's good for pathologists, what you really need is sort of a tumor which is less than 2.5 centimeter. Reason being, the diameter or the aperture of the resectoscope would admit only about 2.5 centimeters sort of piece to come in one go, but this is not sort of applicable for each and every patient. We do laser TURBTs also, and sometimes use a narrowband imaging for completion of TURBT. And this is how it should look like. Basically, you have a tumor there in the center. You have to resect it almost like 2 to 3 centimeters away from the tumor margin, so the pathologist gets a good specimen. You have to have a wide clearance. You need to do a deeper resection. At the end of the day, I think we need to send a separate muscle for the histopathologist. It's extremely important. It's no point telling the pathologist that I have seen a big specimen, you try and find out the muscle in the TURBT. There are many ways of skinning the cat. You can do a good set of TURBT or standard TURBT. The experience is must. Unfortunately, in many centers, I think this is given to sort of second-year resident, third-year resident, but this is not the case. I think this is the most difficult operation to perform. You can get bleeding, obturator jerks, perforations, and that results into giving a poor quality specimen to the pathologist, and then perhaps you would not be able to get a proper diagnosis. We talked about en-bloc resection. It should be sort of a lesion which is less than 2.5 to 3 centimeter. If you have a female patient, maybe you can take the whole specimen in one chunk, and it's always good for the pathologist to have that kind of situation. In principle, when we had done this bladder tumor resection, we instilled mitomycin C as a single instillation perioperatively within 6 to 8 hours of TURBT. It certainly reduces the risk of recurrence. But how do you judge that? We haven't got the histopathology as yet. So how do we judge that? Basically, it's just looking at the endoscopic appearance. If I feel the tumor is solid, people have a lot of necrotic areas, it's not going to be non-muscle invasive. So I'm not going to give this patient as something like perioperative mitomycin C. If I feel the tumor is papillary, people is fronded, little bit of calcification, then certainly I'm thinking this patient has perhaps a low-grade disease. Sometimes you keep on treating these patients, which has very low-grade disease, TN low-grade. I don't think it's required to do perioperative mitomycin C, and if the patient has perforation or bleeding, certainly these are the candidates not for intravesical mitomycin C. Now, this is what we are doing is basically a conventional cystoscopy. In terms of advances, we have now moved to something like a more better sort of visualization for especially flat lesions, carcinoma in situ. Sometimes you don't know whether they're inflammatory or neoplastic. So what we have come out with enhanced cystoscopy. So these are the new techniques looking at correcting the deficiency in the white light cystoscopy. And few of them are listed here. One is PDD, narrowband imaging. I'm not going to cover each and everything, but I'm going to tell you the principles. PDD is a substance which is instilled into the bladder, and then we use a different sort of electron microscope, it's a different sort of screening system, and then you would find out if you have a lesion here on the left-hand side, you may not see a lesion there just above the ureteric opening, and if you use PDD, you may pick up carcinoma in situ. So this is what it looks like. Now, another one, it's like you're trying to find out sort of, a jackal or wolf into the ship. So problem is PDD, sometimes you can have false positive inflammation, you may do unnecessary biopsies. It's approved in USA, but it's not approved in India as such. This brings us to something, a new technology, which is called as a narrowband imaging. Done very simply in outpatient basis with a flexible cystoscope. It can run sort of under local anesthesia. And what it actually helps you is telling you this is a typical lesion what you see in the bladder. That's okay, that's a white light cystoscopy. Much, much better visualization with narrowband imaging. It has a click on the machine. You just put a click and you'll be able to see this much better. Now this lesion with a white light cystoscopy looks like a more of a diffuse lesion, and you're going to take a cold cup biopsy. That may not be something sufficient for the pathologist. And you look at the better look with NBI, you may be able to see the extent of the disease. These kind of flat lesions, carcinoma in situ, you can resect it and give it to the pathologist for that. Somebody would say this is a urethroscopy for a man who had a TCC of the upper tract. Yes, you can see this lesion. Why do you need narrowband imaging? And you see a closer look here, the entire urethral carcinoma in situ, which is just picked up on a narrowband imaging. So this new enhanced technology is definitely going to help us. We also use this NBI for important thing. Once we resect the bladder tumor, we do run the NBI to see whether we have not missed any lesion. I have done a completion TURBT. Now you guys, the pathologists, come into the picture and play a very, very important and a key role here. Majority of the times, what I've seen inside in the bladder usually correlates with what you have sort of reported. Grade can be sometimes issue, and surgery as well as biopsy reporting done at a low volume center can always be a challenging. Now let us look from the pathologist perspective. Many times we ask for a pathologist review, and the pathologist who has already reported gets really offended. So my one-line statement to them when I send a mail, we don't disregard your report or surgery to the surgeon who has sent a patient. I say we trust our pathologist for this expertise. I think that was one of the British way of sort of saying, and nobody gets offended. Now this is how typically the mistakes actually take place. See, this is a cross-section of a bladder. And this is how the pathologist is walking into the layers of the muscle, and he tells us that it's in lamina propria or muscularis propria, and there is discrepancy on that. Other thing is when you report it as PTA or T1, is it really PTA or T1? I think this is what we get the confusion at. Also, I think this issue of grade 1, grade 2, grade 3 has all been sorted out over the period of time, and I think now we don't get much discrepancy, and we put it as something low grade and a high grade. I'm sure this is information all you know. There is so much of a discrepancy in intra-obs or variability. But at least we have that clarification which grade the patient disease has. I don't think we can plan further treatment, and we have to accept, despite being experienced, I think pathologists, you still get 30 to 35% intra-obs or variability. People talked about doing en-bloc resection just to give you sort of 100% sort of accuracy, but I don't think that's possible in patients who have tumor which is more than 2.5 centimeter in size. The another question comes to our mind is when you report as PTA high grade, a lot of people say, does it exist? Yes, it does. And I think we have to tailor the treatment accordingly. And it has serious implications. Now, also important, like the pathologist, I think the surgeon is also important. If the surgeon does a good TURBT, his quality of TURBT is good, I think then perhaps you can take this report as a sort of sacrosanct and then further plan treatment. But if you have any problems, you feel that it has not been done adequately, is incompletely, the quality is sort of questionable, or even the report is questionable, you have to do a restage TURBT. And this is, I'm sure, as a pathologist, you are getting more and more specimens for restage TURBT. And you look at the residual cancer, what you see in the range of 30 to 40%. So this is not disrespect to the surgeon, like a pathologist who has reported, but I think the surgeon has to understand you have to go back in again and re-resect within the 4 to 6 weeks' time. Now, if you don't see a tumor on restage TURBT, the patient goes for intravesical BCG. If the patient has a residual disease or no muscle invasion, he gets intravesical BCG. But if he has a muscle invasion, adverse characteristics, then perhaps the patient goes for radical cystectomy. And that's the importance of doing restaged TURBT. Now, is it become a norm or are we overdoing it? And I think sometimes you overdo it when you know that there is muscle already present in the previous resection, you know the experience of the pathologist and surgeon, and I think it's unnecessarily you can add cost, complication, confusion in a case of cancer. So all three C's are extremely important when you talk about restaging of the TURBT. The bigger concern is this information what you are given to me, is it enough to plan a further treatment? And I look at this report as something we have to read beyond that. So we have to measure the measurable, what you're given to me, and also make a measurable which is not. That's what the Galileo said. And I think what we are looking at more information, apart from pathological report, even if AI comes into the picture, you need to know it's a single, multiple, solid, papillary, LVI in sort of a presence, variant histology, cytology positive, and substaging sometimes. And if we have that information, we can plan the further treatment. Not all T1, G3 or high grade behave in the same fashion. So if you have any of these ATCs, I'm inclined to treat these patients not with intravesical therapy, but I would like to sort of treat this patient with something like more aggressive treatment like radical cystectomy. I'm sure as a pathologist, you keep on reporting as TA, T1B, T1C, and I think there is a sense in that. So if you tell me that if it is encroaching towards a superficial muscle, then perhaps these patients need an aggressive treatment on early cystectomy. What about this tangential spread concept? And this is what I have made it many, many times presenting in the conference. We feel the tumor actually sort of spreads just like this vertical sort of spread. But it's not necessarily the case. Sometimes it has a tangential spread. So when you do restage TURBT, you may find a muscle into this, and this is what I personally feel I think is a point of concern. Risk stratification, usually there are so many different groups which tell you different risk stratification. So this is classical AUA, low risk, intermediate risk, and high risk. And EUA has come out to very, very low risk and a very, very high risk. We as an IBCG group also have come out with a different classification. What it means is if you have a very low risk disease, as a management principle, we do not give them intravesical therapy. You have TA low grade, they don't require any treatment. If you have a high grade adverse tumor characteristic, they need intravesical BCG, no doubt about it. What about intermediate risk group? Recurrent, low grade, what do we do about it? And I don't think there is enough consensus. And we just met a few months ago in Houston. And you see who's who in urological oncology and bladder cancer was there, and we have formed guidelines which are going to get published very soon. So if you have a high risk, you use intravesical BCG. We give induction course weekly for 6 weeks and a maintenance BCG at least for a year, not for 2 to 3 years. We also resort to the fact that, yes, we don't need a full dose of BCG. You can give a low dose BCG to prevent the toxicity of these patients in a bladder cancer. Sometimes you get patients who do not respond, fail to the BCG, and there are various sort of nomenclatures for that. BCG unresponsive, failure, toxicity, various definitions. But what the new definition, what we are talking about, a group which has not been addressed as, is called as patients who are BCG exposed. And this is the information, or this is a sort of a nomenclature, was sort of popularized by Peter Black from Canada. And this was a meeting we had, and this is now a concept that it's not we're talking about a group which has BCG toxicity, but we're talking about something BCG exposed, meaning that they have been exposed to BCG, but they still require a further treatment. Now in US, we're talking about BCG unavailability. In India, that's not an issue. So what are the options what we have? So a lot of new options now. The option is something like gemcitabine and cisplatin intravesical therapy, more popular. Now we have something called as a TAR-200. I'll explain you what it is. You can use interferon, you can use interleukin, you can give systemic therapy, something like an pembro, and that's a long journey we have gone through for the last 8 to 10 years' time. So this is a very new, exciting field. You can give, pembro, which is used for systemic chemotherapy for a high-aggressive bladder cancer which is not responding to BCG or BCG unavailable, or you can use these kind of different drugs intravesically. What are the results like? So if you look at the keynote trial, you would see the results of Keytruda is something like 41%. And if you have other drugs which are intravesically, you can have a fantastic result equivalent to BCG as such. And this is a new device which is called as TAR-200. So what you do is you have gemcitabine, which is like a double gestant or something like that. You put it into the bladder. And you change it every 6 weeks. The principle is this gemcitabine would be sitting in the bladder for next 6 weeks' time. You don't have to bring the patients to the hospital, take the catheter out and put it again in toxicity. And every 6 weeks you keep on changing. And I think this is going to be a big revolution in the treatment of bladder cancer for BCG toxicity for the patients who do not afford to have a BCG. And what are the results like? Look at TAR-200, just as a monotherapy, you get almost whooping 83 to 90% of a response. Or if you give it a combination of TAR-200 and monoclonal antibodies, it is not bad either. As you grow older, I think you keep on looking backwards and say, are we doing right things? So there are people now saying, why do sort of resections, TURBTs for a low-grade spondyloid kind of lesions in the bladder? So we're talking about active surveillance. I'm sure you know this guy, Dr. Professor Mark Soloway, a good friend of mine, my mentor from Miami. And he's now talking about de-intensification of treatment for PTA, low-grade. So what it means is, you have a small lesion in the bladder, you take a cold cup biopsy and fulgurate it in office urology. You don't do resection. Each resection is costly, expensive, a lot of side effects and toxicity. So this is what you get wiser as you get older and older. What about the molecular markers and ctDNAs and subtypes? I don't think it has come to the guidelines as such, especially for a non-muscle invasive bladder cancer. Friends, to the end of my talk, I think you asked me to talk about the management principles and what the future looks like. And I think the future looks like very, very exciting with the new things which I've said, but it is all on the foundation of a lot of hard work with the people like Donald Lamb, who worked in sort of in a BCG, Harry Herr, and this is recently we met over a dinner in Houston. You know, mitomycin C was popularized by Mark Soloway and Donald Lamb for the BCG, and we work in a group. Dr. Badri Koneti is here for International Bladder Cancer Group. You know, Richard Hartmann from Germany, who popularized the new bladders. It was wonderful to get associated with him, and so has Professor Studer, who's no more. Dr. Soloway recently said, this is his car, and the label is Uro-Onco. And he said, we started it like this, and take it further, young guys. Ladies and gentlemen, that is what I have to say for management principles and future of bladder cancer.
Wonderful talk early in the morning. Any expert comments? Anything?
Dr. Kochikar, excellent summary and I think very well comprehensive information. I think a few things from pathologist perspective that I would like to say is that we often have a flat lesions along with the papillary lesions, and it may not be easy to differentiate whether it is a flat carcinoma in situ or a shoulder of a tumor. So that is one thing. And as you know that submucosa, muscularis mucosa is often not present, or it may be fragmented or just may not be appreciable. So sub-staging of PT1, even though has been consistently shown to have an importance, I think there is no standard method that I think as a pathologist, I think we really apply. So I think there is some degree of difficulty in that as well. And I think in my mind also often combining the non-invasive and T1 as one group of non-muscle invasive bladder cancer, do you think that does that make better sense, or I think it kind of too much dilution of the group?
I think this nomenclature we have traveled a long way, because previously we were talking about superficial bladder cancer versus a muscle invasive bladder cancer, superficial or deep. So when you use superficial, I think people used to take it very lightly. It's a superficial bladder cancer. And still today in 2024, 25, people talk about superficial bladder cancer. So it did not address the issue of flat lesions, carcinoma in situ, which are much more aggressive and have a disease, has a different prognosis and a treatment. Like T1 high grade and carcinoma in situ, if they're clubbed together in superficial, then I think that was a misunderstanding amongst the clinicians and the people like. So we came out with sort of a new definition of non-muscle invasive and a muscle invasive, just to make a distinction. I agree what you're trying to say. So that's why the risk stratification comes in. So if you have low risk, you know you're not going to do anything.
Right.
If you have a high risk, they're going to need intravesical therapy. The question remains of intermediate risk. And I think 2025 is still struggling about what's the best treatment for intermediate risk bladder cancer. And I personally feel we are overdoing it. And guys like Soloway and all those guys are now pushing it. In fact, if you read a bladder cancer case report journal, Dr. Soloway, what he did was he identified 25 people across the globe, and he asked the opinion about what you do for intermediate low-grade PTA lesions and asked their summary. And actually the paper has, this is an out-of-the-box paper, so he gave the case and he asked 25 people to advise what to do, and all 25 answers were different. So you go to the Bladder Cancer Journal just last month and it is all there.
Right. And I think one more question that may be relevant for pathologists. We often have a situation where tumor looks overall low grade, but very focal areas are kind of high grade. So I think we often use like high grade tumor within the background of low grade or like focal high grade. So how do you kind of handle this type of situation?
Excellent question. I believe I'm a pathologist, so I don't question what he has reported. So if he says areas of high grade, it means areas of high grade. So it rings a bell, alarming bell. I'm not going to be very aggressive in treating this patient. Perhaps I would treat him with intravesical therapy with less intensification, but I'm going to be very vigilant on him to develop. He develops any further recurrences or muscle invasion. But that's important. I think if you say high grade within the areas of low grade, I think it's important information for me. And if these patients have urine cytology positive, and that's the point I'm making it, if somebody who has a low grade reported on a histopathology, but urine cytology positive, it means that patient has an aggressive disease where missed something somewhere.
Yeah. Thank you very much.
Thank you so much, sir. Thank you so much for the wonderful first session of the day. I would like to invite upon Dr. Sambit Mahathi now, and I would like the chairs to be there itself. And felicitations.
Am I audible to all of you? Good morning. Good morning, everyone. So am I audible? Yeah. So as Makaran said, his talks are very precise and to the point and discusses everything. So let me, can't hear? Okay. So I think this is better. Yeah. So as we all know about Makaran as an excellent researcher, urologist, academician, but he has a lot of good traits and excellent traits in addition to that, which basically sugarcoats the entire his journey in the field of urology. So as a person, he is very friendly, helpful, extremely happy when the mentees do well, which are the biggest quality within him. So we would like to felicitate his lifetime, though he has many more years and many more decades to go in the field of urology and science. In our conference, we're lucky to have you. May I call upon Dr. Mehul Amin and Dr. Seema Kaushal to felicitate Makaran's lifetime journey in urology and uro-oncology, please, as an individual and a researcher. Makaran, please. And may I
a huge
also
round of applause,
request the
please.
chairperson to come in the middle. And Rajal and Madam, please. Say a few words for the young generation pathologists and urologists. Sir, photograph. You're too quick. Now I would request you. Yes. Now I would request Dr. Kochikar to say a few words. We did the ceremony here because he has the flight to catch. Otherwise, we would have done it in the evening in the main felicitation ceremony. Makran, please.
Friends, thank you very much. I think it's heart-touching. Thank you, Sambit, for taking the special efforts not only to invite me, but also to accommodate in the morning. And then I think Phyllis P is a wonderful job at not being here, and I could sort of speak and I could go back. Thank you very much. Thank you, International Association of Integrated Oncology, GUPS, KIMS, AIMS, for such a wonderful honor. It's a privilege and really happy that I'm receiving this prestigious Lifetime Achievement Award, and especially more happy because one of my very close associated, Professor Amin, and all other colleagues, they're here, and I adore Mehul very much, and I think it's a strong association for the last 2 decades. It was not very easy to start the journey. I came back in 1998, from UK with all sort of dreams to establish urological oncology in India as such. Before I came, there were departments who were doing GU, GY, gynec and urology together, and I was not very keen just to get gynecology on the board. So perhaps we were the first one in the country in 1998, that to a 2-tier city or place called as Miraj, to start urological oncology. Mind you, when you want to start a department, you need good pathologist, extremely important, good radiologist, good anesthetist, intensivist, and a postoperative care. And I was very lucky to have a good team of pathologists, Dr. Rakhi, Dr. Sachin, the Department of Histopathology, excellent anesthetists and radiologists to take me through this long journey. So I'm extremely proud of association with all my pathologists, all the radiologists, and the team what we have. 2024 has been a year of awards for me. I had a Avishkar Award from USI in January last year. Then Inspiring Urologist of India by Times Now and Economic Times. And the global organization, SIU, of 197 countries gave me the SIU Distinguished Career Award. So this has been something really fruitful year. And come January 2025, I think Sambit just called me and we're going to get this award. I think Dr. Kaushal said I need to have some poem on this occasion because few of the talks in pathology in Nadiyad, I had a poem. So this is for you, pathologists, because you have a pivotal force in organizing this conference. Urologists and pathologists, we both look through a tiny hole. You tell me this is pink and that is blue, giving me and guiding me an important clue. But let us not focus only on the tiny hole, stick out our neck, see and treat our patients as a whole. Integrated should be, we remain all along, sure will our patients bless us with their heart and soul. Thank you once again. Thank you for the long association.
Thank you so much, sir. Thank you so much. It was a wonderful talk. And the poetry done by you was more wonderful even. Quickly moving on to next session. The next session for the day is Hot Topics in Urological Pathology by 3 international eminent speakers. I would first like to invite our chairs for the session, Dr. Prafulla Kumar Das, Dr. Sushma Patra, Dr. Seema Kaushal, Dr. Sonal Sharma, and Dr. Meenakshi Swain. Our first speaker for the day is Dr. Rajul B. Shah for the next session. Dr. Rajul Shah will be talking on large gland lesions of the prostate. While we are all enthusiastic about the sessions, I would request again the audience to keep the question-answer sessions a little limited to 2 to 3 minutes so that we can finish in time. Thank you so much. So.
Sorry?
The rest of the chair will be joining.
Okay. I can start, right?
Yes.
Yeah. Good morning, everybody. So, a common architectural pattern encountered during evaluation of prostate biopsies is small gland or small acinar pattern, as seen in this example of grade group 1 prostate cancer. But not infrequently, you may encounter predominantly or an exclusive large gland pattern, which will be the focus of my presentation. I will specifically focus on the atypical spectrum. So large glandular lesions of the prostate are characterized by three features. Prostate gland proliferation is of the same size or larger than the benign glands. Glands may exhibit tufted, micropapillary, flat, papillary, or even a cribriform architecture, but if you have an exclusive cribriform architecture, it would be considered a cribriform architecture from point of further workup, and it may represent an intraductal or invasive process. So the histological spectrum of these lesions is pretty broad. It includes pre-malignant, suspicious, and malignant, and often biologically aggressive entities, which are listed here. And some of these lesions can be quite difficult in terms of diagnosis and further workup and regarding grading decisions, which I will cover. When you encounter these lesions, central zone glands and clear cell cribriform hyperplasia are important benign mimics that you must keep in differential diagnosis and exclude them from this particular spectrum. So each entity has a unique clinical significance and management implications, particularly differentiation of high-grade pain from these other remaining entities is especially critical. So I will first talk about the high-grade pain, which is architecturally defined as a normal glands, but lined by cytologically atypical secretory cells, and basal cells are at least focally preserved. It has a higher incidence in blacks compared to Caucasians, and it can only be diagnosed by histology. So it does not elevate PSA, and it does not have any specific imaging characteristics. That is an important point to keep in mind. The best histological discriminator for the diagnosis of high-grade pain is presence of prominent nucleoli in secretory cells visible at 20x magnification, and that kind of in terms of differential diagnosis would be very important. But keep in mind that nucleoli is subjected to the tissue fixation as well as lab processing. So each lab has its own particular kind of characteristics that they have to keep that in mind. Rarely you can have mitosis and hyperchromasia as one of the features that you may use. Due to poor inter-observer reproducibility and lack of cancer association in subsequent biopsy, the diagnosis of low-grade pain should not be utilized in reporting, and the 5th edition of WHO does not recommend the use of this term anymore. So there is a movement now to even remove the high grade and just we call significant lesions as a pain. So high-grade pain has three major architecture: tufting, micropapillary, and flat. But what you may diagnose as a cribriform high-grade pain, now studies have shown that you cannot exclude an underlying intraductal carcinoma, so it is a clinically significant lesion, and I don't use cribriform high-grade pain diagnosis in my any reports. So when I encounter this type of loose cribriform proliferation, which appears kind of worse than high-grade pain, but does not reach the full threshold to classify as an intraductal carcinoma, I consider them as atypical intraductal proliferation, and I will talk more about that later on. Some of the other minor architectural variations include inverted high-grade pain, where the atypical cells appear to be away from the luminal aspect, and then foamy high-grade pain. So high-grade pain has two importance. Within the short term, within 12 months, it can be considered as a marker of a concomitant but missed cancer in the initial biopsy, and long term, it is a precursor lesion to prostate cancer. In contemporary biopsy, as shown in this data, particularly when you have 8 or more cores in your biopsy sampling method, the risk of missed cancer with high-grade pain diagnosis is no more significantly different than the benign.
So high-grade pin diagnosed on extended biopsy is not associated with an increased risk of missed cancer, and patient does not need repeat biopsy within 1 year of the diagnosis. But here are some of the situations when you have multifocal high-grade pin defined as 2 or more course involvement, when you have pin with adjacent small atypical glandular proliferation, and some studies, including ours, have shown that ERG overexpression, which is a very specific marker to prostate cancer, when expressed in high-grade pin, can indicate there is an unsampled ERG-positive prostate cancer. In some of the recent guidelines, high-grade pin is pretty much now followed up with PSA and digital rectal examination, but in certain situations, patient may be offered some liquid biopsy type of biomarker type of test to improve the specificity of the screening, and may also multiparametric MRI may also be offered. And if there is a lesion in MRI, patient would need a repeat biopsy, otherwise these patients can be followed up. So in summary, the predictive value of high-grade pin as a marker of missed cancer has declined significantly in recent years, and because of that, we must be conservative and err on the conservative side, and you still should report the number of courses involved by high-grade pin. So for my remaining kind of topics that I want to discuss, I will show you some case. So this is a 56-year-old male presenting with rising PSA and doubling PSA time. Pre-biopsy PSA was 17.79 with Pirates 5 lesion, and he also had a lung, liver, and bone lesion. So he underwent lesional biopsy, which is shown here. And as you can see here, there is a complex papillary and cribriform proliferation. Clearly, cytologically, quite high-grade looking process. And it appears that it is kind of growing within a duct-like space. So with this morphology, I think clearly these are some of the important differential diagnoses that you would consider, and particularly differentiating it from urothelial carcinoma and confirming a prostatic nature is particularly of importance. So I did some of these markers, NKX 3.1, GATA3, and PIN4 stain. Tumor is positive for NKX 3.1, negative for GATA3, and PIN4 was pretty much lack of basal cell staining with overexpression of AMA-CR. So another important thing that you observe here is that these nuclei have a little stretched out quality. These are elongated, pseudo-stratified columnar type of epithelial appearance. Everybody agree with that? So I think that is very important to appreciate, and I think that particular feature, along with the prostatic confirmed primary nature of the tumor, this is a ductal adenocarcinoma, which is a distinct subtype of prostate adenocarcinoma. It accounts for less than 1% in pure form, but about 5% in mixed and ductal and acinar form, may occur centrally or peripherally. And typically it is considered an advanced aggressive disease with a higher stage presentation. It is also common to see more visceral type of metastasis rather than bone metastasis. And it is typically graded as a 4 or 5 when solid component or necrosis is present. So these are some of the morphological spectrum of ductal adenocarcinoma. Most common ones are cribriform and papillary architecture. And sometimes you may have solid architecture and pin-like architecture, which I would like to show you in a case. But the central theme for this morphological spectrum is you have glands which are lined by tall columnar cells displaying elongated atypical nuclei and nuclear pseudostratification. So very important characteristic to pay attention. I think otherwise you may end up calling a lot of acinar adenocarcinoma as ductal adenocarcinoma if you are not very careful regarding this particular feature. Here is a nice kind of papillary and cribriform ductal adenocarcinoma with beautiful nuclear stratification and high-grade elongated nuclei. You can see that in a higher insert. Ductal adenocarcinoma commonly grow within a duct-like space, so it is not uncommon to see presence of some basal cell staining, and that should not change your diagnosis. And that brings up an important point that ductal adenocarcinoma can have an intraductal component, but ductal adenocarcinoma and intraductal carcinoma are not the same thing. Ductal adenocarcinoma is a type of prostate adenocarcinoma, refers to a morphological or cytological feature, while intraductal is basically a growth pattern of adenocarcinoma, can be acinar type or can be ductal and refers to a location. So recently we revisited this particular entity and we found very interesting observation which I mentioned yesterday. But based on the location of the ductal adenocarcinoma, there can be some important heterogeneity within this tumor. So we don't see this as a uniform tumor, and the one which involves both central as well as the peripheral prostate are particularly one that we think they are the prototypical aggressive ductal adenocarcinoma, typically seen as a pure phenomenon. They have more visceral metastasis, low PSA and high volume disease, but they are also enriched in DNA repair gene defects and P13K pathway alterations. So this is an important one to appreciate and recognize. In comparison, just ductal adenocarcinoma located on the peripheral prostate is often associated with acinar adenocarcinoma, so they are more mixed type. And they are enriched in FOXA1 alteration, but not in DNA repair gene defects. And in our observation, they appear to be clonally related. So they could be potentially a form of a transformation from acinar adenocarcinoma. And third group that Dr. Ming Zhao yesterday, I think, described very well yesterday, that there can be a small group of ductal adenocarcinoma which can be located only within the urethra. So that is an important one to also identify and separate it, because those, most of them on subsequent radical prostatectomy do not show any evidence of ductal adenocarcinoma. So they have excellent outcomes, and it likely represents an in situ form of the disease. The next case is a 60-year-old man presented with rising PSA, pyrites for lesion. So here is the biopsy, about 4 millimeter proliferation of this predominantly large gland that you see in the center. You also see that in the periphery there is a little bit of small glandular component. And a large gland, I think, clearly has a simple architecture. What I mean by simple is that they do not have papillary or cribriforming morphology. Here you have more tufting and little bit of micropapillary type morphology. Nuclei are clearly high grade, but they have a more rounder acinar appearance. You don't see that ductal type of nuclear features that I shown you before. And the nearby small glandular proliferation also appears to be atypical. So with that, I think these are all possible entities that you may consider, particularly high-grade peen with adjacent atypical glands and some of these other entities. So what is, I think, an important thing to appreciate here, that before you may jump calling this a peen, high-grade peen or peen atyp, is that there is too much glandular crowding, and there is also conventional acinar differentiation at the periphery. So in this type of situation, I always like to do peen-4 stain to make sure that I don't miss this particular entity. And as you can see here, that pretty much majority of this large and small gland component lacks basal cells, and it has a clearly infiltrative process that you can appreciate with beautiful internal control. So peen-like prostate adenocarcinoma is characterized by 3 features: proliferation of simple, importantly non-cribriform, non-papillary large glands with flat, tufted or micropapillary architecture, stratified malignant epithelium, and lack of basal cells. And our case that I showed you has pretty much all of these characteristics. So peen-like prostate adenocarcinoma is a rare subtype of acinar adenocarcinoma resembling high-grade peen. Its incidence is about 1% in biopsies. It's often mixed with, typically not seen as a pure proliferation. And so one study has shown that there is an activating mutations in the RAF and RAS pathway. Now this particular entity was first described by Dr. Hamid and Humphrey, and they had 8 or 9 cases Some of them were pure pin-like and some were mixed acinar and pin-like. But importantly, they observed two morphological spectrum, one which is non-columnar cells, the case that I showed you. What I mean by non-columnar is that the nuclear features are more acinar adenocarcinoma-like, but a small subset of their cases had a columnar cells with elongated nuclei that is more typically seen in a ductal adenocarcinoma type of epithelium. So here is an example of pin-like adenocarcinoma showing more standard acinar features, conventional acinar features. And here is the one which shows this simple, relatively simple gland proliferation, no cribriforming or papillary architecture, and glands are lined by more columnar, elongated ductal type of epithelial features. So this particular entity, then later on, Dr. Jonathan Epstein and Tavora, I think, coined the term high-grade pin-like ductal adenocarcinoma of the prostate, and they reported the biological behavior similar to Gleason score 3+3=6. In comparison, we know that when you call traditional ductal adenocarcinoma, it is 4+4=8 or higher. So I think very big kind of potential prognostic difference. But a word of caution that I would recommend when you encounter this in a needle biopsy, particularly when you see this type of ductal epithelial features. So here is one case from radical prostatectomy. And as you can see here that you have beautiful ductal epithelial features. Most of the glands appear simple, non-complex, non-cribriforming or non-papillary, but then you start seeing, I think, in some glands, you have more complexity, which is in some areas you see clearly more papillary architecture with fibrovascular cores. So I think in a needle biopsy, when you encounter ductal epithelial features, in my opinion, you cannot exclude an underlying ductal adenocarcinoma, as ductal adenocarcinoma can focally exhibit pin-like features. So I tend to be very conservative. I like to make this diagnosis when I see more epithelial acinar type of features. So limited data show that pin-like adenocarcinoma, both with acinar and ductal epithelial features, has a behavior similar to pattern 3 acinar adenocarcinoma. But in WHO 5th edition, the pin-like ductal adenocarcinoma word is replaced with pin-like adenocarcinoma, as ductal adenocarcinoma connotes a more aggressive behavior, but no clarifications have been provided regarding the two cytological spectra of pin-like adenocarcinoma. So I think, again, a word of caution, as I mentioned, that when you encounter in needle biopsy the pin-like with ductal epithelial features, be careful, because I don't believe that you can truly rule out underlying ductal adenocarcinoma. The next case is a 78-year-old man presented with a rising PSA. His latest PSA is 64.2, prior inconclusive biopsy, Pirates 5 lesion, and also has an indeterminate left iliac bone lesion. So I think this is a very interesting and fascinating case. You see this spectrum of epithelial proliferation, and I think one thing you clearly see that there is no obvious invasive cancer, so most of this proliferation appears to be limited within these ducts. Some of the ducts are clearly very atypical cytologically, and then the proliferation ranges from kind of loose cribriform to little bit papillary, and in some areas which you can qualify as perhaps more dense cribriform architecture. And in areas like this, you clearly see that the cytological atypia is very significant. There is a marked cytological atypia. So I think one more view of that. So I think with this, I think these are some of the differential that you may consider, and I hope that none of you would consider this as a high-grade pin, right? I mean, clearly it is beyond high-grade pin. And I think we did not see any obvious invasive cancer. So in this type of situation, it is very important that you do basal cell staining to confirm the intraductal nature of the proliferation. So the middle two, atypical intraductal proliferation, suspicious for intraductal carcinoma and intraductal carcinoma, both could be logical choices in this particular case. Here is the pin4 stain, and as you can see here that all this ductal has a nice layer of basal cells, so there is no invasive cancer that was observed. Another thing you saw that I think PSA is very high and Pirate score is 5. So I think this patient with this diagnosis underwent a definitive treatment of androgen deprivation therapy as well as radiation therapy. So we don't have a follow-up radical prostatectomy, but I think they clearly, without undergoing any repeat biopsy, offered the patient a definitive treatment. So intraductal carcinoma of the prostate has two histological hallmarks: expansile proliferation of cancer cells in cribriform or solid architecture, and proliferation is seen within the native prostate glands. So basal cell layer is at least partially preserved. The proliferation is classically more dense in nature, and the dense cribriform is defined as a cellular mass with more cells than the luminal space. So cellular mass typically more than 50% of the luminal space. Studies have also shown that intraductal carcinoma can be very strongly correlated with the comedonecrosis. It can also infrequently present with solid architecture, and for residence purpose, when you have only solid architecture, make sure you rule out urothelial carcinoma from your differential diagnosis. And rarely you may have markedly atypical nuclei, which has also been referred to as a 6 times larger than the adjacent benign nuclei or more pleomorphic type. Again, that is a more arbitrary cutoff. So there are many different diagnostic criteria that have been proposed for intraductal carcinoma. The one that is proposed by Guo and Epstein has been relatively widely utilized. They developed this criteria on cases where there was no obvious invasive cancer. So their idea was that patient can undergo a more definitive treatment when you see this type of morphological features. So when you see solid or dense cribriform, you can make a confident diagnosis. Typically, these are going to be expansile type of proliferation. But rarely you can have a loose cribriform or micropapillary with no with comedonecrosis or marked nuclear atypia. That could be another criteria that can be utilized to make the diagnosis of intraductal carcinoma. And these criteria are relatively considered major criteria, means they are very specific but not very sensitive. So if you use this criteria alone, there are a good number of cases that you could miss diagnosis of intraductal carcinoma. But again, they were developed to have patients that can undergo definitive treatment. So when you have no cancer in the biopsy, you need to use this more stringent criteria. There are certain minor features that in my experience can be very helpful. One of them is that frequently you have more than 6 glands or multiple glands involvement. This kind of right angle branching is a very important feature, suggesting more intraductal rather than an invasive cribriform process. 2-cell population with more outer pleomorphic cells and inner smaller cells is a very useful feature when present. Rarely these inner cells may look like small cell carcinoma, but it has nothing to do with the small cell neuroendocrine carcinoma. So keep that in mind, that rarely you may have this kind of neuroendocrine looking morphology, and then partial involvement of the glands is also very useful feature. So now there is clearly overwhelming evidence that intraductal carcinoma is associated with adverse findings both in the biopsy setting as well as in radical prostatectomy setting. So it has management implications. Patients with this diagnosis are typically not eligible for active surveillance. NCCN recommends germline testing for DNA repair genes that were discussed yesterday. So isolated case that like I showed you, if you make that diagnosis, then many urologists may consider patient for a definitive treatment. So keep that in mind. So infrequently you encounter this kind of borderline proliferations, which is definitely appears to be worse than high-grade PIN, but not fulfilling the diagnostic criteria of intraductal carcinoma. These glands don't have a dense architecture. They don't have any comedonecrosis or marked nuclear atypia, and basal cells are intact surrounding them. So this has been referred to as an atypical intraductal proliferation, which is worse than high-grade PIN, but short of diagnostic criteria of IDCP. And these are some of the other terms that have been proposed in the, yesterday I think it was mentioned that both society are going to have a consensus conference on this issue. So we are going to tackle many of these type of challenging issues. So we have shown that molecularly both atypical intraductal proliferation and intraductal carcinoma have identical features. There is a concomitant and P10 loss and ERG overexpression in AIP, IDCP, and invasive prostate adenocarcinoma when they are associated together. And here is a nice case example where you can see that IDCP, AIP, and invasive cancer, they show similarly ERG overexpression and P10 loss. So that is one very clear evidence. And then also we looked at the outcome of this type of in needle biopsies, and we found that this is often a marker of unsampled intraductal carcinoma. When we had AIP alone in the biopsy, or when these patients were potentially eligible for active surveillance, mean either grade group 1 or grade group 2 without showing any cribriform architecture, this patient on subsequent radical prostatectomy had adverse outcomes, and many of them had a full-fledged intraductal carcinoma. So AIP is a marker of unsampled intraductal carcinoma and other adverse pathological features, and therefore the diagnosis of cribriform high-grade PIN in a biopsy setting is not recommended, as you cannot exclude intraductal carcinoma. When you see this type of morphology, report as AIP suspicious for IDCP, but keep high threshold. Patient with AIP only diagnosis should be followed up with a repeat biopsy. Now, another very contentious issue is that when intraductal carcinoma is present, whether it should be included in the grading or not, and whether it should be really separated from cribriform prostate cancer. And there was nice discussion yesterday on this issue. We clearly recognize both of these phenomena as an aggressive prostate cancer. So I think both societies kind of clearly acknowledge that these are adverse pathological features and you need to report them. But in terms of grading, there was some divergence. GUPS recommended not grading intraductal carcinoma, while ISUP recommends grading intraductal carcinoma when you have an invasive cancer. So to address this question, I would like to kind of briefly summarize what is IDCP. So overwhelming evidence shows that the vast majority of IDCP represents a retrograde spread or a colonization of adjacent invasive prostate cancer. And that has been shown by multiple clinical evidence of associated high-grade cancer and associated adverse pathological features. There is a clearly overwhelming molecular evidence showing a concordant temporous to ERG gene fusions and P10 loss in both IDCP and adjacent invasive cancer. But there is a small proportion of IDCP, which is like typically 2 to 3% on radical prostatectomy, may be associated without invasive cancer areas, and those has been referred to as a potentially precursor-like or a non-invasive pure form of intraductal carcinoma. So those could be a in situ lesions from which prostate cancer could develop. And there is also rarely you can have this phenomenon with a grade group 1 prostate cancer in radical prostatectomy, or sometimes you may not find any invasive cancer. But these type of situations are extremely rare. And again, there is some indirect molecular evidence for this phenomenon as well. So when I face this type of situation in practice, I try to ask myself that, am I dealing with two type of precursor type of IDCP scenarios? And what are those? When you have a lack of definitive infiltrative carcinoma with a suggestion of intraductal carcinoma, or when you have a small volume, low grade, grade group 1 type of prostate cancer with atypical cribriform glands with a suggestion of intraductal carcinoma. So in these two type of situation, I would do basal cell staining and make sure that I think I am separating between the two. And here is my approach. So in those two type of potential precursor setting, I do not grade intraductal carcinoma, but in over majority of type of situation when I have a grade group 2 or higher cancer along with this type of morphology, I would try to separate morphologically using the features that I described, but I don't do basal cell staining to separate between two. I would potentially include them in my grading decision. So here are some final thoughts. So for clinical management, high-grade peen-like carcinoma, ductal adenocarcinoma, and IDCP should always be considered in the differential diagnosis of atypical large gland proliferation. Careful architectural and cytological details will provide you very important clues. However, prudent use of basal cell markers is necessary in some cases. You can also use P10 and ERG, which can be very helpful to differentiate AIP from high-grade peen. But keep in mind that when you have a normal pattern of these markers, that does not rule out the diagnosis of AIP or intraductal carcinoma. So this is very important point to keep in mind. I also showed you that ductal adenocarcinoma is a heterogeneous disease, and understanding of that is going to be critical to patient management. Vast majority of intraductal carcinoma represents a retrograde phenomenon of an adjacent invasive cancer. And ultimately, effective communication with clinical colleagues is important. So regardless which system you use, I think be very clear in your report and communicate with the urologist that this is what I'm doing it. So there is a, I think important message is that when you call 3-3 with intraductal carcinoma, in urologist's mind, it should be very clear that he is dealing with a potentially low-grade cancer, but with an adverse pathological feature. So I think those patients should not be considered good candidate for active surveillance. So with that, thank you for your attention.
Thank you so much, sir, for a wonderful talk. Quick 2 questions from the audience. Sir.
Thank you very much, Rajal, for the wonderful talk. Here, I just have one comment and one question. So the comment is that I think when we think about this potentially precursor intraductal lesions, right? There was a study from Johns Hopkins that is the whole argument of why we should do immunohistochemistry on biopsies that show that 10% of these lesions end up being intraductal carcinoma only in the radical prostatectomy.
Right.
But I want to highlight that that study, when that 10% refers to 2 out of 21 prostatectomies in a referral center. Personally, I think that that number is way lower. That number has been amplified over and over.
Yeah.
But in my practice, I think I've encountered 1 or 2 cases like that among more than 1,000. So that's the comment. And the question is, I just want to see what your clinicians do when you, I've had 2 cases that were intraductal only in the biopsies. And I call it intraductal only, and both cases ended up in treatment, in prostatectomy. So I wanted to see what's your experience in your center.
Yeah, I mean, I shared you one case already, like in this patient underwent a definitive treatment. I think when you have this type of associated Pirates file lesion, high PSA with these features, I mean, I don't really think that I think you can ignore these patients, and I think that would be a serious mistake. So I have several cases where they underwent a definitive treatment with this type of morphology and diagnosis. And I think regarding 3+3 with intraductal carcinoma, that's certainly quite controversial, but one thing that we all agree that these type of scenarios are extremely unusual. So I think, and I think we really need more data in this type of situation. So I think this whole retrograde phenomena, precursor phenomenon is maybe there, but it is not more than a rare phenomenon.
Just to develop on the comment Andy made, I was in a conference with Dr. Epstein and I asked him this question. His view was when you get in this intraductal proliferation, he leave it to the surgeons. If he wants to repeat a biopsy, because most of them are related with a high-grade cancer in a follow-up biopsy, but from his side, he's okay to take that call. Like Andy said, do a radical prostatectomy, I am okay with intraductal.
Yeah. Yeah, no, I think that's the case. I think, at least I think most of them, I think with the right clinical, they may undergo definitive treatment.
Hi, Raj. Yeah, very nice talk, and congratulations on your amazing work you have done in the AIP, ductal, intraductal categories. So based on the data which you have published, others have published, I think you have also shown, seems like AIP is clinically, perhaps morphologically, at the molecular level, very close to intraductal carcinoma. I think seems like all of that data is pointing towards the field. So what do you think, how much more data do we need to be able to start clubbing AIP within the IDC for simplification for clinicians as well as pathologists?
I mean, that's a great question, and I think that's one of the another point that we are trying to tackle, I think, in this consensus conference. So I think, I mean, yes, hi, Mahul.
No, I didn't mean to interrupt you, but...
Oh, yeah.
No, I just think the problem with AIP being close to IDCP and can we kind of get the groups together, the term AIP is when there's diagnostic uncertainty, and we always have to recognize that we will always have diagnostic uncertainty. So I'm not sure sort of moving AIP to IDCP, even though we know that they are probably the same. I have seen 2 or 3 medical legal cases, and one is sort of got resolved, where it was not a question of whether it was AIP or not, but it was PIN that was overcalled or PIN that was IDCP that was undercalled. So having a wastebasket term, wastebasket is wrong, having a gray zone term is really a good idea because we have to be able
I agree with that.
So I think, Rohit, I'm conceptually with you, thinking about it as them being related. But we always have to have this gray zone diagnostic uncertainty.
I think one point that I would make is that Guo-Epstein criteria are developed when you have a pure IDCP and you are looking for an invasive cancer at radical prostatectomy. While most of the time we use that criteria as a prognostic measure, right? That it is like associated. So that is why what I think is that when you have an invasive cancer associated with this type of lesion, you don't have to be very stringent in your morphological criteria. You can use little bit more lower threshold to make the diagnosis of intraductal carcinoma.
And also Epstein criteria, in the initial criteria, are not correlated with outcome. They are based on observations, right?
Yes,
so I think that's another part of the problem. What I do in my practice, and I wanted to see if this sounds sensible to you, is when I have something that looks like AIP, I do ERG and PTEN, and if it has ERG overexpression and PTEN loss, I say AIP because it doesn't meet criteria, but say favor intraductal carcinoma. Does that seem like a reasonable approach?
Absolutely, absolutely. I think that's but just one point that if you have no ERG overexpression or no PTEN loss, that does not technically rule out because only 80% of these lesions typically show this molecular abnormality.
So I just feel that at least seems there is quite a bit of data coming out now. I think you have great studies. So I think in the upcoming consensus, actually might be good to just have some possibly formal recommendations that patients who have AIP or AIP suspicious for IDC or IDC only on biopsy, perhaps just recommend the clinicians a biopsy. I mean, just to, I think we need to use the information we have, and try to consolidate instead of leaving, again, some degree of ambiguity, which is probably not helping. And I agree with Mehul. I think it's tough to be definitive. So.
Thank you so much for the wonderful talk, Dr. Shah. A big round of applause for Sash, sir. The next talk is, I would like to invite the speaker, Dr. Sean R. Williams, for the next talk of the day, how new developments impact diagnosis in existing renal neoplasms. Our co-chair for the session is Dr. Sushma Patra, who has just arrived. I would like to invite her. And Dr. Shah, can you proceed? Thank you so much. I would again request the discussions to be kept a little briefer, sir, because we are running short of time already.
Thanks so much for having me. The conference has been really amazing so far, and it's my first time in India. I really appreciate having me as part of this conference. So my focus for today is to talk about sort of the existing or established renal tumor entities, those that have been around a long time, and what is new about them in the last few years that can impact our diagnosis. So, of course, I think the best place to start here would be with the most common, and that's clear cell renal cell carcinoma. This is the prototypical renal cancer type. And diagnosis is usually straightforward. I think most of the time you don't need any sort of immunohistochemistry or molecular testing. But when you have a high-grade or high-stage tumor, I think the morphology can be quite unusual in certain instances, in which case immunohistochemistry or molecular testing might be helpful. So just looking at kidney cancer guidelines in general, there are different recommendations for treatment of clear cell versus non-clear cell renal cancer. So I think it's desirable to place a tumor into a bucket of clear cell or non-clear cell whenever possible. There is overlap among these drugs, so it may not be the end of the world if you're not able to subtype. But there are some differences in treatment recommendations, so we try to subtype when possible. Here's an example of a tumor that predominantly eosinophilic area of a clear cell renal cell carcinoma where we have a lot of hyaline globules. And I think if you had this by itself, this would be difficult to recognize as clear cell in isolation. However, other areas of the same tumor, you can see a transition to more typical clear cell morphology at the upper aspect of the field, which makes it more straightforward. A recent development in clear cell renal cell carcinoma is that some work by Gala and colleagues showed that sometimes the morphology is unusual when you have a BAP1 deficient tumor. And so we know probably well that clear cell renal cell carcinoma usually has VHL mutation and chromosome 3p loss, which are the characteristic molecular events. But in addition to that, it's been recently recognized that BAP1 deficient tumors, BAP1 is one of the additional genes that's often altered in clear cell RCC. And in this study, it was found that there are some unique morphologic features of BAP1 deficient tumors, especially papillary morphology, hyaline globules, and frequent Amicar and keratin 7 positivity. So here's an example of one where I think the morphology looks a little bit sort of papillary or pseudopapillary. And then in some areas, there are these small hyaline globules within the cytoplasm. So in a tumor like this, it might be not entirely obvious at first glance that you're dealing with a clear cell renal cell carcinoma. You might consider other possibilities like papillary or translocation-associated renal cell carcinoma. But in this case, you can see extensive membranous staining for carbonic anhydrase 9 supporting the clear cell subtype. Something that we're currently working on, Akriti Gupta was a former fellow in our institution, finished last year and is now at the University of Michigan. We were working on a project looking at the presence of foamy macrophages in clear cell renal cell carcinoma. Normally you would think of foamy macrophages as indicating papillary renal cell carcinoma or maybe MITF family translocation renal cell carcinoma. However, we've encountered occasional tumors where we think it truly is a clear cell subtype, and yet there are foamy macrophages within the tumor. And interestingly, after sort of stumbling upon by accident the first couple of examples of this where BAP1 was deficient, we found that almost all of the examples where there are foamy macrophages in a clear cell RCC are BAP1 deficient, at least in certain regions or subpopulations of the tumor cells. Only one out of 23 did not show BAP1 loss, and maybe even that one, if we had sampled other blocks, it might have been lost somewhere within the tumor. So what would you do with, what should we do with this information? Well, to me, if I have a tumor that's kind of weird, but I think it's overall a clear cell renal cell carcinoma, it has foamy macrophages, consider the combination of carbonic anhydrase 9, immunohistochemistry, and BAP1. And if it shows a CA9 positive, BAP1 deficient phenotype, to me that would interpret as in keeping with a clear cell renal cell carcinoma. So here's one with some areas of tumor cells, but then in between there are foamy macrophages like we see in papillary renal cell carcinoma. And the immunohistochemistry of the same tumor, we can see substantial membranous staining for CA9 on the left. And hopefully you can make out on the right. I tried to enhance the contrast a little bit to show that there are many stromal cells that are positive for BAP1, but the actual cells lining the glandular structures are lacking the nuclear staining for BAP1. So in general, when you have a eosinophilic clear cell renal cell carcinoma, I think a couple of things that can be helpful to recognize that. the cheapest and simplest way would just be to look at other areas of the tumor. If you have a whole resection specimen, sample additional areas looking for the more typical low-grade morphology. If you have a resection at your disposal, maybe looking for areas with the classic golden yellow orange color grossly may help to identify those areas microscopically. As was mentioned yesterday, clear cell RCC typically has a very delicate fibrovascular network, although as it was noted yesterday, that can be mimicked by other tumors like translocation family tumors. And as I mentioned, I really like carbonic anhydrase 9 as a marker of clear cell. This being part of the VHL pathways typically shows a diffuse membranous staining in clear cell RCC, although it may be negative in a poorly differentiated component of the tumor like I'll talk about in a minute. Sort of my impression of clear cell RCC is that when it becomes high grade or high stage, or just aggressive in general, the morphology can be really heterogeneous. And I think this is a good example of one where it looks normal and low grade in the lower left part, but then in the upper right you have these enormous giant multinucleated tumor cells, which would be hard to classify if you had only that. Recently some work from my colleague and friend Mahmoud Akul and his group looked at these multinucleated cells in clear cell renal cell carcinoma. He's actually also a faculty member of this meeting and will be presenting virtually tomorrow afternoon. But in the study by Pacheco and colleagues, they found that when you have kind of degenerative appearing giant cells, that is cells where there are multiple tumor nuclei that are kind of smudged and just clustered together, like shown in the top field there, this may not necessarily affect the behavior of renal cell carcinoma, and so it may not warrant consideration as a grade 4 if you have just these degenerative occasional cells with the clumping of the nuclei. But in other tumors where there were definite multinucleated cells with typical nuclear features, either with or without anaplasia, those seem to be associated with aggressive behavior. And so perhaps for me the takeaway from that is that occasional multinucleated cells with clumpy clustered nuclei may not necessarily be an indicator of true high grade. Another project that we've been working on and we're sort of overdue for completing was started by a former fellow, again, that worked with us, Kanika Aurora, formerly Kanika Taneja, where we're looking at clear cell renal cell carcinomas that have sort of a poorly differentiated component. To my knowledge, really, I'm only aware of kind of one case report cited at the bottom there of clear cell showing sort of a micropapillary morphology. And we've encountered tumors where we think overall it is a clear cell RCC, but in certain areas it sort of devolves into an aggressive morphology. Like here, if we saw only the pattern at the upper left, you might think that that was a urothelial carcinoma or just an adenocarcinoma NOS, but when combined with the more classic low-grade areas, you can recognize it as clear cell. Or in this one, for example, there's a transition from clear cell to this solid eosinophilic carcinoma that you might, again, think of urothelial carcinoma if you didn't have the lower grade areas to look at. And so what we found in that study is that PAX8 is typically positive in these tumors, so that can help to assign the renal origin. Of note, though, the carbonic anhydrase 9 may be decreased or absent in the high-grade component, or in some cases we had metastases where the primary tumor looked like a classic clear cell, but the metastasis had only the ugly component and was lacking the CA9 staining. Interestingly, these high-grade components may have some other markers positive that you normally wouldn't expect, like keratin 7 or keratin 20. Another colleague of mine, Reza Algabandan, recently published about a papillary component in clear cell RCC. So it seems that rarely can occur. Interestingly, in their study, there were some that were entirely negative for carbonic anhydrase 9. And so the way what I would do with this is, I would sort of require at least one of kind of the following: a totally classic low-grade clear cell component, diffuse CA9 staining, or proper genetics. So in the study, they were able to classify these as clear cell based on at least one of those features. I usually would like to see diffuse carbonic anhydrase 9 staining myself to feel better about the diagnosis, but in the absence of that, I would really probably want to have genetic confirmation and would probably consider a FISH for a translocation renal cell carcinoma if you had a lack of diffuse CA9 staining. But here's an example of one of these. This is probably also within a vascular space, probably representing vein invasion in the renal sinus. But we have some papillary morphology here. I think if you had only this, you would be thinking of maybe a papillary renal cell carcinoma or a translocation MITF family carcinoma. However, other areas of the same tumor had more typical morphology of clear cell RCC. And here we can see diffuse carbonic anhydrous 9 staining. So this may be an instance where you could use molecular pathology. I think, as I mentioned before, in the vast majority of the time, you probably don't need molecular pathology when diagnosing clear cell RCC. But a subset with unusual morphology, or especially in the metastatic setting, it may be useful. And so here was an example of a nephrectomy where the tumor was very eosinophilic, sort of nonspecific based on morphology, a lot of necrosis. And then using immunohistochemistry, the carbonic anhydrous 9 stained kind of in only a focal patchy distribution, which could represent just ischemia adjacent to the areas of necrosis. So I thought this was sort of inconclusive, but in fact, molecular testing was requested on this tumor and was mutated for the VHL gene, which I took to support the entire classification as clear cell renal cell carcinoma despite the only focal CA9 staining. So in select instances, it may be helpful to have molecular testing. In terms of oncocytic tumors, there are a number of emerging entities in oncocytic renal tumors, and I won't focus on those. I think Dr. Mehra actually will be probably covering a bunch of that shortly. But what's new kind of in the established entities of oncocytoma and chromophobe renal cell carcinoma? Immunohistochemistry, I think, often comes up in this differential diagnosis, so I just wanted to start out with kind of what I expect of an oncocytoma. If you look at the literature, I think it can be confusing talking about keratin 7 in oncocytoma. Some papers will say it's negative, some papers will say it's positive, and I think that depends on the threshold you're using. If you say any positivity means it's positive, then you would say oncocytomas are often positive. But if you have a cutoff like 5 or 10%, then you might say most of them are negative because only rare cells are positive for keratin 7. So I'll show an example of that in a moment. c-KIT and Vimentin don't really help you to distinguish between oncocytoma and chromophobe renal cell carcinoma, but to me they do sort of help just identifying that spectrum, the oncocytic spectrum, and separating it from other tumor types. Vimentin gets a bad reputation in soft tissue pathology, and I agree it's probably useless in soft tissue pathology. But in renal tumors, I do feel that there's at least a select role for it here in distinguishing oncocytoma chromophobe from other categories of renal tumors. So, like I mentioned, I would expect keratin 7 in an oncocytoma to show just scattered staining of individual cells and clusters of cells. But an interesting finding is that in the scarred areas of the tumor, the central scar, the keratin 7 is often increased. And here's a recent paper published by Ankar Sangoy and colleagues showing the funny immunohistochemistry that you can get in the scar areas of oncocytomas. So keratin 7 often increased in the scar area, but if you look away from the scar area, usually you see just scattered individual cells. And then similarly for Vimentin, we expect the tumor cells to be negative, but in the scar area, they're often positive. So what would I do with that? I would just ignore the scarred areas, focus elsewhere. Here in the conventional areas of the tumor, Vimentin is negative. And similarly, they also found that carbonic anhydrase 9 can be positive in the scar areas, but typically not in the other areas. Oncocytoma can have some disconcerting features that it can extend into fat, and that it can involve small vein branches or even perhaps the main renal vein. And so far, all the data that we're aware of suggests that despite these potentially worrisome findings, the behavior still seems to be favorable. So although these would indicate a T3 stage for renal cancer, if the diagnosis otherwise is compatible with oncocytoma, there's no evidence that this affects the behavior. So here's an example of oncocytoma kind of just spilling out into the perinephric fat without any kind of stromal reaction or desmoplasia. And then here's an example of an oncocytic tumor with a large plug of tumor in a vein branch. And although this would seem highly disconcerting, here's an example of a very small early bulge into a vein branch. Although this would seem highly disconcerting, the largest series recently published by Sarah Wobker and colleagues showed that there was no aggressive behavior from these, even with vascular invasion. If you've seen me talk about oncocytic tumors before, you may have seen a picture of this carpet. This probably just proves that I have renal tumors obsessively on the brain, but I was in a hotel at one point using the exercise room, and I saw this carpet, and I thought it reminded me of a specific renal tumor, and probably I'm just obsessed with renal tumors. But if you imagine that these tan structures are tumor cells, and then the yellow blobs in some of them are nuclei. An interesting finding is that not all of the cells have nuclei. And then there's this kind of black outline, which could be prominent cell borders. So this reminded me of a chromophobe renal cell carcinoma. And perhaps an under-discussed finding of chromophobe renal cell carcinoma is that it looks like a lot of cells don't have nuclei. And I think that's not that they don't actually have nuclei, but rather the cells are just so big and so voluminous that you can totally chop them with your microtome and entirely miss the nucleus. So you get this missing nuclei sign that reminded me of the carpet. Chromophobe renal cell carcinoma, though, can have some unusual morphologic patterns. Here's one that I would probably lump under the umbrella of adenoid or adenomatoid / neuroendocrine-like on the left. And I think if you had only that, you would be struggling to recognize that as a chromophobe renal cell carcinoma. However, on the left, or excuse me, on the right are some areas that were more typical. And using immunohistochemistry, this was positive for KIT in a membranous distribution and diffusely positive for keratin 7, supporting it in this sort of chromophobe spectrum. Again, my friend and colleague Reza Al-Gabandan recently published this review looking at the different histologies of chromophobe renal cell carcinoma. And there can be quite a few unusual patterns in chromophobe RCC tumors. Again, recently, Ankar Sangoy and colleagues described some retraction-like spaces mimicking kind of a micropapillary pattern. Other studies have described small cells or papillary architecture. Like the one that we just saw, some of these tumors have been described as resembling neuroendocrine differentiation. However, usually it seems that they're not truly positive for neuroendocrine markers, and so it's probably more of a pseudo-neuroendocrine morphology. And then some tumors have been described as microcystic and pigmented. So chromophobe renal cell carcinoma kind of has, I guess, many faces that are important for us to recognize and place into that bucket of non-aggressive renal cancer. So what do we do with tumors that are in the sort of gray zone between oncocytoma and chromophobe renal cell carcinoma? I think a nice development was that in the recent GUPS consensus paper on existing renal entities, it was proposed that we can use this term of oncocytic renal neoplasm of low malignant potential, not further specified or not further classified, as a category for tumors that are in this oncocytic spectrum. Maybe there's some minor atypical findings that make us hesitate in considering it an outright oncocytoma, but we can place it in this box of likely non-aggressive and not even meeting diagnostic criteria for chromophobe renal cell carcinoma to convey to our clinical colleagues that the tumor would likely be highly favorable, and maybe at worst, the patient needs some surveillance similar to what you would do for a chromophobe tumor. And in fact, in the Cleveland Clinic, we're using that terminology quite a lot when there's any minor atypical findings that make you a little bit nervous about diagnosing an outright oncocytoma, but yet there are no definite features of malignancy. Within papillary renal cell carcinoma, the most recent major development is that type 1 and type 2 subtyping is kind of no longer recommended. I think this was also alluded to yesterday. The entity formerly known as type 1 papillary RCC appears to be the homogeneous entity that would be under the diagnosis of papillary renal cell carcinoma currently. What was formerly known as type 2 probably includes more than one diagnostic entity, such as MITF family translocation renal cell carcinoma, FH deficient renal cell carcinoma, and others. So a consequence of this is that maybe some of the things that we previously called type 2 will be pushed into the unclassified or not otherwise specified renal cell carcinoma category if they don't have prototypical features of papillary renal cell carcinoma. A pattern that's been more sort of recently elucidated in papillary renal cell carcinoma is the so-called biphasic pattern. Originally, this was recognized by Andre Hess and colleagues from the Czech Republic under the name biphasic squamoid alveolar renal cell carcinoma. since there are these nests of eosinophilic cells within the lumen of the glands that kind of resemble squamous differentiation. However, all evidence suggests that these are not true squamous cells, but rather just more voluminous eosinophilic tumor cells. And all of the data so far suggest that this is similar to papillary renal cell carcinoma, just a funny morphology of papillary renal cell carcinoma. Here's just a full screen view of this pattern with the eosinophilic cells kind of in the lumen of some of the glands. So does that histology matter? Not really. I think you can diagnose it as papillary renal cell carcinoma. One recent study did find a higher frequency of MET alterations with this morphology, including some which were germline. But overall, I think for clear communication purposes, we can just put this together with regular papillary renal cell carcinoma. Clear cell papillary renal cell tumor, for a long time I probably would have discussed this among emerging or new entities, but I think now it probably warrants consideration as an established entity. It was first recognized in 2006, so we're coming up on almost 20 years since it was described. It has its own chapter in the WHO classification, so I think it's now pretty well established. Since almost all of these tumors are extremely favorable, it's been now reclassified as a tumor rather than a carcinoma in the WHO classification. However, the question kind of remains, does aggressive behavior ever occur in clear cell papillary renal cell tumor? There are a couple of reports of possible metastases, both coming from the Mayo Clinic, Dr. Shonak Gupta and colleagues, in which there were tumors that very much resemble the clear cell papillary tumor that metastasized. In the first instance, everything seemed pretty much perfect, including absence of genetics of another renal tumor type. However, the primary tumor was never removed. Only the metastasis was available for evaluation in that first report. In the second report, there was even more comprehensive evaluation. And again, no highly specific findings of any other tumor type. So I guess it remains uncertain whether this is a non-aggressive entity that can extremely rarely metastasize, or if these rare examples are a clear cell papillary tumor mimicking, or excuse me, another type of renal cell carcinoma mimicking a clear cell papillary tumor. Here's one other report of a clear cell papillary tumor, or what looked like a clear cell papillary tumor that transitioned into sarcomatoid dedifferentiation. So again, is it possible that rare tumors can progress? Perhaps. So I guess there kind of, to me, remains three possibilities. Is clear cell papillary tumor a sort of benign, non-aggressive tumor with extremely rare metastasis? There are reports of metastatic oncocytoma suggesting that, that maybe some of these low-risk benign tumors just very, very rarely do metastasize. Perhaps these are actually misdiagnosed. There's something else mimicking a clear cell papillary tumor, or perhaps rarely one of these can progress to malignancy, acquiring a high-grade or sarcomatoid component, although two of those reports that I mentioned didn't have any such high-grade component recognized. So my approach to clear cell papillary tumor is I kind of want everything to be perfect. I want to see the classic morphology and the classic immunohistochemistry. And some might consider it perhaps a bit excessive, but I do all 6 of these immunohistochemical markers listed here, basically anytime I'm making that diagnosis. Since the stakes are fairly high, being that this is a non-aggressive / benign tumor, and we're distinguishing it from a renal cell carcinoma. So you'd expect CA9, high molecular weight keratin, and keratin 7 and GATA3 to be positive. Some labs, I think, have had different experience with GATA3. I think this may depend on your method and your clone, but at least in my experience, almost everything that I've wanted to call a clear cell papillary tumor has had at least weak GATA3 staining. So it may depend on your particular laboratory, but for me, most of the time, there is at least weak staining. I usually do not do molecular pathology, but that could be considered in cases where the diagnosis is challenging. We heard a bit about translocation, MITF family translocation renal cell carcinoma yesterday, so I won't spend too much time on it today, but just to touch upon a couple of areas that are more recently recognized or emerging in MITF family translocation renal cell carcinoma. Again, in general, a marker that I like a lot is carbonic anhydrase 9. You'd expect it to be minimal or negative in the MITF family translocation tumors, helping to distinguish them from clear cell subtype. Cathepsin K and melanocytic markers are often helpful as well, in that if they're positive, that raises suspicion for the diagnosis. However, a negative result for those two doesn't exclude the diagnosis, since only about half of translocation tumors are positive for cathepsin K. Here's one with sort of a clear cell-like pattern, but it has nuclear alignment, kind of resembling a clear cell papillary tumor. And then other areas of the same tumor have some hyalinized fibrovascular stroma and some psammoma bodies in the lower left, raising suspicion for a translocation tumor. And this is actually one with the nano-TFE3 fusion, which has been recently recognized to have a unique challenge in diagnosis. Since the TFE3 and nano genes are both on the X chromosome, if you're using a FISH assay to try to detect TFE3 rearrangement, the two probes don't move to separate chromosomes like they normally would, and so this can be a very subtle or false negative appearance using FISH. And similarly, the RBM10 gene is also located right next to the TFE3 gene on the X chromosome. And so again, with rearrangement, those genes do not split apart widely like they normally would, and so a FISH can appear negative. So what's the optimal method for detection of MITF family tumors? I think it's debatable. You can use immunohistochemistry for the TFE3 or TFEB proteins themselves. Those are probably sensitive but not too specific, and if you have a weak to moderate staining reaction, you may want to follow that up with a molecular test. FISH has a very strong sensitivity and high specificity, but as we just noted, there are some false negative examples. Next generation sequencing is highly sensitive and highly specific, but I recognize that that's not going to be widely available everywhere, and in fact we use it only as kind of a backup in select patients. Secondly, it may depend on your NGS techniques whether or not you would detect the TFEB amplification that was talked about yesterday, so that may be a limitation of using NGS. Some ancillary IHC markers, we mentioned already, cathepsin K has a high specificity but low sensitivity. Only about half of the tumors are positive depending on which exact fusion they have. We've recently started using a marker called GPNMB, which is an emerging marker, probably of higher sensitivity than cathepsin K. This also detects tumors with TSC-mTOR pathway alterations. But the full spectrum of what is positive for this marker likely remains to be further determined, since there are only a few papers so far. And then Dr. Mehra yesterday mentioned that they used the TRIM63 RNA-ish assay, which does seem to also have very high sensitivity and specificity, but again, not every practice would have access to that technique. Just lastly, to touch upon infiltrative pattern in renal cell tumors. And I think, again, Dr. Mehra mentioned this yesterday. If you have a tumor with an infiltrative pattern, I would kind of consider these sort of 4 diagnoses almost all the time before classifying a tumor. I would highly consider urothelial carcinoma, INI1, SMARCB1 deficient medullary carcinoma, FH deficient renal cell carcinoma, or metastasis from another cancer. Does collecting duct renal cell carcinoma sort of still exist in current practice? I think that's debatable, but it would be a diagnosis of extreme exclusion where the tumor appears to be Pax8 positive, and you can strongly argue against all of these other considerations before arriving at that diagnosis. So I am just about out of time, so I'll come to this summary page here. Some important things in current classification of the common renal neoplasms. Clear cell versus non-clear cell may be relevant for treatment purposes, and so I really like to use the morphology plus CA9 for that diagnosis, and in select patients, genetics. In the oncocytic tumors, the Orn lump or oncocytic renal neoplasm of low malignant potential, I think now is becoming a more viable category for non-aggressive oncocytic renal tumors, acknowledging that we don't really know exactly where the cutoff should be between oncocytoma and chromophobe. In papillary tumors, type 1 and type 2 is no longer used. Clear cell papillary tumor, again, highly favorable but rare reports of metastases. And then in the MITF family, there are these cryptic fusions which can be difficult to detect with FISH. And so I'll stop there, hopefully to try to keep us on time. Thank you.
Thank you very much, Professor Williamson, for your excellent deliberation and how the newer development can impact on the treatment of existing tumors. So we now invite a few questions, one or two questions from the audience. Yeah, please.
Sean, great presentation. So, I mean, my question is that particularly in biopsy, how far would you go? Like sometime when you just don't have obvious diagnosis, I mean, how far you would go to prove that that's the case?
So in the biopsy setting, I think one thing that I pursue is if there's a possibility of clear cell papillary renal cell tumor, then I often do immunohistochemistry to evaluate that differential diagnosis, clear cell versus clear cell papillary tumor. That's interesting because now that it's been kind of relabeled as a benign or low risk tumor, we're making a little bit more of a major diagnosis on a biopsy setting. So you might argue, should we outright call that on a biopsy? Maybe not. And then if you're sort of in the non-clear cell box but difficult to classify, sometimes I do leave it in the biopsy setting as sort of renal cell carcinoma with a comment that it's difficult to definitively classify and that may be better done on a resection if possible. Although you occasionally could do molecular testing or FISH or something on a biopsy. Often we'll leave it as renal cell carcinoma in the biopsy diagnosis and then possibly refine it on the resection if possible.
Thank you. Any question from audience? Yes, please.
Yeah, excellent talk. Nowadays, our pathologists take a longer time to report the kidneys. 1 day for a bladder, 2 days for a prostate. And once the kidneys come, they said, no, give us a week or so. So looking at your lecture and listening to and also sort of looking at the past talks on the kidney, I mean, has it become really difficult to subclassify, to get to rare entities? And the next question is how it's going to help us in the management. Because when you see these sort of fearsome words, I mean, last week we had a patient with chromophobe RCC with sarcomatoidifferentiation. There are still sort of with new classification, every time our team goes for a conference, comes back, we get a new diagnosis on the board. So we don't know, I mean, where to go for, and especially for a metastatic disease, whether we can offer them something different. Non-clear cell, we don't have any treatment on our hand. But so new entities coming up, I think as a clinicians, we are really scared.
Yeah, it's interesting. I guess in some ways, maybe we're making things too complicated with all of these emerging entities because the treatment would be similar most of the time for a non-clear cell tumor. Sometimes I've been asked, are we over-splitting with these entities? And maybe we are, but I guess from the learning standpoint and the research standpoint, I'd like to figure out if there's a significance to some of these subtle differences clinically. But you're right, yeah, it seems like it's becoming complicated, and hopefully with topics like this, we can convey to the non-specialists a little bit that it's not as critical as it might seem to split hairs of some of these subtypes. But I think some of them do have importance, like the clear cell papillary tumor, very favorable, some associated with hereditary syndromes, and so forth.
Just to build on that question, where do you leave it? For example, you don't have facilities for FISH or the arrangements. Like all the tumors or the eosinophilic ones have certain criteria. You look for intracellular calcifications, prominent eosinophilic nucleoli in some of them, like vacuolations. The SDH has a different morphology. So how far do you go on morphology, like in your routine reporting?
I mean, I think the important thing is to, if you can recognize certain important diagnoses, at least, like as you mentioned, with evacuation, the SDH deficient renal cell carcinoma, that would have some major implications in terms of the hereditary syndrome. And so if I see features that I think are suspicious for that, I would try to pursue the further testing. Maybe just to recommend genetic counseling if you don't have access to the immunohistochemistry or something like that. But I think Dr. Mera's got the next topic on pink cell tumors of the kidney, so that may add some more clarity to this part.
But in the clear cell setting, you do a CA9, and if it is diffuse, we are okay to call it clear.
Yeah, if I think the morphology looks good for clear cell, and then there's diffuse CA9, usually I would stop there, and plus minus if there's any chance of clear cell papillary tumor, adding keratin 7 and those. But if I think it's clear cell and there's diffuse CA9, usually I feel good to stop there.
Thank you very much. For the interest of time, I think we'll close it here. Any quick comment from your chairperson?
No comment. Just excellent talk, Sean. Just clarity on clear cell papillary tumors with reports from Mayo coming with metastasis. So what's your take on it? Are we again going back to carcinoma, or do we need to add a bottom line if we see such kind of tumor when we write a report?
I don't know what to make of those. I mean, there's so few reports, and I sort of almost do believe that there are rare, quote unquote, metastatic oncocytomas. So maybe some of these very low risk benign tumors just super rarely metastasize. I don't know. It's really tricky, and I have seen one example of what I really thought was going to be a clear cell papillary tumor, but then the immunohistochemistry was wrong, and so I erred toward a diagnosis of clear cell in that case. So I think it's tricky. Last year at the European Congress, we had the precursor meeting, which discussed a little bit of this. Does it ever progress? I think it'd be interesting to kind of further study this and figure out. I really don't know what to make of those rare
I think we
reports.
need more evidence and more follow-up to make a note of it, whether it's tumor or RCC.
Thank you very much. This is the end of this session. Over to organizer.
Thank you so much, sir. It was a wonderful talk by Dr. Williamson. I would like to invite Dr. Rohit Mehra for the next talk on pink cell tumors of the kidney, making sense.
Good morning, everyone. Thank you for the conference organizers for having me here today, and thanks to Sean for the excellent narrative in the previous talk. I hope this helps clarify, but I'm sure I'll be adding some fuel to the fire as well. So actually there is an intense pink cell tumor neoplastic output from the human nephron or within the kidney. And the pink character which we see, if we look at under the microscope, even the AI studies which are coming out, they are actually looking at this pink texture which we can perceive. And sometimes it's a smooth pink staining, and sometimes it's a very granular texture to it. And actually that carries some significance. So I believe pink is a more broader term which can happen in a lot of different neoplasms in the kidney, and I will be sharing some of those. But then when we have the pink granular cytoplasm, which we have sort of relatively specifically labeled as oncocytic or eosinophilic granular, generally reflects some metabolic perturbations at the mitochondrial level. So the mitochondrial dysfunction is generally going to manifest as the pink granularity, which we so-called oncocytic tumors of the kidney. And these are over here several different so-called eosinophilic or pink or oncocytic tumors listed in the kidney. The challenge is some of these have morphologic similarities, and regardless, they are still distinct entities with distinct histopathologic features and clinicopathologic annotations. And this is what is compounding the problem. The morphologic similarity, but regardless, these being distinct entities. So the questions we need to ask are, what are we seeing under the microscope? What are the underlying mechanisms? So why are these distinct entities, but how do they still carry some morphologic as well as biomarker similarities? What are the origin of these tumors? And can all of this help facilitate our understanding of clinical diagnostics and research? So the human kidney is anatomically and histologically a complex parenchyma, and each human kidney houses 900,000 nephrons. It's a big number, but it's a finite number. Actually, it's only 900,000 nephrons per kidney. And each nephron constitutes the anatomic, histologic, functional, and anatomic, as well as physiologic unit of each kidney. And then there are specific cells along the epithelial lining of nephron, which determine the unique functionality as well as the potential for neoplastic transformation. So we are able to now perform a very unique kind of single cell sequencing, which lets us predict the cell of origin for different renal tumors. So these are all radar plots. So I think the way to read this is, I think these are all radar plots, and we go from 1 to 12. And these are different cells which are lining the nephron from the proximal to the distal end. For example, these are PT cells, which are proximal tubular cells, and these are the intercalated cells, which are in the distal nephron. And this spoke actually points towards the cell of origin for different tumors. So we have been able to show that the clear cell renal cell carcinoma, papillary RCC, and the subset of MITF RCC actually originate from these uncommon PTB cell type clusters within the proximal nephron. And we have also been able to confirm that chromophobe renal cell carcinoma originates from the intercalated cells. I think everyone knows here that clear cell renal cell carcinoma exhibits vimentin expression. So if we ask why is that the case, and actually it is actually used diagnostically in some centers. I do not use it for diagnostic purposes, but I have always wondered why is an epithelial tumor expressing vimentin? And the answer lies in this PTB cells. The PTB cells have inherent stem cell-like properties, and they express stem cell-like markers, and one of the markers which is constitutively expressed in PTB cells is vimentin. And that is the reason clear cell RCC is actually expressed vimentin. So we are able to perform now this very unique kind of nephronal mapping where we are able to delineate different segments of the nephron. And then using single cell sequencing and other sequencing technologies, we are able to map each segment of the nephron with different biomarkers. And we have some established biomarkers which we use daily in our practice. For example, CD117 is an intercalated cell marker expressed in the distal nephron area. There are several advantages to this technology and or this kind of nephronal mapping. We can learn about the origin of tumors, and then we can find cancer-specific biomarkers and tumor-specific biomarkers for different renal tumor entities. So actually, I'm going to walk us through the nephron from the proximal end to the distal end. Actually, Sean covered a lot of the proximal nephron-based tumors, which include clear cell RCCs and papillary RCC, and he talked a little bit about distal nephrons, which include a lot of these eosinophilic tumors. So a lot of molecular data has also come up, which has tried to distinguish these proximal tubular nephron-based tumors compared to the distal tubular nephron-based tumor. And the transcriptional networks in the proximal nephron and the distal nephron are expressed differentially. So actually there is a lot of sense in terms of where these tumors are originating from and how they are evolving. So this is a very evolving field right now, but this is my current understanding of which renal tumors originate from which segments of the nephron. So clear cell RCC, papillary RCC, subset of MITF RCC originating from the proximal nephron, MTSSC from loop of Henle, a lot of pink tumors from the distal nephron, and the medullary RCC from the thick ascending limb of loop of Henle. So in my talk, I'm focusing more or less on these tumors today. And like we know, oncocytomas, chromophobe RCCs, several mTOR TSC based as well as KRAS mutant based tumors originate from the distal nephron. So all oncocytic tumors which originate from the intercalated cell have CD117 expression. So if we think why oncocytomas, chromophobe RCCs, other low-grade renal oncocytic tumors have CD117 expression, it's because the cell of origin, the intercalated cell, has constitutive CD117 expression. This is not a mutational kit-based overexpression. This is because the originating cell, the intercalated cell, has CD117 expression. That is the reason these oncocytic tumors are showing CD117 expression or overexpression. CK7 expression is variable for unknown reasons, at least so far, but we do have new biomarkers now to characterize oncocytic tumors, as well as to help distinguish metastatic chromophobe RCC from others. And I will talk about at least a few of these today. So renal oncocytoma, I think Sean has already described. I think Dr. Amin and Dr. Tiku have like these really nice papers on renal oncocytoma. I think this is what this tumor looks under the microscope. And I hope all of you can appreciate this cytoplasmic eosinophilic granular texture, and this in my sense is the oncocytic cytoplasm we talk about. And I think in my sense for residents and fellows, for calling a tumor as an oncocytoma, I look at the nuclear features. If the nuclei are round, predominantly similar to each other, reflecting a clonal state. And if 80 to 90% of these nuclei can pass through a sieve with perfectly round holes, that is for me a renal oncocytoma. There are several acceptable findings which include the degenerative atypia, small cells or oncoblasts, and fat invasion and vascular invasion. These are all okay for a diagnosis of renal oncocytoma. But there are some non-acceptable findings. For example, infrequent to frequent mitosis, true coagulative tumor necrosis, overtly papillary architecture, and true cytologic atypia. If I see any of these features, I generally tend to stay away from a diagnosis of renal oncocytoma. Again, these tumors have diffuse CD117 expression with rare CK7. Majority of these tumors have a normal karyotype, but there are subset of tumors with a loss of chromosome 1Y, and there's another subset with the CCND1 rearrangement. At the morphologic level, these different subsets with different molecular annotations look similar. There are some biomarkers to help figure out these tumors, but currently there is no clinical utility for those. Renal oncocytomas, as well as other eosinophilic pink granular tumors of the distal nephron, do exhibit either mitochondrial gene mutations or mitochondrial dysfunction. And that is the reason, or at least one reason for this granularity I talked about. And most of these tumors also express other intercalated cell markers, and these are Link 1187 and FOXI1. I will have a few slides on this later on. Can we diagnose renal oncocytoma on biopsy? In my practice, I do that, and I will generally, when I come across a situation where a particular renal tumor biopsy looks like me to an oncocytoma, I will call it as an oncocytic renal neoplasm favor oncocytoma. And I will put in a comment that if this biopsy sample is representative of the entire lesion, the appearances would be consistent with an oncocytoma. A chromophobe RCC, I think Sean has already described this, including the cells which do not have any nuclei. And then I think these are different architectural growth patterns which can still be possible for chromophobe renal cell carcinoma. Chromophobe RCC, for unknown reasons, at least so far, has a propensity to undergo an epithelial mesenchymal kind of transition, and this is what is known as sarcomatoid features. Here we can see these retained islands of chromophobe RCC and this abrupt juxtaposition to this high-grade spindle cell morphology. This tumor has an abrupt juxtaposition, whereas there are other tumors where we can see a slow gradual transition as well. And these are examples of sarcomatoid features within chromophobe renal cell carcinoma. Here we can see this residual island of chromophobe RCC, and we can see this really high-grade morphology with tumor giant cells as well. And this generally portends a poor prognosis for patients with chromophobe renal cell carcinoma. It is important to distinguish these from degenerative atypia when the nuclei have more like an ink blot or like dark blue character. And Ki67 can really help easily in distinguishing when there is a doubt. So grading of chromophobe RCC is currently not recommended. There are some surgical pathologic features which can help determine aggressiveness of chromophobe RCC, and these include pathologic stage, necrosis, sarcomatoid features, as well as small vessel micro invasion. So the chromophobe renal cell carcinoma has a very distinct signature loss of 7 chromosomes at the cytogenetic level, and these chromosomes are 1, 2, 6, 10, 13, 17, and 21. And there are fewer hypermethylation events and lower mutational burden in clear cell RCC and papillary RCC. And this is the reason when actually chromophobe RCC metastasizes, it is even less amenable to tyrosine kinase inhibitor and immune checkpoint inhibitor therapy because it's a lower mutational burden and lesser hypermethylation events. The TCGA has done a remarkable workup of chromophobe renal cell carcinoma, again with the same cytogenetic signature loss of chromosomes I mentioned. Only a small subset of chromophobe RCC have inherent or intrinsic mTOR-TSC pathway aberration. It's only a small subset, not the entire chromophobe RCC series. And there is a subset of chromophobe RCC which has TERT promoter aberrations or mutation as well. There are some high-risk molecular features now associated with poor survival, which include TP53 mutations, PTEN mutations, CDKN2 alterations, as well as DNA hypermethylation. It's also important to remember that PTEN can be implicated within chromophobe renal cell carcinoma, both in a somatic or sporadic as well as germline fashion. So please be careful when you handle PET and ISC in chromophobe renal cell carcinoma. We have performed single-cell sequencing on chromophobe renal cell carcinomas, and we have nominated several markers, and one of my favorite markers, and the one we have published a lot, and now we actually have been using this marker clinically in our RNA ISC lab for almost 2 years now, is called Link 1187. So Link 1187 is a long non-coding gene, meaning that there is a gene transcript, but there is no protein. So that means IHC cannot be utilized to detect overexpression of this gene because there is no corresponding protein, but we can detect the RNA transcript by using this technology called RNA in situ hybridization. And this is the background kidney, and we can see Link 1187 RNA highlighting these individual cells, and these are actually the intercalated cells which are giving rise to or linked directly to this chromophobe renal cell carcinoma, which is showing this brown granular dot-like expression, and each dot actually represents a RNA transcript. For those who are not familiar with RNA-ish, it is not a rocket science. It's like any other surgical pathology tool we have. We just need to get familiar with this. We use RNA-ish on a daily basis, and we are very comfortable in our lab. It is like how IHC started, and there are a lot of problems in immunohistochemistry, antibody variability, specificity issues, sensitivity issues. So in certain situations, RNA-ish can be actually very, very helpful. We have also done a study in head-to-head comparison of CD117 and Link 1187, and anyone who is practicing GU pathology has come across eosinophilic pink tumors, and when we stain them with CD117 expression, the expression for CD117 is equivocal, and then we are left wondering, is it truly a positive CD117 tumor or not? And then we have done head-to-head comparison of Link 1187, which is also an intercalated cell marker, and actually, surprisingly, and to my satisfaction, 100% of the tumors with equivocal CD117 expression, we were able to resolve all of those situations by performing RNA-ish for Link 1187. So there are a subset of chromophobe renal cell carcinoma which have more uniform eosinophilia in the cytoplasm. Again, we do not know the reason why a subset of chromophobe renal cell carcinoma, but these are questions for the residents and fellows to figure out as they go along in their careers. These tumors tend to be more acinar, diffuse eosinophilic cytoplasm, focal nuclear wrinkling, and certal perinuclear clearing. These tumors are still CD117 positive with negative to focal CK7. They do express 1187 and FOXI1 faithfully. 40% of these tumors are diploid, and generally these tumors have less frequent chromosomal losses than the classic chromophobe renal cell carcinoma. These are more examples of the eosinophilic pattern of chromophobe renal cell carcinoma. And it's important to stay away from the terminology of eosinophilic variant because variants are associated with gene variants, not morphologic variants. And I think Gladel had pointed this out yesterday. So I think these are more like eosinophilic features of chromophobe RCC. And I think even at this power, we can see this certal perinuclear clearing and certal nuclear wrinkling. And this can be helpful for the diagnosis. So I have talked about oncocytoma, chromophobe RCC, eosinophilic pattern of chromophobe RCC. Let us review this renal tumor biopsy, which I came across about 3 years back or so, 55-year-old male with a 5.2 centimeter renal tumor. And we can see there are areas of pink cellular character, which are abruptly juxtaposed to these cells which have cytoplasmic clarity. So at the morphologic level, one could suspect that there are areas resembling oncocytoma, and then there are other areas resembling chromophobe renal cell carcinoma. And these tumors have been historically, for this reason, called hybrid oncocytic tumor. And when we stain these tumors, they are positive for PAX8. One population of cells is positive for CD117. I think if we look carefully at this IHC, there are a lot of cells which are negative for CD117. And this is a question I have been trying to figure out for a long time. What is this second population of cells, which is CD117 expression? We have called this a checkered expression pattern for CD117, and CK7 is generally frequent in these tumors. So based on, again, sequencing studies we have done on hybrid oncocytic tumors from patients with genomically proven BHD syndrome, we have found out that actually one subset of the cells is positive for CD117, and these are the cells which are originating from intercalated cells, and that is why they have constitutive CD117 expression. And the second population of cells, which is almost mutually exclusive, not 100%, but almost mutually exclusive, is labeling with this marker called L1CAM, which is now very helpful in workup of renal tumors. And this is actually a marker for principal cells, which are different from the intercalated cells, and principal cells are also coming from the distal nephron. So now we have a tumor in BHD patients, which is hybrid, not because it has areas resembling oncocytoma or truly representing oncocytoma or chromophobe RCC. If this entire tumor was made of areas coming from oncocytoma and chromophobe RCC, the entire tumor would be CD117 positive, but we can see that is not the case here. Actually, there is a checkered growth pattern expression, and the reason is this tumor is hybrid because there are two cellular constituents, which is, I think, a very interesting phenomena. Most tumors tend to be clonal, but this tumor actually has a subset of cells which are L1CAM positive and a subset of cells which are CD117 positive. And I believe there is a precursor ICPC cell which actually evolves within this tumor either into a IC state or to PC state. Hybrid oncocytic tumors may occur in patients with renal oncocytosis, in patients with BHD syndrome, and they can also happen uncommonly in sporadic tumors. We are right now trying to study the nature of these tumors in sporadic situations. Whenever I diagnose this tumor on needle biopsy, I will generally add a comment, especially in those cases where there is no previous clinical hereditary association. I will add this comment to say that this renal mass biopsy demonstrates an oncocytic neoplasm with hybrid features, which may be seen in patients with BHD and or renal oncocytosis. Let us review this tumor. Again, this has that eosinophilic pink granular character. There are some nuclear variations, perhaps too much for oncocytoma, but they're not really a definitive features for chromophobe renal cell carcinoma. And like Sean pointed out, these are the tumors which we have in the past called low-grade oncocytic RCC unclassified, or we are now calling them as oncocytic renal neoplasm of low malignant potential NOS. I still use these, both of these terms depending on the case. So this is my approach to low-grade renal oncocytic tumors, and I have talked about most of these tumors. I think there is a lot of data, and I think our clinicians have also pointed out what's the advantage of this kind of granularity in classification, and I think it's a great debate to have. And but I think there can be syndromic annotations. Uncommonly there can be sarcomatoid change, at least in a subset of these tumors, and we are learning more and more about these. So one tumor I haven't talked about so far is a low-grade oncocytic tumor. These tumors generally have a more acinar features. Previously, they have been placed under the eosinophilic pattern of chromophobe RCC, but now we have learned that these are distinct tumors. So these tumors tend to have this consistent perinuclear halos, and they are consistently positive for L1CAM, and we believe that these tumors arise from the principal cells. There's a nice study from MSK now comparing low-grade oncocytic tumors from the eosinophilic pattern of chromophobe RCC, and there are two distinct differences. Based on the CNV profile, lots have a very, very flat genome, whereas eosinophilic chromophobe RCC still have the signature chromosomal differences we will see in chromophobe renal cell carcinoma, and then the high majority of lot have mTOR-TSC pathway aberration. So I think these are two distinct entities. This is my current impression of renal tumors with oncocytic features, including their morphologic features, cell of origin, biomarker profile, as well as genomic aberrations. But I think this field is evolving as I speak, so I think please keep an eye out. Then the question which has come again and again, I think we also discussed this in the European Congress meeting, which was in Italy a couple of months back, that are these tumors related to each other in terms of genesis? Meaning, can an oncocytoma progressively perhaps develop into chromophobe RCC or associated with chromophobe renal cell carcinoma? So there is the CPTEC interrogation interrogation of kidney tumors, and I happen to be the GU pathologist on this CPTEC interrogation of kidney tumors, and we have now 3 papers out, so please review these when you can. And based on the proteogenomic assessment, we believe these are all distinct tumors. These are not progression events. But why the morphologic similarity, despite these being distinct tumor entities? At least one answer which we know today is there is a common cell of origin or common nephronal segment of origin. And that is the reason that we are seeing some cellular or morphologic or histologic commonalities. Also, the majority of these tumors have mitochondrial perturbations, and that is another reason we have this morphologic similarity, but these are still distinct tumors with specific genomic profiles, expression signatures. CNV events are very unique in renal tumors, so we can almost diagnose the high majority of renal tumors just looking at their copy number variation patterns. We don't even need to look at the H&E slide. We are developing a CNV-based clinical assay right now in our lab as well. And then, like I mentioned yesterday, kidney cancer is a metabolomic disease, and the metabolomic dysfunction is distinct in all of these tumors. No talk on renal tumors can be complete today without at least touching the mTOR-TSC family of renal tumors. I believe WHO needs its own distinct chapter on this family of renal tumors to avoid confusion. And the mTOR-TSC family of genes can be implicated in both germline as well as somatic mutation. And these are the tumors which are listed here, which can show mTOR-TSC pathway aberrations. This is an example of one of the tumors. This tumor has eosinophilic solid and cystic features. If we think about mTOR-TSC pathway tumors, we can see even this tumor has cells with large size. And actually that is true for almost any mTOR-TSC pathway aberrant renal tumor. Why is that the case? The reason is that mTOR pathway physiologically is involved in cellular growth, regeneration, and increase in cell size. So when mTOR pathway becomes aberrant, the renal neoplasms which are associated with mTOR pathway aberrations tend to have a large tumor size. So the same tumor, when it is associated with hereditary annotations, is known as a TSC-RCC, but when this tumor happens in a sporadic fashion, this is known as an ESC-RCC. So we, as well as others, have worked a lot on these ESC-RCCs, and ESC-RCC is now included in the 2022 WHO renal tumor classification. Now, this is another example of mTOR-TSC pathway aberrant tumor, EVT, and here again we can see the large cell size, cytoplasmic vascularization, large nucleus with prominent nucleoli, and these tumors tend to express CD117 and cathepsin K. These are not KIT mutations, but I'm not certain if this tumor is also originating from the distal nephron or not, possibly. I've already talked about LOT. I think Sean talked about GPNMB, and conceptually, I feel the reason GPNMB is not able to help us distinguish between mTOR pathway tumors and MITF-RCC is, if we try to understand tumor biology, actually MITF pathway genes and mTOR pathway genes are in a forward loop feedback, meaning that once TFE3 and TFEB are overexpressed, they're going to upregulate overexpression of mTOR-TSC pathway genes. Similarly, when mTOR-TSC pathway becomes aberrant, it kicks up the TFE3, TFEB gene expression. That is the reason it's very difficult to develop biomarkers which are inherently distinguishing between these two family of renal tumors. So Dr. Shah and I have recently written a review article, which I believe was a GUPS article, which was a GUPS initiative led by Christina, and I think please visit this when you can. I hope you find it helpful. And Sean and Sambit also have this nice article where they have talked about inherently mTOR-TSC pathway aberrations in the renal tumors. I think it's a nice study. Please check it out when you can. Then moving on to the last segment of my talk, what are the other renal tumors with pink appearance? This is a low-power view of a tumor with a compact solid papillary architecture. This is an easy diagnosis, large nuclei, perinuclear halos, prominent nucleoli. This is an example of a FH deficient renal cell carcinoma, most commonly associated with the HLRCC syndrome. This tumor has been talked about in the morning today. This tumor again has a solid or nestic, perhaps microcystic appearance, a neuroendocrine character to the nuclei, cytoplasmic vacuoles, eosinophilic secretions, and this is an example of a STHP deficient renal cell carcinoma. Based on our several studies or several modalities, we believe now that STHB deficient renal cell carcinomas also originate from the distal nephron, and we are presenting this in the USCAP Boston meeting in 2025. I'll skip this entity. This tumor I showed yesterday, which has the features of the erstwhile no longer used type 2 papillary RCC, but this is an example of a TFE3 altered renal cell carcinoma. And like I had mentioned yesterday, renal cell carcinomas can also show high-grade oncocytic and papillary features. For unknown reasons, there is a linear array of nuclei away from the basement membrane. I think we need to find out why are MITF RCC pathway tumors exhibiting this kind of morphology, that there's an accentuation of linear array of nuclei away from the basement membrane. But this can be a helpful feature for MITF RCC, including TFEB amplified RCC. So I already went over this yesterday, so I can skip. Another distal nephron-based tumor is this interesting and intriguing entity called papillary renal neoplasm with reverse polarity, which shows tubulopapillary and oncocytic features. There is a low-grade nuclei, again with luminar accentuation, unknown reasons. These tumors tend to be positive for L1-CAM and GATA3, both distal nephron-based markers. So I do believe this tumor arises from the distal nephron. Currently, the WHO possibly suggests, or there is some data suggested to include these tumors with papillary renal cell carcinoma. I do not think that is the case. I think these are inherently very different tumors than papillary renal cell carcinoma. There is a commonality to 717 CNV, but I think if we look at the TCGA data, KRAS mutations are uniquely very uncommon in RCC, but this is a renal neoplasm where KRAS mutations are highly enriched, and these tumors have a favorable prognosis. So I think these are standalone, distinct entities. So I'm almost done. This is a renal cell carcinoma with eosinophilic features, high-grade nuclei. When I worked up this tumor, it was positive only for pancytokeratin, PAX8, and PAX2. All the markers I did were not helpful towards the diagnosis, and so I ended up calling this a RCC NOS, or unclassified. And Dr. Chen at MSK has shown that when actually renal cell carcinomas are correctly placed, even in the unclassified or NOS category, actually these tumors are enriched for specific pathway aberrations. So actually there is a value in placing tumors correctly, even in the unclassified or NOS domain. This is my approach for difficult to classify renal tumors, which includes my first-tier workup markers, second-tier workup markers. And I resort to molecular testing, especially when there are tumors which are difficult to classify, definitely in tumors where there is a metastatic phenotype or there is a germline annotation. So artificial intelligence has made an indent in the RCC domain as well. I was privileged to participate in this study where we were able to distinguish clear cell RCCs from TFE3 RCCs just using AI-based algorithms. So there is a lot of movement in this field. So these are the overarching goals of renal tumors: finding specific cell of origin, distinct clinicopathologic features, different biomarkers, genomic epigenetic events, copy number changes, metabolic perturbations. And in the end, we want to help our clinicians, especially in the metastatic state, to perform molecularly enabled clinical trials. I think this is an exciting and fantastic time to be a pathologist. You know, I think I love working with my colleagues. I hope all of you are enjoying working as pathologists, and I hope everyone is enjoying working with pathologists. I'm happy to take any questions.
Wonderful talk by Dr. Mehra. Thank you so much.
Thank you very much, Professor Mehra, for your extensive deliberation on different kinds of pink tumors of kidney. So any question from audience we can have? Please, yes.
Excellent talk, Dr. Mehra. I had a couple of just comments and queries. Some time back, I had a case which was absolutely looking like chromophobe. In the sense, we reported it as chromophobe, but just as a completion, we did CK7, CKIT, and it was dead negative. I've never come across chromophobe which is dead negative for CK7.
Yes,
and it was absolutely chromophobe. There was no other differential diagnosis. And I, in fact, shared this case with some of my friends also. And I did ask the question. Generally, you can have focal CK7, focal strong group of cells, but never a dead CK7 and a CKIT. Now that you've shown the whole nephron and the distribution of these, so some of these, have you come across chromophobe which are completely dead negative for 7?
Yes. I think that's a great question. I have come across these, and we have had two strategies. I think in some of these cases, CD117 was negative, but then we ended up doing other markers like link 1187, and actually that was positive. Regardless, I have seen probably 2 or 3 cases now where even those markers were negative. I think more work needs to be done on those, and I think we need to perhaps perform some genomic interrogation for these tumors to see where they are originating from. And I think I believe they will still have the classic signature loss of chromosomes. Similarly, we have seen tumors which are clear cell RCC very uncommonly, which have the VHL pathway aberrations, but they are CA9 negative. I don't mean to scare people, but I'm talking about zebras, but I think they do exist. But if it looks like chromophobe RCC, I would call it a chromophobe RCC.
Regarding L1 cam, it's very, very exciting marker. You said it's principal cells. We had a case of FH deficient, which was strongly L1 positive, L1 cam positive.
Wow. I think
maybe once.
Yes, I think so. So you stole our thunder. So right now we have a manuscript actually which is close to submission, where we have presented this at USCAP. We have interrogated L1 cam in HLRCC, associated RCC, and FH deficient RCC. More than 95% of those tumors are positive. Yes, so I think we are happy to collaborate with you.
That was a great presentation. I'd just like to throw a wild question out. Is there a possibility that WHO would consider reclassifying renal tumors based on cell of origin?
Well, I wouldn't say it's a different classification system. I would say that as we go along, it's possible that within each renal cell carcinoma category, a paragraph might be added which talks about what's the cellular origin of these tumors. I do not believe that a cell of origin based classification is necessary, but I believe an insight and learning into cell of origin is necessary for these different renal cell carcinoma subtypes. Also, this is a very new and exciting field. I think we are learning more about it every day. For example, my previous thought process was that L1 cam is purely a principal cell marker, but now actually we have more data that L1 cam is also expressed in poorly differentiated high-grade carcinomas like Santosh mentioned, FH deficient renal cell carcinomas. I will mention that I do believe that already our WHO, it doesn't say it explicitly, but our WHO classification of our renal tumors is inherently a molecular classification, and I think putting that explicitly out there is going to help everyone.
Yeah, please.
Excellent talk.
Rohit, can I ask a question?
Sorry.
Yeah, please go ahead.
Excellent talk. Thank you very much. I just wanted to see what's your opinion about renal tumors with biallelic NF2 inactivation.
Sorry, biallelic?
Biallelic NF2 inactivation. In terms of whether they could represent a distinct entity. And of course, I'm talking about those in which NF2 biallelic inactivation is not happening in the context of another well-recognized driver, of course.
Yeah, I think you're spot on, Andy. I believe those are distinct tumors. I think that should be a different and distinct chapter within WHO, and we are learning more about those. And like, the BHP RCCs, and there are some other ones which have been described by Dr. Pentel. I think actually the work has been done in Chicago. So I do believe those are distinct tumors. Also in terms of NF2 pathway tumors have hippo pathway aberrations. So these tumors in metastatic state, a lot of these tumors can be metastatic. These tumors have an aggressive phenotype and they might be more amenable for NF2 inhibitors which already exist in the space. We just need more clinical trials. The problem with these clinical trials is these are still isolated cases. The majority, 85% of tumors are clear cell papillary and chromophobe, but I believe those are distinct entities.
Yeah, excellent talk. We do see a lot of small renal masses nowadays. Number one, we do a sort of needle biopsy before we put them on active surveillance or sort of otherwise treatment. So how confident the pathologist would be with a 1 or 2 needle core biopsy with this kind of so much you need immunohistochemistry markers and so many tests to run. So a needle biopsy versus a specimen.
Yeah, no, I think that's a great question. I think high majority of tumors are still clear cell papillary or chromophobe RCC, and I think that is what 80 or 85% or perhaps 80% of tumors are falling in that category. And a diagnosis of those tumors on biopsies in high majority of instances will be unequivocal. So I think that should be very helpful for the clinician. Sorry, go ahead.
Yeah, and the second question was, all these oncocytic varieties, have we come to a stage where we can confidently say we can follow these patients with active surveillance? Have we
Yes,
reached a
yes,
stage?
and I think that is true. And I did have one slide actually. I think where I think high majority of these tumors tend to have an indolent behavior. So I think that is where clinical sciences and morphologists need to come together. I think like renal oncocytomas, low-grade renal oncocytic tumor, they all have a very similar prognosis. Like low-grade oncocytic RCC, RON, NOS, oncocytoma, even if they involve the sinus or the vessel, they're going to have a good prognosis. I believe most of these are okay to be followed by active surveillance. But is that for 100% of cases? No, but high majority, yes. But I think that goes with medicine and tumor biology.
Rohit, I have one question. So I think we know that there is a renal oncocytic neoplasm, further unclassified category, which is the new. And I think I see that with creation of that category, basically we became so defensive on diagnosis of oncocytoma, which we used to call oncocytoma, now are pretty much put into that bucket. So where you draw the line, and I think, I typically do CK7, CD117 must, in whenever I'm dealing with a low-grade oncocytic tumor. Yeah. What would be your...
Yes. I know I have a similar strategy, Raj, like for CD117 and CK7 expression. I still do not like to see a lot of CK7 expression in renal oncocytoma. We don't really have a lot of background data to explain this finding. But in terms of data available in literature, if there's a lot of frequent or cellular clusters rather than single cells positive for CD117, as for CK7, I tend to stay away from the diagnosis. But I agree with you. I think this entity has not helped a lot, perhaps, but then there are tumors which are not oncocytomas or chromophobe RCC. It sort of helps give us a name. For clinical reasons, I believe all of these are indolent tumors. So I think putting that in our comment, and I think trying to help our clinical colleagues, that these are still okay to be followed by active surveillance.
Sometimes I find these oncocytomas have multinucleation and a lot of atypia. Is that allowed in an oncocytoma? And a lot of emperipolis both in clear cell RCCs and other oncocytic. What is the role of these? Are these findings to be documented?
Well, if there's true cytologic atypia, I might stay away from the diagnosis. I do not recall seeing a lot of emperipolises in oncocytomas. I don't know what Raj or Sean think.
Not in oncocytomas. Okay. I'm saying oncocytic tumors in general.
Yeah.
Occasionally you find, quite distinct emperipolises, and even in clear cell sometimes. Just want to know from the house, how important is it to document?
Well, I think till we know the overall diagnostic entity, and I think there will be some variations which are present, but till we are clear about the overall diagnosis, I think we should be able to still convey the correct information.
Thank you very much, the speaker and the participants. I think we have to stop here for the paucity of time. Over to organizer.
Thank you so much for the wonderful session on the hot topics of uro-oncology and uropathology. I will now request Adcs team international speakers to center the stage and our chairpersons to center the stage for a group photograph, please.
So thanks again. So I'll just cover a couple of cases focusing on the topic of clear cell and papillary tumors of the kidney. For the first patient, this is a renal tumor, and let's say that this was a typical patient in the age presentation range of the 50s or 60s, so the kind of common age range where we would see a renal cell carcinoma. And most areas show cells with clear cytoplasm, like we can see here. But then interestingly, there were a few areas with these punctate calcifications, maybe psammoma bodies within the tumor. In other areas here, you can see on the left, more clear cytoplasm, and then a transition to slightly more eosinophilic cytoplasm on the right. So whenever I would encounter this combination of findings, I think the main couple of things that I would think of would be clear cell renal cell carcinoma, like we talked about in the earlier session. That's certainly the most common type of renal cell carcinoma, and it's fairly common to have eosinophilic cells with higher grade tumors. But the combination of a clear cell pattern plus calcifications or maybe psammoma bodies would make me strongly consider the possibility of MITF family translocation renal cell carcinoma. So my approach would be sort of to be very cautious diagnosing a clear cell renal cell carcinoma with psammoma bodies or kind of small punctate calcifications. Strongly consider MITF family tumors. However, some recent work that I participated in, again with my colleague Ankar Sangoy and others, including Dr. Mehra and others who are here today, we found that you can rarely have psammomatous or punctate calcifications in a true clear cell renal, or what we think to be a true clear cell renal cell carcinoma. Some background on the project that we did goes back to work with Dr. David Grigno. He was one of my mentors at Indiana University, a really great pathologist and great speaker if you ever had a chance to see him lecture. Unfortunately, he passed away a couple of years ago. But working with him, and then Dr. Sangoy recalled a lecture that he gave in 2018 where he mentioned that finding psammoma bodies in a clear cell renal cell carcinoma would be an extremely rare occurrence, and he would like anyone to take a picture if they ever encounter that. And so that prompted us to think about this topic, and we pursued a study where we found 21 tumors which we thought to be clear cell renal cell carcinoma in which there were calcifications. Apologies, I guess my font shifted a little bit, so the words are overlapping a little bit here. Mostly these tumors were high grade, so grade 3 or 4. And often there were other unusual morphologic patterns associated, or higher grade morphologic patterns like eosinophilic cells, giant cells like we talked about earlier, rhabdoid features. One tumor had kind of a branched glandular pattern like you might see in a clear cell papillary tumor. One had some spindle cells not quite reaching the level of sarcomatoid dedifferentiation, and one had a poorly differentiated component like I talked about earlier. In support of these being actual clear cell renal cell carcinomas, we thought that most of them had diffuse CA9 staining that says 80 to 100% of the cells. It's kind of overlap there. Although it could be, again, decreased in the eosinophilic cells like we talked about in the earlier session. Importantly, though, at the bottom right, we can see that all of the markers of translocation renal cell carcinomas, including the highly sensitive TRIM63 RNA-ish and TFE3, TFEB fish, were all negative, arguing against these being translocation renal cell carcinomas. Interestingly, we found only 7 out of 19 where we did chromosome 3p fish to have a 3p loss. On the left is an example of one that shows deletion of chromosome 3p. You can see 2 copies of the centromere, but only 1 copy in green of the P arm. And that seems perhaps a bit low. What's the explanation for that? I'm not really sure, but you may require multiple technologies to really assess a clear cell renal cell carcinoma and capture all of the genetic alterations. We didn't do sequencing, and so we don't know for sure if these had VHL mutation. And promoter hypermethylation is also another mechanism by which VHL can be inactivated. So we may be underestimating the genetics of clear cell in this cohort. But at any rate, here's an example of one of these showing diffuse carbonic anhydrase 9 staining. But on the right side, you can see actually in the eosinophilic areas it transitions to a lesser amount of staining. Here's another tumor with clear cells and kind of scattered calcifications. In this same patient, we had a transition from the low-grade component to giant cells on the right-hand side here. And you can see again in that field, the CA9 was strong membranous in the low-grade component, but then absent in the giant cell component. So sort of the Cleveland Clinic approach to deciding whether or not you need to pursue TFE3 or TFEB FISH for a translocation renal cell carcinoma, we often use a combination of markers, carbonic anhydrase 9, cathepsin K, and keratin CAM 5.2. And so we figure that diagnosis of MITF family translocation carcinoma is relatively unlikely if you have a positive CA9 and keratin CAM 5.2 with the cathepsin K being negative. However, in the opposite situation where you have carbonic anhydrase 9 negative, we would strongly consider pursuing that further with FISH. We usually default to FISH, although we do have a targeted next-generation sequencing panel that detects TFE3 alterations. But at the present time, we're mostly using FISH, at least as our default. Like I mentioned earlier, there are some emerging markers for translocation renal cell carcinomas. GPNMB is something we recently added to our inventory. You may consider replacing cathepsin K with that, although I think we need more studies on that marker. We have had a few tumors with sort of unexpected positive results, although those were not further pursued with genetics, so we're not totally sure what the significance is. For example, we encountered a tumor that we thought mostly the balance of features favored clear cell papillary renal tumor, which should not have alterations in those molecular pathways, but yet the only discordant IHC finding was GPNMB positive. But again, that tumor was not sequenced, so we don't really know. Maybe it in fact did have a genetic alteration that we overlooked. Another part of our approach is that if the features are really strongly favoring an MITF translocation family renal cell carcinoma, it may be reasonable to just make a diagnosis of translocation, features strongly suggesting translocation renal cell carcinoma. Why? If FISH is not available or is pending, that can put the tumor into a non-clear cell box for treatment purposes. And then even if FISH is negative, there are the cryptic fusions, which we talked about earlier, which are not necessarily excluded. So sometimes we often do use, as at least a preliminary diagnosis, renal cell carcinoma with features strongly suggestive of MITF family translocation renal cell carcinoma. In the interest of time, I guess I'll just briefly touch upon this, a second example. Here was a renal cell carcinoma that we encountered, has cells with very clear cytoplasm. And looking at it more closely, kind of two things came to my mind in terms of differential diagnosis: clear cell renal cell carcinoma or hemangioblastoma. And there have been rare reports of hemangioblastomas in the kidney. Normally these are expected in the brain and central nervous system, or less commonly in soft tissue. But interestingly, the ones that have been reported in the kidney paradoxically seem to have PAX8 positivity. In contrast, CNS hemangioblastomas have been reported to be negative for PAX8, helping to distinguish them from metastatic RCC. So the PAX8 positivity in renal hemangioblastomas is somewhat surprising and paradoxical. These are some references describing renal hemangioblastoma. So it seems that multiple groups have reported hemangioblastomas in the kidney, but others have also described renal cell carcinomas that have overlapping features with hemangioblastoma, and here are a few references along those lines. In our current patient, here's an example of PAX8 staining, which would argue for the primary renal cell origin. There is some focal patchy staining for inhibin, a marker that we'd expect of hemangioblastoma. Carbonic anhydrase 9 again showed membranous positivity, although that wouldn't distinguish between those two tumor types. And interestingly, this one showed diffuse keratin 7 staining. And some recent work from a Japanese group has suggested that what has been referred to as hemangioblastoma, like renal cell carcinoma, may actually be more in the spectrum of renal cell carcinoma with fibromyomatous stroma in the spectrum of the TSC-mTOR pathway mutated renal cell carcinomas. So I kind of think we have an open question here whether primary renal hemangioblastoma actually exists now that with this recent understanding. Perhaps the tumors that have been previously diagnosed as primary renal hemangioblastomas are actually more in the spectrum of renal cell carcinomas with the fibromyomatostroma, those that are TSC or mTOR gene alterations. And just as another example of that, this is a patient that I saw a few years ago where the patient was clinically thought to have tuberous sclerosis, so thought to have a germline mutation of the TSC mTOR genes, had multiple angiomyolipomas in the kidney, had a tumor pictured, you can see here on the left, which what looked like a renal cell carcinoma with fibromyomatostroma. And then in another specimen had what looked like a hemangioblastoma. And I considered that to be paradoxical because hemangioblastoma is associated with VHL mutation, not TSC mTOR. But interestingly, sequencing of that tumor, the one that looked like hemangioblastoma, revealed only TSC2 alteration and not a VHL alteration. So again, I think this perhaps supports the possibility that at least some of what was previously thought to be hemangioblastomas of the kidney may actually be more of a spectrum of the morphology of renal cell carcinoma with fibromyomatostroma. So it looks like we about out of time, so I'll stop there and we can continue with the next part.
Thank you so much, Dr. Williamson. Any questions from the chair?
Nice talk, Sean. I think your comment on the hemangioblastoma-like tumors or the so-called hemangioblastomas, I think I agree with you that is debatable. We actually interrogated and tried to find biomarkers for hemangioblastomas, both central as well as non-central in type in kidney and other organs. And we actually use single cell sequencing studies to do that. But actually, so what happened is, I think, at least I feel the way this process might be evolving is that the primary CNS hemangioblastomas may or may not be VHL related, but somehow they're still expressing CA9. And I think renal hemangioblastomas perhaps might express CA9. I think that's an open question, like you mentioned, whether they're related to FMS or not. The ones I have seen, the renal hemangioblastomas as well as adrenal hemangioblastomas, did not seem to have that FMS character, but I believe they are possibly another tumor in the mTOR-TSC family of renal tumors. And I think that even begs more that in the next evolving WHO classification, I think we probably just need to put all of these tumors separate within a single molecular category. And that might explain also like the morphologic phenotype we are talking about. Thank you.
Thank you, Dr. Williamson. For the next talk, I would invite Dr. Andrea Costa to a talk on sex part stromal cell tumors of testis.
Good morning, everyone. Thanks once again for the invitation to be part of this wonderful Congress. I'm really happy to be here with you, and in this presentation I will be showing two cases that show the challenges associated with diagnosing sex-core stromal tumors with large Sertoli cell phenotype. I have no disclosures for this talk, and our first case is a consult of a radical orchiectomy of a 16-year-old teenager who presented in 2007 with a large testicular tumor, and all serum markers were negative. And here you can see a low magnification micrograph of the tumor that shows three sort of different areas, one here at the top, one in the middle with prominent calcifications, and one here and the lower part of the picture that corresponded to the center of the tumor. We will go over each one of these areas at higher magnification, and you can see here that an area here at the top had what seemingly were intratubular lesions composed of these large Sertoli cells with abundant pink cytoplasm and round regular nuclei associated with abundant eosinophilic basement membrane material. Right next to this area, you had small nests of tumor cells with similar cytomorphologic features associated with myxostroma and a very dense inflammatory infiltrate that we will see in greater detail in other pictures later. Here you can see the middle portion of the lesion, characterized again by nests of similar neoplastic cells, closely associated with this complex mulberry-like calcifications that have very prominent lamination, as you can see in those pictures. And the center of the tumor consisted mostly of trabeculae of tumor cells with similar phenotype. Again, you can see the myxostroma, and on the right you can see that the infiltrate present within the stroma was composed exclusively of neutrophils. So we didn't have this stain back then when we diagnosed this case, so we did it retrospectively, but here you can see that PRKR1A expression was retained but significantly reduced in the intratubular component of the tumor. You can see the normal expression here in non-neoplastic seminiferous tubules. And interestingly, some of the nests that were associated with these calcifications were also showing retained expression of the marker, although at a lower intensity when compared to the normal testicular parenchyma or non-neoplastic testicular parenchyma. But the center of the tumor was totally negative for PRKR1A, meaning that there was loss of PRKR1A expression, and you can see the normal expression present in the internal control neutrophils there in the lower picture. So again, this case was diagnosed in 2007, and apparently the patient had some perioral lesions that are poorly defined in the clinical history, but they were not hyperpigmented. However, because of the diagnosis of this large cell calcifying Sertoli cell tumor, which you might have all recognized very well because it's a very typical tumor, this patient was interpreted to have Poyd-Yeger syndrome. And that's interesting because we know that large cell calcifying Sertoli cell tumor is typically associated with a Carney complex, but in the literature there have been some cases that have been reported in the context of Poyd-Yeger syndrome. But the big caveat there is that all those cases predate the era of molecular pathology, or at least didn't have any molecular studies. So again, this patient was put on in 2007 on surveillance for Poyd-Yeger syndrome, so he was scoped many times looking for polyps. But 2 years later, he developed a myxoma of the lip, confirmed by pathology. In 2019, he developed a chest wall lesion that was a solitary fibrous tumor, and later that year, he presented with Cushing's syndrome, and the underlying cause was found to be primary pigmented nodular adrenocortical disease. And at the end of that year, the patient was diagnosed with a pigmented epithelial melanocytoma. So here, the melanocytoma, the adrenal lesion, and the myxoma are all features of the Carney complex, not of Poyd-Yeger syndrome. And that's why in 2019, 12 years later, and many endoscopies later, the patient underwent germline testing, and a pathogenic PRKR1A variant was found, which was truncating. And therefore, the diagnosis of the syndrome was changed to Carney complex. And here I'm showing the second case, again, partial orchiectomy in this case from a 15-year-old teenager. In this case, the patient had an established diagnosis of Poyd-Yeger syndrome with a known germline STK11 mutation. He had presented initially with intussusception due to intestinal polyps. And on surveillance ultrasound, he was found to have bilateral testicular masses. And this is taken literally from the clinical history. The clinician interpreted these tumors as being large cell calcifying Sertoli cell tumor. And again, this is interesting because the tumor that is typically associated with the Poyd-Yeger syndrome is intratubular large cell hyalinizing Sertoli cell neoplasia not large cell calcifying Sertoli cell tumor. But it looks like we're making this quite confusing for clinicians. So we performed a partial orchiectomy or an excisional biopsy, and here you can see a low magnification micrograph of the tumor that interestingly had an intracystic component that you can see in greater detail on the right. And at intermediate and high magnification, you can appreciate the morphologic overlap with the prior tumor, in that this tumor consisted of this large epithelioid neoplastic Sertoli cells with abundant pink cytoplasm. It also contained an intratubular component associated with abundant eosinophilic basement membrane material. But as you can see here in the center, there were some nests that were difficult to interpret as being intratubular, and they appear to be an invasive component of the tumor. This tumor also had very prominent calcifications, but unlike the prior lesions, those calcifications were not mulberry-like and were not laminated. And you can also see that the stroma is different. Here you don't have that myxoid stroma that you saw in the prior tumor, and you don't have the neutrophilic infiltrate. Again, we didn't have a lot of immunohistochemistry when we diagnosed this case initially, but retrospectively, we did PRKR1A, in this case with a red chromogen, and you can see that this marker was retained in the tumor. Here I'm showing another section just to show you that the retained expression of this marker was seen throughout the lesion. And also retrospectively, we performed STK11 immunohistochemistry. This is a part of an ongoing study that we're performing in collaboration with Will Anderson and Jason Hornick at Brigham. And you can see that there was loss of STK11 expression in this tumor with retained expression in background seminiferous tubule, and this was present throughout the tumor, as you can appreciate here in yet another section. So I think that this tumor generated some debate, and it was hard to diagnose because there were some features that were suggestive of a large cell calcifying Sertoli cell tumor, such as the presence of invasive components, because as the name implies, intratubular large cell hyalinizing Sertoli cell neoplasia is supposed to be entirely intratubular, right? But the association with Poyer syndrome and the absence of some of the characteristics seen in large cell calcifying Sertoli cell tumors, such as the typical calcifications, myxoid stroma, and neutrophilic infiltrate, were more suggestive of intratubular large cell hyalinizing Sertoli cell neoplasia. So I think this whole confusion that we've seen in these two cases is totally justified for several reasons. One is because both tumor types have been reported in the context of Poyer syndrome. However, again, I want to emphasize that the large cell calcifying Sertoli cell tumors that were reported in these patients were not analyzed at the molecular level. The other problem is large cell calcifying Sertoli cell tumors we know can have intratubular components, and we have seen at least one bona fide case of a purely intratubular large cell calcifying Sertoli cell tumor confirmed by PRKR1A immunohistochemistry. The other problem is that they do show overlapping features being characterized by these large eosinophilic neoplastic Sertoli cells, and I think the biggest problem is that the name intratubular large cell hyalinizing Sertoli cell neoplasia implies that these tumors can only be intratubular when we know that STK11 altered neoplasms in the ovary can definitely have invasive components. So what do we know about these two tumor types so far? Well, what we know is that tumors that are classified or were diagnosed as large cell calcifying Sertoli cell tumors, when they are sequenced successfully, they invariably have PRKR1A variants with loss of heterozygosity, and that has been confirmed in 2 separate studies, and that correlates very well with the loss of PRKR1A expression that we see in more than 90% of these tumors. We don't know much about intratubular large cell hyalinizing Sertoli cell neoplasia, mostly because my attempts to sequence them have been unsuccessful, but recently we have this STK11 IHC, and in an ongoing study we have shown that 4 of 8 cases had complete loss of expression, 3 of 8 had significantly reduced expression, and only 1 had retained expression, whereas all large cell calcifying Sertoli cell tumors that were confirmed molecularly had retained expression of this marker. So we are hoping to publish this data soon. Thank you very much. That's all I have, and happy to take questions.
Thank you so much for the question. Any questions? Any comments?
Quite interesting and thought-provoking case. Being in Indiana University, I think you see lots of testicular tumors and post-chemo RPLNDs. In general, just tell us, what's the incidence of non-germ cell tumor entities within the testes at Indiana University? Reason I'm asking is tumor markers normal, small tumors. So are we sort of looking at doing more of a testicular preservation surgery in these kind of patients, doing in hyocectomy? That's the whole idea.
Thank you so much.
Thank you very much for this question. And so I would say that our population is very biased, as many of these tumors we see in consultation. So it's hard to estimate, what's the real prevalence of sex stromal tumors based on our experience. But I would say it's about 5% for us. And that could also be biased because we also see a huge load of germ cell tumors because they go to Indiana for treatment and for archaeology. But in our practice, it's about 5% of all tumors. Having said that, I think in pre-pubertal patients, our urologists are usually, willing to do this approach of, a testis-sparing surgery with sometimes an intraoperative assessment and go from there. But in post-pubertal patients, I think the approach is almost universally radical orchiectomy unless the tumor is very small. But I think in post-pubertal patients, they usually, unless there are any specific issues related to the patient, will go for a radical orchiectomy.
Thank you. Chairs, any comments? We'll take the next case. Thank you so much. For the next presentation, I would like to invite Dr. Jayaram Iyengar. He would talk about an interesting case of kidney tumor. Dr. Iyengar?
Thank you very much. And I come from a resource-poor setting where access to clinical information is scarce. Very often we do not have patient clinical information, but nevertheless, we do come across a fair number of cases with interesting presentations, and this case is one of them that I would like to share with you. We received a biopsy endoscopic biopsy from a gastric polyp in a 74-year-old lady who presented with dyspepsia and upper abdominal discomfort and dark-colored stools. And apparently, the mass was in the body of the stomach, fairly large, 3x2x1 polypoidal mass, which on a whole slide mount, on a whole slide image, showed a nice cauliflower appearance with well-formed glands in the stalk. The stalk was quite long and extensive ulceration in the surface, and the entire area of the stalk was covered with pink and blue areas. And as you can see here, there are a lot of inflammatory cells in the ulcerated area, and then in the center we have a whole lot of cells with different kind of appearance, which are arranged in cords, and even this magnification, you can see that there are sheets of cells with clear cytoplasm. Again, well appreciated here. And on a higher view, a lot of clear cells were there with some amount of nuclear pleomorphism, visible nucleoli here and there, as we can see here. So this left us with multiple thoughts. First, of course, very unlikely, could it be a xanthoma? Xanthomas do not present with such huge masses, and they are usually foam cells in between normal appearing glands in the laminopropria. So we did not really consider a gastric xanthoma here. Could it be a a carcinoma with clear cell carcinoma, enteroblastic differentiation. Predominantly they present as tubular papillary pattern and their large cells. Didn't fit into that in this particular case. Could it be a diffuse adenocarcinoma signet ring cell type? We really could not demonstrate mucin in this case. And of course, could it also be a clear cell sarcoma? The cells were absolutely clear. Clear cells have a pale eosinophilic cytoplasm. So we didn't really seriously consider that. And with this morphology, the other thought that occurred to us was, could it be a metastasis from a clear cell carcinoma, very likely source being the kidney. We were really excited about this, and we did try to reach back to the laboratory that referred this specimen to us. And with great difficulty, after a couple of days, we got the history that this patient was diagnosed as a clear cell renal cell carcinoma in 2018 with a nuclear grade of 2. And there was extension into the renal vein, so it was a PT3N0 tumor. We, as pathologists, get hyper excited when we see wonderful cases or interesting cases, and this, it kind of pumped up our excitement, and we thought this is something very, very rare that we are seeing. But a couple of days later, we did also get additional information that at the time of the biopsy, the patient also had multiple other metastases, which was evidenced on PET CT. No doubt, interesting case, but the level of rarity seemed to have come down. But nevertheless, this patient had a renal cell carcinoma 6 years before she presented again with extensive metastasis. And the interesting point here was that one of the metastatic sites was a gastric polyp, which was mistaken for a adenoma or some other gastric polyp. So we did do some literature search in this case. And of course, before that, we thought we would do some basic IHC to at least tell us that this is of renal origin. And this was not ordered by the clinician or the patient, so we did it out of our own interest. So I selected 2 basic markers. One, of course, was a lot of talk about CA9 was made. We did a CA9 stain, and you can see that the gastric mucosa, the normal mucosa is lighting up, which is expected. And the entire tumor is showing a CA9 positivity, which was a complete membranous staining, as you can see here. So the next question we needed to resolve was this a primary gastric carcinoma, or whether it's a carcinoma which is a clear cell renal cell carcinoma. We did a PAX8 stain, which was slightly faint, no doubt, but clearly the nuclei were positive for PAX8, which helped us establish a diagnosis that this is a metastatic clear cell renal cell carcinoma. And in the given clinical context, I think that was a very strong possibility. We did a literature search, found certain case reports about gastric metastasis from a clear cell carcinoma of the kidney. And there are certain points which were made. Though the commonest sites of metastasis are the lungs and bone, etc., gastric metastasis is rare and signifies an adverse prognostic event. Whether with or without surgical intervention, the survival is not really great, and it typically presents as a polypoid mass in the submucosa. Metastasis can occur, interestingly, even as late as 20 years after the initial diagnosis. Various mechanisms have been postulated, various genetic predispositions have been postulated again, but at this point, when this article was written in 2024, the authors say that they are not really clear about how and why these metastasize to the areas like the stomach. There was another case report in 2021 which analyzed pure gastric metastasis from renal cell carcinomas versus gastric metastasis from renal cell carcinoma associated with other extra distant metastasis. And they clearly showed that pure gastric metastasis from renal cell carcinomas are very rare. 0.1 to 0.2% of gastric carcinomas metastasize exclusively to the stomach. And that may happen even as remotely as 20 to 25, 28 years. In this case, they have found 23 years as the longest period in this paper, after the primary is diagnosed and treated. And this is a list of about 27 publications where gastric metastasis was associated with other distant metastasis. So, very simple messages I would like to convey to most of people who come in work from our environment like mine, is that we need to be prepared for surprises. And the other aspect is, though we would like to be very conservative about use of immunohistochemistry, rightly so, in a given case where even if it means that we stretch our resources to throw in a couple of IHC markers, we could select a few basic markers to help us establish these diagnoses. So, thank you very much.
Hi. Can I make a comment? Hi. Yeah, very nice case study. Thanks for sharing. I think just one caveat in these situations. I think I have also happened to have come across a case like this. So I think, and we haven't published. So thanks again for sharing. I think just one caveat is that pancreatic neuroendocrine tumors can be PAX8 positive. So I think it's just good to just keep that in the differential, and I think you might have also mentioned it. They can be PAX8 positive, especially with the polyclonal antibody, which is used more commonly than the monoclonal. So I think just having some negative neuroendocrine markers might be helpful in these situations. And the second comment was, in discussion with clinical colleagues, what I have come across now is there's a lot of data which is coming out. Some of it has come from Payal Kapoor from UT Southwestern. The CPTEC studies have mentioned as well. I think Sean mentioned there is some utility of BAP1 immunohistochemistry now. So for the first thing is in the TCGA data, other data has shown that BAP1 is very strongly prognostic when BAP1 IHC is lost. It is not perfect for BAP1 mutations, but more than 80% of RCCs with BAP1 mutations will have BAP1 loss. And BAP1 loss is really very prognostic. Even in metastatic state, a patient who has metastases with BAP1 retained compared to BAP1 loss actually has differential prognostic information. Second point related to BAP1 is actually, so is there any therapeutic implications to that? So patients who have BAP1 loss, again based on CPTEC data, other data, they have shown that these tumors tend to be more inflamed and more amenable to immunotherapy. And there's like a lot of data coming out in that space as well. So in my practice, at least when I have a metastatic tumor, I do tend to perform BAP1 immunohistochemistry. In communication with clinical colleagues in different meetings, ASCO, other meetings, in general, clinicians are now suggesting that they would rather know than not know. Is there any direct clinical correlate or therapeutic correlate? Possibly not, but that is one suggestion. Like I would have been curious if this tumor was BAP1 lost or not, but very nice case.
Would a pancreatic neuroendocrine tumor be positive for K9?
I'm sorry?
CA9?
They can be, uncommonly. So CA9 is not CA9 we have to remember is not a tumor lineage marker. It's a VHL perturbation marker. So it's not perfect. And also CA9 has not been interrogated formally in every tumor type in the human body. So we have to just keep some latitude alive. You know, I don't think it's that black and white.
Noted.
Just a comment, it's a very nice case, although in this case the morphology was typical. Just for the maybe trainees in this one, because I see some of GI. So whenever you see foam cells in the GI biopsies, I typically do a cytokeratin. If it is a duodenum, you rule out atypical mycobacteria and Whipple's disease. So just a comment that if you see vacuolated cells in GI, I think it's must to do a cytokeratin.
Yeah. It's quite interesting. Can I make one quick comment regarding BAP1 because Dr. Mehra mentioned about it. So I am at the same center, UT Southwestern, and every clear cell RCC, We do BAP1 immunohistochemical stain. The only thing I would say that the frequency of BAP1 loss is very low in my experience. Less than 10% of tumor would show BAP1 loss. But I think when it is present, it can be very helpful, but if it is intact, it's not going to help you.
That is the exact data from PCB as well, that 10 to 15%. And I think, Raj, that correlates, I think what you're mentioning is directly correlated with the TCGA data that within primary renal neoplasms, 10 to 15% will have BAP1 association. So I think that is the correct frequency. So it is uncommon, but when BAP1 is lost, it's a strong prognosticator.
It's quite interesting. Tertiary center, cancer center do see all the organs. I mean, last 35 years, I've seen except nail and hair, where you will see sort of renal cell carcinoma metastasis even after so many years. Now, the interesting part is, now with the advent of TKIs, we have seen sort of patients who have smaller metastases like this. I mean, they usually melt. And that's very promising because now we are seeing patients, lesion in the scalp, lesion in the nose. In fact, last week we had one patient who had an endobronchial metastasis, and only thing we knew when he coughed out the metastasis, his whole pneumothorax got completely opened up. And this was, is kind of quite interesting scenario. Otherwise, in the past, we had to do sort of, lung resection, gastric resection, and so many other things. Quite interesting.
Yeah, we too as pathologists have stumbled upon undetected renal cell carcinomas which are picked up on FNAs in the lymph nodes or remote sites. I mean, this is something which we all need to be aware of.
And I think you were undone with limited information by the clinicians. I think you would have had a history of renal cell carcinoma.
Yeah. In fact, we had a nasal mass which came as a nasal polyp, sir. Very interesting.
We had
Same
one
thing.
in duodenum.
No primary diagnosis.
I think we are bound to
RCC.
have many cases like these where, so the message here is that we all need to be prepared for these surprises.
So melanoma, sometimes they are mimickers, so you can have these clear cells. So in the nasal mass, it was thought of that. And then it turned out that he had a big mass in the kidney.
We had the one in duodenum, really finding it difficult to make it as a CCRCC. A couple of years back. We will look for BAP1 in that, BAP1 loss.
Yeah, I think that we should be doing.
Just one question for Dr. Mehra and Dr. Shah. Do we need to add BAP1 immunohistochemistry in clear cell RCC on a regular basis? What's your suggestion on that?
Yeah, I think that's a good question, a provocative question. I think several variables are involved, including the resources possible at an institution. BAP1 IHC might not be available in all places. There are also, it's not a perfect marker. There are some antibody variability and interpretation issues. Having said that, at least in my practice, I tend to stain BAP1 on all metastatic renal cell carcinomas. That is unequivocal for me in metastatic space. Primary space is more debatable. So I think at least the current recommendations probably do not support staining a primary tumor. But if there was a primary tumor biopsy and there is already clinical metastases, that might be another indication. But I think this field is growing as we are talking.
Yeah, I kind of essentially agree with what Rohit said. I think, it has primarily a prognostic importance, but there is a diagnostic value of that because it is, if you have a BAP1 loss, it will confirm the clear cell RCC nature of the tumor. But again, intact will not necessarily help you, but overall it has a very important prognostic implication.
Thank you so much. Really interesting cases presented by the speakers, and everybody is intrigued about them. I would request everybody to give a huge round of applause for the amazing session, and request all the chair and the speakers to center the stage for a group photograph.
Thank you so much. Now we proceed towards our next session, which would be 2 talks, and I would like to invite call upon the chairpersons, Dr. Chira Ranjan Khadanga, Dr. Surendra Senapati, Dr. Sanjeev Mishra, Dr. Seema Kaushal, and Dr. Pranati Pradhan. Can I please have you all on the stage? And I invite the first speaker, Dr. Chinmay Pani, to deliver his talk on management of platinum-ineligible advanced bladder cancer. Dr. Pani?
Good noon to all of you and respected chairpersons, esteemed delegates. I have been, so thanks to the organizers, specifically Dr. Saurav and his team for giving me the opportunity to speak about the management of platinum-ineligible advanced bladder cancer. So my overview of talk will be the introductions of platinum eligibility criteria in the bladder cancer, management of cisplatin eligible and platinum ineligible bladder cancer, and future outlook and some of my takeaway. So we all know that there is a high incidences of a burden of the bladder cancers in India. That is around 17th, bladder cancer is about 17th leading cause of cancer in India and 13th leading cause of cancer death in India. We often see the patient in the latter stage in comparison to our western part. The metastatic disease at presentation published by the TMS group is almost 17%. They might be seen locally advanced is almost in 36%, and non-muscle invasive percentage was less in comparison to our western part. So we all know that those who are locally advanced in metastatic bladder cancer have a very poor prognosis. The 5-year survival in the distant metastatic disease is almost very less, that is almost of 7.7%. And the metastatic disease relapse after cystectomy is common. Not that we have done the surgery in the muscle invasive bladder cancer, it will not. Most 50% of patients have relapsed after the surgery has been done, and the post-surgery, the relapse is not local, it's the distant metastasis. So 70 to 90% patient relapse with the distant metastasis. So when we look into the patient's eligibility criteria, the pivotal point we discuss that whether it is cisplatin eligible, cisplatin ineligible, platinum ineligible. So there are 3 domains. So cisplatin eligible is almost 30 to 60%, cisplatin ineligible is 40 to 70, and the platinum ineligible is 6 to 20% of cases. The criteria of the cisplatin ineligibility by the Galsky criteria 2011 is the ECOG performance status 2, creatinine clearance less than 60, peripheral neuropathy more than equal to grade 2, and heart failure, NYHA heart failure class 3, and of course of the hearing loss. But when you come to the platinum ineligibility criteria by the Gupta's criteria published in 2019, the ECOG, there are more poorer performance patients. ECOG more than 3, creatinine clearance less than 30, and peripheral neuropathy. The NYHA heart failure more than equal to 3, and ECOG 2 with the creatinine clearance less than 30. So the platinum ineligible are still more fit. The cisplatin ineligible are fit, but platinum ineligible is still more unfit and more debilitating patient, I can say. So why the platinum eligibility is most important? Why you change to give platinum? That I will tell you the subsequent slide. But out of all patients we try to give platinum, which is 50 to 70, those who are ineligible, out of which 75% we try to give the carboplatin-based regimen, which is a platinum but not the cisplatin, along with the clinical decision-related factors like performance status, renal functions, neuropathy, and age. This is the assembled data from various phase 3 trial that if you use the first-line cisplatin-based therapy, the overall survival is 14 to 15 months. The progression-free survival is 8 to 10, with a response of almost in the range of 55 to 70%. But when you give the cisplatin ineligible, we give carboplatin, which we often give around 75% of cases. The survival reduced to 8 to 9 months, progression-free survival from 8 to 10 to it is 4 to 6, and overall response 30 to 41%. So if we calculate the survival which is poorer in the platinum ineligible patient, that is from 13.3 to 5.1 month. So let us see how we are managing the patient. So coming to this, we have a huge therapeutic landscape from 1965 to 2023. There is an era we focus on chemotherapy. Then cisplatin got approved. Then MVAC, then gemcitabine, gem plus carbo, gem plus cis, the vinflunine. Then followed by the era of the immunotherapy, and where we're giving atezolizumab, pembro, and Nivo. Then comes the era of the ADC. ADC got first approved, and enfortumab got approved in 2019. Then avelumab maintenance got the approval in 2020. Then now we are working on the EV plus pembro ADC along with immunotherapy, and also chemotherapy plus nivolumab, that is gem plus cis plus nivolumab. So coming to the focused landscape, what has been given to me, that how should we treat the cisplatin ineligible patient. So preferred regimen as per the NCCN 2024 access yesterday, that the pembrolizumab plus the enfortumab, that is PEM plus EV, that's category 1 recommendation. Gem plus carbo followed by the avelumab maintenance is category 1 recommendation. Other recommendations are about chemotherapy, gem plus pacli, then single agent pembrolizumab and single agent atezolizumab, those who are the PD-L1 expression high. So I'll be dissecting the data set, and giving justice to the time. But what ESMO said? ESMO said that the treatment name advanced metastatic urothelial cancer, in spite of the platinum eligibility or ineligibility, give enfortumab plus pembrolizumab. If there is disease progression, then go for the platinum-based therapy. If it is not happening due to unavailability, due to cost, due to toxicity, due to the different stratification point, then you try to analyze the patient in cisplatin eligible and ineligible. If it is ineligible, cisplatin or carboplatin eligible, give gem cis or gem carbo. If there is disease progression, go by the pembro or atezolizumab. If it is no disease progression, go by the avelumab maintenance. And then the second line of therapy will be enfortumab, single agent, etrafinib, saxagliptin, and other therapy. So to concrete, picturize the landscape. In cisplatin ineligible, we have the Javelin bladder regimen, gem plus carbo plus avelumab maintenance, and EV plus pembro, that is ADC regimen. In the platinum ineligible, it is atezolizumab or pembrolizumab, EV plus pembro, and non-platinum chemotherapy. So let us dissect the data point one by one. So Javelin 100, they are the first line avelumab maintenance plus best supportive care versus best supportive care. In the selected group of patients, those who are the first line locally advanced metastatic urothelial cancer, those who are CR or PR or stable disease, in the first line of chemotherapy, and that chemotherapy they have given gem plus carbo or gem plus cis. Then they have done a radiological assessment, then they stratify into avelumab maintenance, and every 2 weekly, followed by the best supportive care. The primary endpoint was overall survival. The secondary endpoint was PFS, response, time to response, and the duration of response, disease control, and so forth and so on. So the overall survival was 23.8 versus 15 month. the timeline of 2-year data point is 49.50 versus 38. The 3-year data point is 36 versus 29.8. The PFS is 2.5 month versus median PFS is 2.5 month versus 2.1 month, where the 2-year data point is the 23.4 versus 7.1, and 3-year was 15.9 versus 5.3. So longer follow-up gives better result, but when they try to analyze whether those who have taken GEM-CIS versus GEM-CARBO, is there any difference or not? So those who are in the GEM-CIS, they do little bit better. The median survival was 25.1 versus 17.5. So also the PFS was 5.7 versus 2. And when they given the carboplatin, the survival is 20.8 versus 13, which is statistically significant. And so also the PFS is statistically significant, that is 3.7 versus 2. So survival benefit is irrespective of those who are cisplatin eligible and those who are cisplatin ineligible. And to figure it out, almost 40% of patients could not be able to take cisplatin, they took carboplatin. So this is the survival from the start of the first line the platinum based therapy, and the survival was high in terms of 29.7 versus 25.8, and the updated data is also coming up in a bigger way. So one data point that we stratify. The second one is the ADC plus IO regimen, that is EV plus Pembro by the EV302 and Keynote A39 study. The patient population was previously untreated patient and eligible for platinum, and immunotherapy naive patient, those who are GFR of more than 30. They give EV plus Pembro. The EV, how many gives have not been mentioned. You can give till the toxicity and till the response is there. The pembrolizumab will give up to 3 years, maximum up to 35 cycle versus the chemotherapy. And the chemotherapy you can use cis and cisplatin or carboplatin. And the primary endpoint was PFS and overall survival. Secondary endpoint was overall response and safety. So those who received the progression-free survival was 12.5 versus 6.3, almost double. The hazard ratio was 0.45. The 1-year time point, that is 50.7 versus 21.6. And the 1.5-year time point, the survival PFS is 43 versus 11.7. The OS, median OS was 31.5 versus 16.1 with a hazard ratio of 0.47. And the risk of death is reduced by 53% of the patient who received EV plus pembrolizumab. So when they analyzed the cisplatin eligibility in the OS subgroup analysis, which was a part of the study, assessment study, so those who are cisplatin eligible, their hazard ratio is 0.53, but those who are cisplatin ineligible, the hazard ratio was 0.43, and the median survival in the cisplatin ineligible group was not recordable versus 12.7. So irrespective of the cisplatin eligible or cisplatin ineligible, both does have the excellent response. Not only the OS and PFS, but also the overall response of 44 to 67%. But the complete response is almost double, 12.5 to 29.1. And so improvement in the objective response, and so also the complete response and the partial response. This subgroup analysis of the OS in the pre-specified subgroup, if you look into the last but lower line, the cisplatin eligibility, both in eligible and the ineligible, it favors EV plus Pembro. Though in the specified protocol, in the ADC group, there is a high adverse effect. The serious adverse event in the EV plus Pembro is around 28% versus in the chemotherapy, it is about 19%. The number of deaths is both arm is 4, though the causes of death are different in the EV plus Pembro. There's a typical, the complications like peripheral neuropathy, asthenia, diarrhea, immune-related lung disease, and multiple organ dysfunction, whereas in chemotherapy, it is the febrile neutropenia, myocardial infarction, neutropenic sepsis, and sepsis itself. So that is why the enfortumab vedotin plus pembrolizumab is given the score 4 by the ESMO MCBS scoring system. Then questions about whether it is Can we give only EV or EV plus Pembro? Though it is a very small study, the cohort K of the EV103, which is phase 1B to phase 2 study, in the cisplatin ineligible group, previously untreated with any therapy, so EV monotherapy vis-a-vis EV plus Pembro, they have seen the response was improved from 45 to 64%, and there is a doubling of the overall the CR and also the PR. Almost CR is double, 4.1 versus the 10.5. So best overall response is increase in this true, and irrespective of the PD-L1 status, the waterfall plot shows the anti-tumor activity irrespective of the high PD-L1, low PD-L1, no PD-L1 available. And the progression-based survival almost in the range of 8 months, and the overall survival is almost in the range of 22 months, which is good. But they have relatively high incidence of peripheral neuropathy and hyperglycemia, and so the patient who are having severe neuropathy or diabetic, and this is very difficult to give such kind of therapy to this patient. So come to the single agent pembrolizumab. The approval is for the patient with a locally advanced metastatic urothelial cancer, not eligible for the platinum-containing chemotherapy as a single agent. This is from the Keynote 052 study, and almost 370 patients locally advanced in metastatic urothelial cancer who had one or more comorbidity and not eligible for the platinum-containing therapy. So this is a single-arm study. So the response is 30%, complete response is 10%, partial response is 20%. The median, the duration of response is 33.4 months. The overall survival at the 2-year data point is 31 versus the 3-year data point is 22.1. It's a very small study, nothing much to say. In the atezolizumab, also approved for the, first got approved in 2016, tumors who express PD-L1 who are not eligible for the platinum-containing chemotherapy regardless of the PD-L1 expression. So this based on 2 trials. The first trial is the phase 2 IMvigor 210, atezolizumab first-line treatment in cisplatin ineligible patient with locally advanced metastatic urothelial cancer. It is a singular multicenter phase 2 trial. Previously the treatment name and the cisplatin ineligibility based upon the more than one of the impaired renal function, grade 2 hearing loss and grade 2 neuropathy. What you do in the clinical practice, they have given atezolizumab only and till the progressive disease. The primary endpoint was overall response. The secondary endpoint was PFS, duration of response, overall response, and other thing. So the overall response was 24 and complete response was 8%. Median, the duration of response was not reached. The 1-year data set point was 58%. 2-year OS is 41 point, and median overall survival was 16.3 months. So the OS has increased when in the longer follow-up. Initially it was 14.8 and later on it was 16.3. So when they try to analyze the efficacy in elderly, which is one of the concern because it happens in the elderly individuals. So more than 75 and less than 75, the responses are same, around 16 to 20%, so response is good, and it is irrespective of the PD-L1, whether it is low or or it is IC 0 to 1 or IC 2 to 3. So in the both category, the responses was unique in that of the low age group and the higher age group. So this is IMvigor 130 study, where it published in the GU23, discussed in the GU23 in the ASCO Genitourinary Cancer Symposium. Final overall survival analysis of atezolizumab monotherapy versus chemotherapy in untreated locally advanced metastatic urothelial cancer. The treatment, the study design is a little bit complex. Locally advanced men metastatic urothelial cancer, no therapy, performance status of 0 to 2, platinum ineligible. They have randomized to 3 arms. Arm A is the chemotherapy with atezolizumab. Arm B is atezolizumab monotherapy. Arm C is chemotherapy with placebo. Our focus of intention was B versus C, not the other. So I am focusing on the arm B versus arm C. And which was, though the survival was, the statistical analysis was not in a part of arm B and arm C. So OS was a co-primary endpoint to do an OS analysis of arm B and arm C in the intent to treat populations. And in the stratification factor, they have mentioned the investigator choice of platinum. So finally, they analyze, the explorative analysis, they analyze the subgroup analysis outcome in patients, those who are platinum eligible versus the platinum ineligible. So the final OS analysis in the intent to treat population, there is no difference between atezolizumab versus the atezolizumab plus chemotherapy. Number one. Number two, when they try to analyze the PD-L1 0 to 1, IC 0 to 1 versus PD-L1 IC 2 to 3, the difference hazard ratio is 0.67, which is statistically significant, and the OS in the arm B, means only pembrolizumab, is 27.5 versus the 16.7. And the OS in the cisplatin ineligible population with the PD-L1 IC2 to 3, it is more distinct, that is 18.6 versus 10 month with a hazard ratio of 0.6, which is statistically significant, but not in the PD-L1 group IC0 to IC1. So in the cisplatin ineligible with PD-L1 positive, it is showing positive. It is showing the positive data point, and this is irrespective of the cisplatin eligible only by the PD-L1 high and PD-L1 low. So, these are the various data points. I'll show my data later on. So why there is still an unmet need to integrate various other molecular markers into the system, and the first line specifically in the cisplatin ineligible group. So additions of the pembrolizumab along with the FGFR receptors inhibitors, the combinations of the immunotherapy along with the FGFR receptors, and many trials are on to, and there are still in recruitment. Some trials have been completed and waiting for the final approval to come. So while we take a decision making, we have to look into the many things into the picture. What is the efficacy profile? What is the safety and tolerability? What is the patient preferences? What the guideline says? What is the level of evidences? As the access to the drug and cost, quality of life, durations of treatment, and what is the probable sequencing, how do you treat the patient later on. So best treatment, and to individualize treatment, you have to see the patient fitting criteria into the what eligibility criteria, do a shared decision making, and check out the available first line options available, along with shared decision making with the patient to find out the conclusive what will best and suitable for the patient. So to conclude, patients with platinum ineligible bladder cancer had a poorer outcome. Eligibility criteria assists us to deliver the appropriate therapy for our patient. Majority of the cisplatin ineligible patient will be carboplatin eligible, almost 75%. Only 6 to 20% of bladder cancer will be platinum ineligible, which we offer to give either single agent pembro or single agent atezolizumab. Though we have a large experience on JB100, Javelin Bladder 100, which can be leveraged to deliver avalumab maintenance to patients who are cisplatin ineligible, but receive the carboplatin-based therapy. And though the data of EV plus pembro is upcoming in a much bigger way, but accessibility and cost is an issue, particularly in India, what we face in practice. And still for them, pembro with atezo would be a good and viable option. Thank you very much.
Thank you. Thank you for that wonderful talk, Dr. Pani. Any questions?
So,
that was a lovely talk. So just for the simplification of the audience, how do you treat your patient who is platinum ineligible in your clinic? So
yes.
Just for simplification.
So if we fit into the criteria of the platinum eligibility, then we see the performance status is good. Then whether first thing is cisplatin eligible or not. If it is not eligible, then see for the carboplatin eligibility. If anyhow the carboplatin is not eligible, means poor performance status, elderly, where you don't intend to give chemotherapy, in that, which is also coming to 6 to 10%, maybe 20% of cases, because we see more of advanced cases. To them, we leave them for the atezolizumab or pembrolizumab. Those who are carboplatin eligible, because of the availability and accessibility to the EV plus pembrolizumab is a little bit tricky. So we try to give GEM plus carboplatin followed by the available maintenance as for to date. And I think the approval will come and availability will be much sooner. So probably we can use later on EV plus Pembro or EV is in the second line therapy if you can use now first line Gem plus Carbo along with available maintenance.
So would there be any platinum ineligible, I mean both cis as well as carbo, in which you would be using EV Pembro?
Yes. Around, if you see the data of the V302, almost 45% of patients are actually platinum ineligible, and so in the both group, in the both the V plus Pembro group and also in the chemotherapy arm, so they are platinum ineligible. So I think if the general condition is good, fitness is fine, and availability of the drug is there, in that group of patient also we can give you plus Pembro.
Thank you.
Dr. Chenmay,
One question.
this side. Excellent talk. So another question, what level of GFR do you consider as, I think, was it discussed earlier? Sorry if I missed that. But do you consider 50, 40, 30 of lately and with PS?
So please. So I've shown in the first slide as per the two different criteria.
But in your practice, I mean, there are now trials where they have taken up to even 40.
True.
Classically was 60 and then we came down to 50.
So
and
classically we
40.
were initially taken into, initially we were taking up to 60, but later on we are also okay in 50. But the carboplatin data, what they say, it should be more than 30.
No, for cisplatin.
For cisplatin, you can give reduced dose, I think up to 40 to 45. That is, I'm confident enough.
So does it change when it is kind of neoadjuvant approach? Does your level of GFR change, or metastatic setting, is it kind of different level at which you think cisplatin eligibility, about the cisplatin eligibility?
True. We are more obsessed in giving the Gem plus cis specifically in the neoadjuvant setting because we know that Gem plus Carbo has not an equal response than that of Gem plus cis. So in that setting, we are more lenient and more aggressive about the giving. We try to give the reduced dose and try to find it out and see the optimal response in the patient, rather than fixing to the data set whether it is 60 or 30 or 40. So we have to optimize that.
So wonderful.
Question from the chair.
Yeah, 1 second. Can I ask one question?
Can pembrolizumab used as a concurrent medication during the radical radiotherapy in cisplatin ineligible? Is there any data toxicity?
Not aware. So sir is asking whether concurrent chemoradiotherapy in cisplatin ineligible utilizations of pembrolizumab with RT.
No, you may use gemcitabine. Gemcitabine, we have data for gemcitabine.
No, sir. He is asking utilizations of pembrolizumab with RT concurrent.
No.
The only thing is that whether with the Niagara trial, are we really comfortable giving cisplatin at the more than 40? So in a day-to-day setting, at least I have to think twice for considering giving cisplatin in a...
But sir, till 50, I think
50
we all
is
are
okay.
giving,
Everyone is okay.
So
But
below
35,
50,
will you be comfortable giving cisplatin? Whatever the data says, but when the patient is in front of you, I don't think so that anybody has courage. Until unless very young patient, some obstructive component, it is okay that it may improve with the chemotherapy. But for a 70-year patient with critical 35, giving cisplatin, I don't think so that...
I don't think so. So, but the carboplatin eligibility criteria is GFR 30, so that we can
But
change.
neoadjuvant, we generally it's better to go for upfront surgery and then give them whatever adjuvant possible.
There was a concept of dose reduction in cisplatin.
Yes.
So does it apply here?
Yes. So he's asking regarding the reduced dose of cisplatin. So I
So
told
day
you
one day it is already used, 35, the split dosing.
Yeah. We can do the split dosing and we can do the reduced dosing if the GFR is almost around 50, I can say.
I think 50 to 60 we are still comfortable, but 40 to 50 in high volume centers, it is very difficult to treat because the kind of patients that come have a poor PS rather than if it's 0-1 PS with probably 45 and above, very, very cautiously. 40 to 45 would be really, really tough. I mean,
even if you have to admit the patient, good hydration, every third day creatinine monitoring, but you just can't give in OPD basis. You have to admit the patient and carefully monitor and should not be out of your radar. So that is the only thing.
Any role of N-acetylcysteine to reverse this? No.
And I don't think so that anybody uses the anaesthetic. I think practically it's not possible.
These are usually older patients as well. I mean, usually in their 60s and 70s, and poor PS. So PS is another important, very, very important component for considering cisplatin eligibility apart from GFR. And I mean, once cisplatin toxicity happens, it's a nightmare for any medical oncologist.
Okay. Thank you. The clarification that radiation with the IO is in phase 2 trial. And one clarification, in your practice, there are so many IOs. So which one you like to opt for? And do you also subject this patient for the CPS score?
Sir, that's a bigger debate. I have not included into the data point. The pembrolizumab, the approval is irrespective of the PD-L1. The atezolizumab approval was the TC score that for immunocell, and they have used SP142, and immunocell has been calculated, not the tumor cell, and the cutoff point was 5%. So in that way, you need to send it. For available data point from the JB100, so there is no requirement of doing the PD-L1 status. So as for the data point, if you look into, the JV100 has a more robust data, and the survival is 29.4 if you look into the first starting from the platinum-based therapy till the survival. So that could be the preferable option along with gem carbo followed by the avelumab maintenance, those who are PR or CR or in stable disease. In the IMvigor atezolizumab study, recently the FDA have given a notice to limit the use till the PD-L1 value is more than 5%. So pembrolizumab is really, if you...
Why even consider atezo if we have other options?
Yes, that I'm sorry, asking how do you
we have
optimize it?
data for Nivo, Pembro.
True, sir.
Thank you so much. I request Dr. Pani to please be seated for the photo session following the next talk. Can I please call upon our next speaker, Dr. Matthew O'Levin. He will speak about key role of urology, a key role urology is playing in defining pathology's digital future. Over to you.
Is it possible to get the notes? Let's see here. Oh, if it's possible.
Notes access.
It's okay. It's okay. Yeah. Okay. It's an honor to be here, being able to speak with you. This is my first time in this part of India, in Odisha. I love India. I love the history and the rich and diversity of cultures, and the deep spiritual roots that I've found here. And so it's just been a pleasure. And I'd like to just thank the organizers of this conference for the good work that you've done and giving me this opportunity. This is going to be a little bit of a different kind of talk. I'm a pathologist by training, but for the last 10 years I've spent somewhat in an odyssey, and as I've tried to do some pioneering in the world of digital pathology. So this will feel a little different. It'll feel a little more like a story. Right before lunch, that's not a bad thing. As a pathologist, talking to non-pathologists often, I'm very sensitive about putting people to sleep. It actually happened again on the plane here, flying somewhere over the Middle East. The gentleman next to me asked me what I do, and I got really excited and animated, and I started showing him digital pathology, and the next thing I knew, he was literally sleeping, almost falling on me, and I thought, oh man, that's not a good sign. So my goal is not to do that here today. I practiced at a large urban medical center
after I trained at Stanford, had some very good training. Some folks here I remember from my time there. And I went to a large urban medical center and took all that great training, but that's not where I grew up. I grew up in this place. And those of you from Odisha maybe understand the pride one feels going back to the place that you're from. It's southern Utah is where I grew up, and my parents were in a town that was probably about 80 kilometers from the nearest doctor, let alone pathologist. And so practicing in the urban setting that I was in made me very sensitive about the disparity in the level of care that I was able to provide and what the people in the places where I came from were able to access. And I saw digital pathology as one way to be able to level the playing field. And so I started on this journey. That was about 2012 when I was sitting in the doctor's lounge with my colleague, and we came up with this idea that we wanted to go digital. And back then, we thought this is what digital looked like. We went out and we convinced our wives, both of us, to go out and buy a whole slide imaging system. That's like taking a mortgage out on a house. It was a big risk, and we successfully convinced our understanding wives that this was a good idea. And we placed it in a remote setting and we had a really naive business plan that was never going to work. But we were so excited. We cross-validated the whole slide imaging with the slides in 2013. And we thought, okay, we're practicing digital pathology, we're up and running. And it was only a few months that we found ourselves looking at our microscopes again. There was dust gathering on the whole slide imaging system. We had successfully gone out and recruited, as it turns out, a bunch of urology clinics to join this with us. So we were successful at being able to get the urologists to buy into working with us because the idea was, hey, you can get world-class pathology, even in a place where you don't have access to subspecialists. And so we were very successful at being able to get the specimens to flow, but we found that it was just so much faster to look at the slides in our microscopes, and it was just impractical. And I think many of you maybe have experienced that as you've tried to practice digitally. And it was a frustrating moment when we realized, why did we just convince our wives to do this? And I remember sitting in the doctor's lounge with him, and we said, why isn't this working? And we realized that we were still working with a pre-analytic workflow and a diagnostic workflow that was built for microscopes, not for computers. And we asked ourselves one important question, which was, if you could redesign the workflow in the histology lab and the way we operate as pathologists, just reimagine it, what would that look like? And started off on the back of napkins, and it led to this odyssey. So, we purchased the scanner in 2013. We got with some engineers and people much smarter than we are technically. By 2015, we were in deep enough that we actually partnered with a Romanian histotechnology company because we realized that it was really important to standardize pre-analytics. Anyway, by 2025 now, we actually have created a platform. We created a network of digital pathologists, and now over 3 million diagnoses have been rendered on that platform in the United States. At a time when, in the United States, digital pathology has stumbled, as Mehul mentioned, the regulatory framework is really, while you'd think the United States would be all over it. It's been very difficult for digital pathology to gain traction, but by the end of 2025, we're on track to have about 20% of all prostate and bladder biopsies in the United States flowing through this platform. So it's been remarkable growth from in a place that you would not expect it. It's one of the interesting insights that we gained is that most cancer patients are actually not in the large centers. Most cancer patients are being treated locally, especially in urological cancers, prostate cancer. And so being able to really move the needle in community practices, in practices that are not typically where you'd think you'd be getting the highest, most advanced standard of diagnostic care, that's been quite fulfilling. One of the secrets to this success has been thinking about pre-analytic standardization. This is where the pathologists get excited and the non-pathologists start to fall asleep. So I'm going to try to make pre-analytic standardization in the histology lab really exciting for oncologists. I'm just kidding. But it is different than what you've ever seen. We were thoughtful about this, and one of the things I like about this conference is that it is multidisciplinary. This is Rafael Jimenez from Mayo Clinic, and Ash Ross, who at the time was at Hopkins, and Adam Cole, who's a community practicing pathologist, and I forget the radiologist's name, but he was at Mayo Clinic. This is in southern Utah, where we got together and said, okay, how would we reimagine this? And it led to some interesting things. Formalin jars. It's a staple, but it wreaks havoc on our tissue when it sits in a formalin jar for variable amounts of time, and it now suddenly makes all of your IHC or molecular stains very difficult to interpret, especially if it's quantitative because of the masking of the antigens. And so we focused on, okay, if we're going to rethink this, let's make the tissue preservation better, more reliable, and let's do it in a way that we can actually get adoption. So we developed what is called the biopsy board. I can go into the technical parts of that if you really want to, just come talk to me. But formalin jar, so we did some initial data. When we first validated this, we just wanted to make sure that it looked as good under the microscope, and that's a pretty low bar in the way that we do things in the United States. It comes down to a pathologist saying, yeah, it looks the same, I can't tell the difference. But the molecular changes due to formalin are actually much more subtle and actually much more drastic and important in terms of ancillary testing. So the first 6 months or so, we checked very closely with molecular companies. This was from Myriad Genetics. It turns out they were seeing lots of cancellations due to poor preservation of RNA. When we switched to the biopsy board, the rate of RNA preservation problems went down tremendously, and so to less than a third of what it was before. We also started to see less variation in the IHC stains, the PIN4s, and the things that we were ordering. So the nice thing is what was easier in the clinic and more appealing because they didn't have to label all these bottles also turned into something that was better quality. And what that led to was adoption. So we were able to change something that was a problem in the lab by thinking about just convenience and ease in the clinic. Lab workflow, grossing is a pain, but it's so important to high quality. And in a world where we have AI that can recognize people's faces, it's not that hard to recognize and measure tissue. And so we created an AI-based grossing system that instantly measures the tissues and correlates the gross that's in the clinic with puts it directly into the lab report. Lots of implications for this that we didn't fully appreciate when we were doing it. But then there's the biopsy chip. I actually skipped this. So up in the top right, standardizing the embedding of tissues. This biopsy chip holds 6 cores shows the sites, maintains the orientation, and therefore, instead of having 12 slides, you now have 6 slides. You have 2 slides with 6 cores on them, and you know which core is which, and you have the orientation. You pair that now with the AI, and it's amazing what can be done. So we automate that grossing process. And so this is a complete expansion of what digital pathology, what we think about. Digital pathology, just like pathology, is not just about reading and slides and recognizing patterns. Pathology is about taking care of taking care of patients and helping them through something that a part of their health care, a part of their cancer care that they really can't do without us. And it's much more than just recognizing patterns. It's about the whole process. So digital pathology is actually not just about looking at whole slide images. Digital pathology is about using digital tools and technologies to improve that entire process, the entire workflow for pathology. And when you do that, it's amazing what happens. Now, I don't know if you can, on the computer down there, can you push this, make this video go? Usually I have to click on it, but if I just push play, it doesn't play. If it doesn't go, we'll just, if you want to see how the workflow works, how the pathology signs out their cases, just come talk to me and I can show you. Otherwise, yeah, it's okay. Yeah, it's a technical problem, but if you're interested, that's great. If you're not interested, you don't have to watch a pathologist sign out cases on a video. If you are interested, just come talk to me, and I'll show you how it's done. One of the key things in making digital work efficiently is integration. So we were able to integrate not only with the lab information systems and different things upstream, but then there's all the molecular testing and the ability to be able to order molecular tests downstream. That makes a huge difference in terms of being able to actually get those molecular tests ordered. In the United States, and I suspect it's true everywhere, we have all these amazing new ancillary tests that can target therapies, but most of the time, if you're not in one of the big academic centers, those tests don't get ordered, unless it's somebody who's fresh out of training and at the cutting edge. Oftentimes, when you're out in the community practice, the latest and greatest doesn't get to the end of the line. The cool thing about being able to manage this remotely is we're able to much more effectively get those molecular tests ordered, because the urologists have a menu of tests, and they're like, oh, what is this test? And we can actually suggest tests that enable us to really get the molecular testing that drives so much of precision medicine all the way out to the community-based practitioners. So as I was saying, digital pathology is a lot more than just reading a slide on a computer. Digital pathology is about using IT infrastructure and the cloud to be able to manage patient specimens, manage the ordering of ancillary tests, connect consultants. It really is so much more than I think what we think about. And what it has done is it's enabled us to create different practice models. This describes that ancillary test ordering system where we have a digital hub that has all of the blocks. Now any clinic that orders it that's part of that digital hub, we can manage their molecular test send-outs, which has really driven the growth of this. As the molecular testing companies have recognized this, they're the first ones to say, hey, you really should go digital, which has really helped grow our practice. Now, the crazy thing is that the largest, most advanced, and let's face it, the most endowed with cash medical centers, most of them are not digital. How does this little startup in the middle of nowhere in Utah grow quickly to have 20% of the urology market? And it's because digital changes the business model. And I think this applies not just in rural America. I think this is a global, globally scalable model, one that could easily be deployed by someone in India who sees this and wants to seize the moment. The idea is that when new technology comes in and it's not accessible because of cost, which is true for whole slide imaging systems and digital pathology in general, then it requires people to collaborate. And so what we did is we found a lot of small labs that had no business buying a whole slide imaging system and said, let's consolidate the histology, share in that in a cooperative way, like in the same way that farmers do in cooperatives, and we'll all be better off together. And so we created what's called a digital histology co-op. And there's a whole business model with that, which is beyond what we'll have time to talk about. But if you're interested in that, I'm happy to talk to you about it later. By aggregating many small, and I'll be honest with you, poor quality labs into one advanced, high quality, state-of-the-art lab, suddenly we had standardization. In rural America, you had pathologists literally going around in motorhomes, RVs, going from lab to lab, reading slides because they were making slides in very poor quality labs. And it was a terrible practice model. And so by doing this, we had better quality pathology, and the data now is standardized. It's aggregated in the same place. We don't own the data as a company. It's owned by the labs that are part of that cooperative. But now the data is all standardized, and the ability to be able to use that for the benefit of the patients and for clinical trial enrollment is really quite exciting. I now have started a nonprofit foundation called the Digital Diagnostic Foundation, and this is deploying this model not just in a commercial practice, which is where we learned the model. We're trying to democratize that, and not only doing it in the United States, but our hope is to be able to create standardization everywhere. And so, again, if you'd like to talk about this, I'd love to talk to you, and some folks here from Lumea will too. In the end, we're all just trying to make this better for the patient. This is my punchline here at the end of this. In a world, and I said this in Mehul's talk, in a changing world, you've got three choices. You can resist and you'll lose. You'll watchfully wait and maybe you'll persist. But if you'll lead, you have a chance to really prosper and make a difference. And I hope that that there are folks here that want to take the latter. So thank you very much.
Thank you. Thank you for that wonderful talk. Nice perspectives for the future. There's a slight change before we break for lunch. So can you please ask you to sit on the
Yeah, can
Any
I
question? Yeah.
just met, I think, very inspirational presentation, and I, of course, have known you for a long time, and you have done amazing work. I think my one question is that I think in big academic centers like where I am working, the ecosystem, which I think is very important eventually for a digital pathology to become a standardized platform. And I still don't see that. I think like you have a product for small prostate labs or like individual, and I think that where you think, I think we will be able to create that type of ecosystem, which I can, like from renal tumors to prostatic biopsies to bladder, I can say more seamlessly work in that type of platform.
Yeah, that's a great question. And I will be the first to admit that these are different ecosystems. And my statement about large health systems being slow to adopt is not a criticism, it's just a reality that it's hard because it's a complex system. My impression is that one of the ways not to do it is to try to change it all at once and then have, and one day you're everyone's using microscopes, and the next day everyone's signing out digitally. That doesn't seem realistic to me. There's so much more to it than where you're looking at the slide. And people that have tried to do it all at once, I think get overwhelmed, and it becomes difficult to actually make progress. I think one of the points of my talk was, by focusing on one field, one type of cancer, we were able to do this very well and broadly, and now the goal is, okay, let's now replicate, this worked. Let's now replicate this specialty by specialty. And so whether that's going to be true for the large centers doing it that way, or whether it's going to go another way, I don't know. But that's how we were able to make some traction that way.
Thank you. Thank you so much. So before we break for lunch, we have a next talk by Dr. Atul Batra. He would speak about paradigm shift in management of muscle-invasive bladder cancer. After this session. Yeah. We'll have a group picture after this session. So, yeah. Thank you. Sorry? Yeah, of course, yeah.
So, thank you. Thank you first of all for inviting me here and giving an opportunity to talk about this paradigm shift in the management of muscle-invasive bladder cancer. And I'm the last man standing between you and the lunch, so I'll quickly complete this. So after decades of treatment with cisplatin-based chemotherapy, we have now seen that over the last few years, there have been a growing interest in the change in the management of bladder cancer. We have seen how immunotherapy has come in. We are seeing pembrolizumab, avelumab, nivolumab, and now with the antibody drug conjugate, enfortumab vedotin, now we have another drug which is quite effective, and we are seeing that this is now shifting from the discussion between gemcitabine cisplatin versus carboplatin, Gemcis versus MVAC, into now changing the whole management of bladder cancer. So this is quite interesting, and we'll see a lot of developments that would happen in the next 5 to 10 years. So this would have been discussed earlier. We're seeing that with the muscle invasion, the prognosis of bladder cancer does decrease, and we are seeing that the number of cases are increasing. We are seeing a lot more patients in their older age, and as the tumor progresses, the outcomes get worse. So basically, these are the 3 modalities that are involved in bladder cancer or any other tumor: surgery, radiotherapy, and chemotherapy. And the focus of today's talk would be predominantly on systemic therapy rather than just chemotherapy, and how this has changed over the years. Typically, this is how bladder cancer has been managed, that we look at the muscle-invasive bladder cancer, and then we advise neoadjuvant chemotherapy in fit patients. Most of the patients still don't get it. Most of the patients would get a cystectomy done if operable, and then get a referral for chemotherapy, where we do offer them adjuvant chemotherapy if that was not given, and if it is T3 and above. But however, if the patient was to be discussed in a multidisciplinary team, all muscle-invasive cancers would be offered neoadjuvant chemotherapy if they are cisplatin eligible. And the definition of cisplatin eligibility is also evolving with time, from 60 to 50 to 40, as we were just discussing. So overall, we are now also seeing that there's now bladder conservation protocols that are also coming into picture, where we are discussing about long-term follow-ups being somewhat similar numerically.
Every time your pathologist has to report for that one and again. So these kind of things, if it is sustainable, then definitely give an option.
Fine. So now there is no ego. So let us listen from experts.
One point I would say, sir. One point I will make. Exactly the same point I wanted to tell in my last slide, that the bladder preservation is not for all. Bladder preservation is for, first, the patient should be suitable for bladder preservation.
Yeah,
second,
in last slide you have already surrendered.
Yes, sir.
So let us listen from, yeah.
Nice presentation. Someone actually just elaborate, what is your clinical practice in Apollo Vizag? How you are proceeding in this case of muscle-invasive bladder cancer, number 1. And regarding, just elaborate about the toxicity profile, radiation site and surgical site.
Firstly, it is very difficult to get the maximal TURBT in our practical problem that we see. the urologists don't give us with maximal TURBT. That is a first and foremost issue that we commonly face. At our place, yes, we have the multidisciplinary tumor board. We do bladder preservation approach, and again, the issue of having regular cystoscopy, etc., that is done. And I do agree that there are certain patients who do miss out. They don't come for the checkup at the right time. So that does happen. Toxicity profile is not an issue. They are very well
with the
controlled.
latest technology. Yeah, let us listen to experts.
One more thing to answer his question is that nowadays you are having plenty of PET scan there. Now every time the patient is coming, whether you rely on your surgeons, he is a radiation oncologist. Now how much it has been regarded, he is not going to do a cystoscopy. Now the best thing is that, okay, do a PET scan.
No, this is not the standard of care.
It is,
PET is not the standard of care.
What I'm talking, it's not a standard.
Post-radiation setting.
It's not a standard. What I'm talking about, that's what we are talking about over here. It's not the theoretical things which you are talking.
Yeah, let us listen from the experts.
I think I'll start with my comment that both of you actually deliberated so well that I'm really confused. Both are, like Sunil should not feel that I'm biased towards Suman, but the point is, as sir also pointed out.
Because you are a radiation oncologist.
No, I don't want to keep that bias here.
So you should be very neutral. Huh?
Both are correct, because patient selection is the most important thing. Patient's wish, the age, how many times patient has recurred. All these strict criteria are to be followed if you are going for a bladder preservation. And believe me, as a surgeon, you might have faced many times that when you create a new bladder or give him an option of non-natural bladder, patients do have problem with their quality of life. That is undeniable. And PET-CT, as of now, is not indicated for bladder tumors. That is out. I will draw your attention towards another area. What is the cause of bladder cancer? 50% of them are caused by smoking. So why not focus at the preventive part and get the incidences down so that we have less, chances of having bladder cancer, stricter smoking laws and all. They will probably be better to reduce the incidence of the disease. And with the expertise of surgeons and radiation, probably we are now in an era where we can do much better surgeries, much better cystectomy with lesser side effects, and much better radiation with lesser side effects. But both have their plus and minus, and nothing can be replaced. They are like two sides of a coin. So this fight will go on, but ultimately patient benefit, what is the wish of the patient, how much money they are going to spend, and what is, basically you can do a robotic surgery, but what is the cost of robotic surgery, Sunil? It costs above 7.5 lakhs in the best centers. So is it affordable for some patient? No. So then it has to be a compromise between what the patient can afford, what the patient can want, what is your expertise in your own setup. And the one criteria that you said that radiation oncologists are always going for PET-CT. I would say that, okay, fine. But very nicely it has been put in somewhere, bladder preservation protocol, that whatever is visibly completely excisable tumor should be taken off for bladder conservation. So that criteria is already fitted in to probably shield the surgical colleagues that we don't go for something which is not completely curable with surgery. I mean, not completely to be taken out with surgery. So that criteria is already written down. So that is probably something which I cannot say as a non-surgeon, but that criteria is already there. The visibly it should be looking like that it can be completely taken out. That's there in the criteria for bladder preservation. So already the criteria is a little biased. But anyway, I think both have their places and both would have their importances in management of bladder cancer.
I have one question. So many experts, I would ask whether, apart from the muscle invasion, whether any histological subtyping decides on your,
yes, absolutely.
It will make changes in your decision making.
I specifically mentioned that in the slide that it is urothelial cancer, all the which is more responsive. So non-urothelial cancers should not be tried for bladder preservation because of the lack of data.
Some histologic variants are very aggressive by nature, like micropapillary variant, like plasmacytoid, like rhabdoid variant and sarcomatoid variant. Even if it is T1 disease, that should be amenable to radical cystectomy.
Even clear cell type.
Yes, clear cell type.
Thank you so much for the wonderful debate. And thank you so much for the debaters, for the expert opinion and the chairpersons. I would like to request everybody to come center stage for a group photograph, please. A big round of applause for everybody post-lunch first session.
Thank you. Thank you so much. Oh, it's okay. So we now quickly proceed towards our next session. That will be a panel discussion. And I would like to call upon the moderator, Dr. Dipti Rani Samanta. Can I please invite the chairperson, Dr. Deepak Rautrai, on the stage, please? While I call the panelists, Dr. Soumya Panda, Dr. Atul Batra, Dr. Jogmaya Patnaik, Dr. Seema Kaushal, Dr. Samrendra Dash, Dr. Sandeep Parekh, Dr. Sailesh Soni, Dr. Ganesh Subudhi, and Dr. Prashant Das. Thank you. Over to you, ma'am.
I think that is better. Some person may go to that side because it will be equal.
As many as could be accommodated on the other side.
And it will be easier to see you also. Yeah. Yeah. Atul can go to that side also. Better to have. Good afternoon, ladies and gentlemen. Now we are going to start the session. Respected chairperson, you are going to start the session. That is a panel discussion on neoadjuvant and adjuvant strategies in bladder cancer. Our esteemed panelist, Dr. Soumya Panda, Dr. Prashant Das, Dr. Seema Kaushal, Dr. Atul Batra, Dr. Sailesh Soni, Dr. Samrendra Das, Dr. Jogmaya Patnaik, Dr. Ganesh Subudhi, Dr. Rajiv Saini, Dr. Sandeep Kumar Barik. I think we are having 5 medical oncologists and only 1 surgical oncologist and 2 pathologists. Seema? I think Dr. Seema Kaushal is not. She is not there. Okay. Okay, I think all the questions may go to Dr. Sailesh as only 1 pathologist is here. Yeah, just we are going to start. This is one patient, 62-year male, clinically presented with painless hematuria for 2 months, increased urinary frequency and mild dysuria for 2 months. He was a known hypertensive. Physical examination was unremarkable with no palpable abdominal masses or suprapubic tenderness. Of course, rectal examination reveals grade 1 prostatomegaly. Dr. Prashant, being a surgical oncologist, how to proceed in this patient?
For this patient, I would get a urinary cytology done, and along with it, imaging of the urinary tract, which can be in the form of a CT urography and a CT abdomen pelvis, and office histoscopy to see for any lesions are there or not.
Okay. And laboratory test we did, that is the complete blood count normal, renal function test normal, liver function test normal, urine cytology reveals positive for malignant cells. Imaging studies we can see here, ultrasound abdomen and pelvis, there is a mass lesion at the posterior wall of the urinary bladder as well as the dome without any back pressure changes. CT urogram informs us regarding the thickened bladder wall in the posterior wall and dome. There is no evidence of lymphadenopathy or distant metastasis. Since in MRI also, there is one mass at posterior wall of urinary bladder with muscle invasion without any pelvic lymph node involvement. CT chest and abdomen reveals there is no evidence of metastatic disease. We did cystoscopy and that finding is ulcerative lesion in the posterior wall isolate lobe, and after biopsy, histopathology reveals high-grade urothelial carcinoma invading the superficial muscularis propria. And Dr. Salis, what is high-grade? And is there high-grade tumor? Is there any inter-observer variation in grading the urothelial carcinoma?
Can you repeat the question, please?
What is high-grade?
High grade in the sense where there are a lot of ATPA from basal layer to top layer, multiple mitotic activity, and tumor is infiltrating into the lamina propria or muscularis.
Yeah, the report is high grade. If high grade component represents more than or equal to 5%, and the tumors with less than 5% high grade component should be reported as low grade with less than 5% high grade. This is the NCSL recommendation. And in WHO 5th edition also, there is required to grade every urothelial carcinoma. Majority of invasive urothelial carcinoma are high grade. Histologic subtypes of urothelial carcinoma and those with divergent differentiation are all considered high grade, as we listened from Dr. Subhasis, chairperson, who told. Then again to Salis, what is your comment on variant histology as well as subtype? What are the variant histology?
If you are seeing a micropapillary nested variant, microcystic variants, or squamous cell carcinoma, and that's all different divergent differentiation in case of urothelial carcinoma.
Sarcomatoid, plasmacytoid, all the variants are variant histology.
Micropapillary, as we have frequently heard, that's poor prognosis.
Yeah, I think it's a question for Dr. Sandeep. What do you think? What is PT4A versus PT2? It is not working, I think. Please.
Direct invasion into the transmural bladder, that is PT4A, and it is originated in the urethra, we get it as PT2.
Because we know that pathology point of view, histopathology report is essential. But what do you think, Dr. Silas? Besides histopathology report, is there any role of molecular workup you do in?
If you're planning for therapy point of view, if you are going for a personalized kind of treatment, in that case, if you go in for immune checkpoint inhibitor kind of thing, then molecular analysis in that case is relevant.
We are having 6 molecular subgroups, and these are all luminal papillary, where you are having FGFR3 mutation, luminal infiltrated, all these variants. Like
these are especially FGFR3 mutation if you are going for any
in luminal papillary variety. And besides that, basal squamous and neuroendocrine like also. These are different molecular classifications, but last is the TCGA 2017. They have done taking 412 patients. This classification started in London University, taking 308 patients, and later on in 2017, TCGA 2017 revealed these are all classification like luminal papillary, infiltrated, basal squamous, and neuronal. And Dr. Swamya, what is your practice? Do you treat muscle invasive bladder cancer based on molecular subtype?
As of now, that
from predictive and progressive
yeah, but
point
there
of
is
view?
data right now coming up. But as of now, in our lab, we have started classifying them there, but they are mainly based on IHC, which is not the correct way to classify bladder cancer by molecular subtyping.
Okay.
So FGFR again is FGFR3 is again not very much available. So we are not able to do that. The ideal way is to do a PCR method if it is there. So right now we are able to classify. And all the recent trials.
IHC.
FGFR3, we are doing it IHC, but the ideal way is through a TheraKit.
Yeah.
So a TheraKit of FGFR is available. That is on RT-PCR. The FGFR3 usually fuses with another thing that is known as TACA. So FGFR3 can be a fusion, can be an alteration, can be a mutation. But most of the inhibitors of the FGFR3, they target the fusion part. And that is not, so currently we are not able to do that. So as of now, it is more of theoretical. and yes, they are prognostic, but whether they are predictive or not, it is very preliminary to tell that they are predictive and we can diversify our treatment. None of the trials have done that. They have taken it as an exploratory endpoint to look at the subtypes and then decide on the treatment in the future.
Yeah, in future it will come up, like now you
so
are relying on the prognostic part.
ctDNA in bladder is a hot topic. So somebody who is having a ctDNA positive, so they will have a poorer outcome.
Now the patient, 62 years male, Hindu male, clinically presented with hematuria of 2-month duration, urinary cytology is positive, CT and MRI scan shows a mass at posterior wall and dome of urinary bladder, and cystoscopic biopsy revealed high-grade urothelial carcinoma invading the superficial muscular propria. Then Dr. Atul, what will be the stage of the disease?
If it is, it's still in its T2 stage.
T2A?
T2A. And most of such patients will not
Clinically
mostly be operated and
they are not having lymphadenopathy in the CT and MRI.
There's
and
no
clinically, yeah, T2A
stage
and
2
0.
would be.
Stage 2, yeah. And Dr. Prasant, being a surgeon, how do you treat these type of patients? How will you treat?
This is a high-grade tumor. It is muscle invasive and also multifocal. So firstly, I'll be referring to my medical oncologist colleague for neoadjuvant chemotherapy. After that only, we'll be taking off the patient for surgery.
Yes, in muscle invasive, T2A, T2B, N0, M0, neoadjuvant chemotherapy is the treatment of choice, followed by radical cystectomy. After that, if you are having YPT2, YPT4A, first you will give in neoadjuvant chemotherapy, cisplatin-based chemotherapy. After that, if it is YPT2 and YPT4A or YPN node positive, then nivolumab. We will discuss in further slides. You can continue nivolumab. But your patient, if not fit for neoadjuvant chemotherapy, you can consider radical CTRT after TURBT. If there is no disease, you can do a surveillance. If the patient again is not fit for radical CTRT, you can give for radiotherapy only. And after that, if you are having any disease, you can go for surgery. Then why neoadjuvant chemotherapy? Is there any evidence, Dr. Soumya? Is there any advantages with respect to the endpoint? What do you think?
Yeah, so there is a higher kind of a downstaging and a PCR that can be achieved with a neoadjuvant chemotherapy. If you look at the evidence in neoadjuvant chemotherapy is much stronger compared to the adjuvant. And when it comes to muscle invasive bladder cancer, so that's the standard, and the absolute survival is something like around 5% and a 14% decrease in relative risk of recurrence.
There is pathological complete response
Yeah,
also,
more
PCR, and downstaging less than PT2. And there is SOG 8710 trial, what is SOG? Because if you see this trial, there will be median overall survival benefit of 2.6 years when one arm is MVAC along with cystectomy compared with cystectomy alone. And there are all cisplatin-based neoadjuvant CT, whatever we discussed. PCR rate is ranging from 20 to 40%. And this is one meta-analysis. You can neoadjuvant chemotherapy in invasive bladder cancer. The meta-analysis reveals us, taking 11 trials, 3,005 patients, there will be significant OS benefit, 5% at 5 years, and DFS benefit 9% at 5 years, associated with platinum-based combination chemotherapy. Also, PCR rate 20 to 30%, we discussed now. Then Dr. Jogamaya, what should be the chemotherapy protocol in neoadjuvant setting? What is your practice? What you are doing?
In neoadjuvant protocol, we mainly use two approved chemotherapy regimens are there. One is dose-dense MVAC, another is gemcitabine cisplatin. Dose-dense MVAC is less used because of its toxicities. We commonly use gemcitabine cisplatin 3 to 4 cycles.
Okay, yes. Can you substitute carboplatin instead of cisplatin? What do you think? In cisplatin?
No, in neoadjuvant setting, we cannot substitute carboplatin by cisplatin. It is not advisable. It has not shown any benefit. Cisplatin ineligible patients are a different subset of patients. For them, the treatment protocol to be decided in a multidisciplinary plan.
Yeah.
But cisplatin cannot be substituted with carboplatin.
Yeah, in NCCN guideline, that is the dose-dense MVAC, That is the methotrexate, vinblastine, doxorubicin and cisplatin combination dose dense way with growth factor support because it is a toxic regimen for 3 to 6 cycles. Other recommended regimen, how Dr. Jogamaya highlighted, that is the combination of gemcitabine and cisplatin, what we are doing in our practice for 4 cycles. And most important thing that carboplatin should not be substituted for cisplatin in the perioperative bladder cancer setting. And some says it is better to go for 21-day cycle. What is your opinion? Gemcitabine, whether we have to go for a date?
Somebody who is not fit for cisplatin, then better to go for directly for a surgery. So in that case, neoadjuvant plan might be dropped off. So yeah, somebody is having a creatinine clearance of more than 60, then in that case, the dose of cisplatin is 70 mg per meter square on day 1, gemcitabine is 1000, day 1 and day 8 mg per meter square. But when it comes to CC of 40 to 60, in that case, many times we come down to a day 1 and day 8, we split it. So cisplatin, instead of giving a 70 mg per meter square, we give it 35 on day 1 and 35 on day 8.
Yeah, okay. And that will come up, that will come up. That will, Dr. Atul will highlight regarding that. And if you are comparing this gemcitabine, platinum and MVAC, we know that in MVAC there is higher toxicity, having severe nausea and myelosuppression. But in gemcitabine is low toxicity, having reduced myelosuppression. But similar survival outcome we are having in both regimen. And this is the answer for the carboplatin. We are seeing here, cisplatin eligible patients, they are having median overall survival 14 months and 15.1 months respectively in both MVAC and gemcitabine platinum. But when you are giving carboplatin, you can see the graph, this curve, they are just superimposing and median overall survival very low, 9.3 months. And Dr. Ganesh, I think Dr. Ganesh's question will go to Dr. Atul. How will you assess the CDP eligibility? How will you know that patient is eligible for cisplatin?
So more, first would be a GFR, right? More than 60 is clear. But even 50 to 60. We are
discussing for the students like postgraduate
50 to 60. 50 to 60 if PS is 1. Now with Niagara saying that 40 is good, so 40 we...
That is for immunotherapy?
Older patients. No, that is combined GemCis plus Durvalum.
Okay.
So 50, more than 50, I think. More than 50 if PS is good. 40 to 50 we would be a little more cautious. If the disease is T2, then probably surgery would be a better choice in that case. If the patient is older age and the GFR is between 40 to 50, then probably go ahead with surgery. So finally, more than 50 with a good PS are the two predominant things. And you also need to look for hair loss and okay.
Yeah, what is your opinion again, Dr. Atul? It is for you. What is the any biomarker there is for response to NSCT? You are having any biomarker?
So people have looked at HRR in bladder, but it has not correlated as well as in other tumors, if you look at that. Other than that, we are looking at other markers, but still there's no concrete data to say that this is the biomarker
data
where...
is not strong enough to give you impression.
And HRR does not. Probably it is more of a bystander in bladder cancer rather than actually a marker of platinum sensitivity.
Of course, there are some studies are going on where DNA damage repair genes have been analyzed.
Yeah, those are HRR, homologous recombination repair, but still the data doesn't support the platinum sensitivity in urothelial.
In future you will discuss like ERCC1 they are platinum having resistance and ERCC2 they are having sensitivity to cisplatin and carboplatin resistant to radiation. There are so many things are coming up in near future and we will see. Sorry, it's not coming here. Slides are not coming. Yeah. I think Dr. Rajiv is not there. Is there any role of neoadjuvant immunotherapy or immunochemotherapy in muscle invasive? Dr. Soumya.
Yeah, I think that is what Dr. Atul was discussing regarding the Niagara trial that has come up. The rest of the molecules, they don't look that promising. Only the phase 3 data is available for the durvalumab, the Niagara trial. So in that, the primary endpoint was PCR, and the another co-primary endpoint was again event-free survival, and a secondary endpoint was overall survival. So in that trial, almost, if for the residents out there, you can remember 80%. So all the PCR difference between the chemo only arm and your Durva plus chemo arm, that was around 8% difference was there. That was not statistically significant. And they had missed out the initial slides which he talked at, and later on, even after adding that, that was not much of a difference. EFS, yes, it looks better, statistically significant. OS, again, very preliminary, but as of now, the trend is that it is separating. Curves are separating as early as 6 weeks, but right now, whether I'm going to offer them to the patient or not, a very tough one to tell. I still feel from my side that we'll wait a bit when the primary endpoint itself was a PCR, and that is negative.
But
so I'll wait.
OS data is not robust enough.
No, it is preliminary, but it is they're separating and they're significant.
This Niagara, what Atul highlighted, it is
Yeah.
somehow
EFS is
interesting and somehow informative, and it will be exciting.
Yeah.
But
and again he told that Nivo was not given in the adjuvant arm. So that is again, so right now if we look at the data, 4 patients received actually in Niagara, only 4 patients.
Design of the trial we have seen,
Trial,
he has highlighted. Really.
Yeah, so when the trial was designed at that time, the Nivo data had not come, but later on they did not make an amendment. They had included only few patients, but again that is, so right now it is more towards a bit of adjuvant Nivo as of now from medical oncologist perspective, but that is an open question for debate.
Okay, there are so many trials are coming up, recruiting and active. And it is Dr. Sandeep. What is the role of neoadjuvant radiotherapy in muscle invasive bladder cancer?
So, as of now,
About squamous cell carcinoma.
yes, as of now, if you ask me neoadjuvant, I would say that we don't practice yet, but it's an area which is still unexplored. Like we discussed a cisplatin ineligible case. So these are patients we can use on them. And of course, if you are talking about PCR, if you take our lessons from rectal cancer, there is a scope which is yet to be explored.
Yeah, but as a whole, neoadjuvant radiotherapy is
as of now in practice we are not using it.
Yeah, ultimately the patient underwent radical cystectomy. Our patient underwent radical cystectomy, now not received neoadjuvant chemotherapy, cisplatin-based chemotherapy with ileal conduit. His histopathology report is suggestive of tumor type is urothelial carcinoma of urinary bladder, sarcomatid variant. We discussed now variant histology, aggressive, sarcomatid variant, histological grade, high grade, growth pattern, solid growth pattern, multicentricity, tumor multicentricity is very much there. In local invasion, we can see here there is a deep muscularis propria without extension to perivesical fat. There is no vascular invasion, PNA present, adjacent non-neoplastic bladder mucosa unremarkable, widespread tumor necrosis, and all the margins are negative, like right ureteral cut margin, left ureteral cut margin, urethral cut margin, all are negative. Prostate not involved, seminal vesicle and both cut margin of vas not involved. In lymph node dissection, you can see there is right pelvic lymph node, 2 positive out of 7, and left pelvic node, there is all 7 negative. And pathological stage here, PT2V, PN1, and CM0, stage 3A. Dr. Sailesh, whether the histopathology report is adequate or we need more information? This is the histopathology report.
In this report, they have said the sarcomatid variant, whether it is a diffuse sarcomatid or percentage urothelial with sarcomatid, differentiation in percentage of sarcomatid variant, that is not defined in this case. Another margins, they have all margins have.
We want to know percentage of sarcomatid component.
Variant.
Okay.
And another thing is that they have put up a 2 lymph node, but size of lymph node they have not mentioned. Because once size of lymph node is more than 2 centimeter, then it automatically upstages the lymph node staging to N2.
Dr. Prasant, when to refer the patient in muscle invasive bladder cancer, post-op setting or adjuvant therapy? When you refer?
Usually after the wound has recovered, usually takes some 4 to 6 weeks. But if we go by the studies, it should not be delayed more than 90 days.
Okay. After
After
4 to
surgery.
6 weeks.
4 to 6 weeks is standard when when the wound has recovered completely and stitches have been removed.
And then Dr. Sandeep, again for you, because you are alone, what is the next plan of treatment in this patient? The patient is having lymph node involvement, there is no extravesical tumor extension and positive surgical margin.
Lymph node involvement, yes, I would like to give adjuvant RT, especially now with Dr. Bedang's trial from TMH. So where they have given adjuvant RT even in locally advanced T4 stage also. They have encouraging results. So node positive, yes. T3, T4, I would wait for further
Local tumor control, further local
yes,
tumor.
further trials to come up.
Dr. Jogamaya, do you like to give chemotherapy in this patient? Is there any survival advantage?
The role of adjuvant chemotherapy is not as robust as neoadjuvant chemotherapy, but still because this patient has never received chemotherapy, definitely a stage 3 disease, I would like to give adjuvant chemotherapy, gemcitabine cisplatin based.
Yeah, all these selected adjuvant chemotherapy studies, of course here in last study there is PFS benefit, observation versus chemo at relapse, GEMCIS and MVAC dose days MVAC have been compared, and whatever you know here, there is overall survival benefit to adjuvant cisplatin based chemotherapy in this meta-analysis, and this overall survival benefit you can see here, this favors adjuvant chemotherapy versus surgery, and in terms of disease-free survival also, they favor adjuvant chemotherapy, is definitely favorable. Dr. Jogamaya, again, can you defer adjuvant chemotherapy? What do you think? Whether you have to go for immediate or you can delay?
If the patient has any post-operative complications, then only we should delay. Otherwise, as Prashant has said that within maximum 6 weeks, patient should be started on adjuvant chemotherapy. If the patient is ineligible, for example, due to hydronephrosis or any other post-operative complications, then in that situation, we have currently data of adjuvant nivolumab.
But yes, this is URTC 30994. Here you can see if you are going for immediate chemotherapy, it definitely is better. The curve separates, and this is of course there is no difference in OS, but that is the difference in DFS we are seeing here. And this is the updated meta-analysis, again favors immediate chemotherapy. And this is the evidence supporting adjuvant therapy. URTC 30994 trial demonstrated improved progression-free survival with adjuvant chemotherapy in high-risk patients, and recommendation is for adjuvant cisplatin-based combination chemotherapy to patients with P3, T4 and PN node positive disease if no neoadjuvant chemotherapy has been given. Dr. Jogamaya has highlighted. The strength rating is very strong. And Atul, again you have to highlight because you have already highlighted NIAGARA. And is there any added advantage on checkpoint inhibitors? What are the things are coming up and what do you practice in your practice?
So such a patient, he has not received chemotherapy earlier and is cisplatin eligible, will receive 4 cycles of gemcitabine and cisplatin. Now if the patient was cisplatin ineligible, then we have the option either of 1 year of nivolumab, checkmate 274, and recently a Ambassador was also reported where pembrolizumab for 1 year can. We have longer term survival data, overall survival data only for checkmate. So nivolumab would be a preferred strategy if the patient is cisplatin
Because this
ineligible.
atezolizumab not having a negative trial, atezolizumab.
Atezolizumab is not an active drug overall in oncology. It is a very
Okay, pembrolizumab,
It is-
nivolumab, and at last we are
nivolumab would
thinking
be
about
preferred because of the longer term follow-up of checkmate 274. Ambassador only DFS results have been reported. OS is not yet significant.
And who are the candidates, Dr. Soumya? They get maximum benefit of disease-free survival on nivolumab because nivolumab has been studied.
Correct. So that is the PD-L1. So in the study of the checkmate, they showed that somebody who is PD-L1 positive, they do really well, and the curves really stand out. So that's why you have got a FDA approval for the nivolumab for the PD-L1. Irrespective of the PD-L1, but when it comes to European Medical Agency EMA, they have given approval of PD-L1 more than 1%. Yes. So that's why the magnitude of benefit is really more in case of PD-L1 more than 1%.
Benefit, I think. all whole population.
So the intent to treat was the primary endpoint, that was positive. But the magnitude of benefit is very high in PD-L1 positive.
Yes, yes. The benefit of nivolumab is considerably lower in PD-L1 expression low patients. And PD-L1 should be more than 1%, but somehow nivolumab having benefit in ITT population. And this is the checkmate 274. Is there any role of adjuvant immunotherapy in this patient? What do you think?
This patient, as I told, in the eligibility criteria of this particular checkmate, you can see that. So somebody in the adjuvant setting, if they are willing for a gemcis, then you have to give gemcis. So if the patient is not willing for a gemcitabine cisplatin, or it is a cisplatin ineligible for some reason, in that particular scenario, you can give an option of nivolumab.
And this is the thing, this the disease-free survival by subgroup. You can see here, elderly age group, they do benefit. Sex also male, they are having more benefit. And ECOG performance status, you can see the ECOG 0, they are being benefited. And most important thing is initial tumor origin, the urinary bladder tumors, cancers, they are more benefited from this nivolumab. And this extended follow-up of checkmate 274, downstairs ongoing DFS, and disease metastasis-free survival benefits of adjuvant nivolumab compared to placebo. But here now we can recommend offer adjuvant cisplatinum-based combination chemotherapy to patients with P-T3 or T4 or P node-positive disease if no neoadjuvant chemotherapy has been given. The strength rating is very strong, but offer adjuvant nivolumab to selected patients like P-T3-4 and PN plus disease not eligible for or who decline or adjuvant cisplatin-based chemotherapy. But ISMO guideline, what do it say? They do not recommend adjuvant immunotherapy due to conflicting results from the trials with no available OS data. This Durvalumab trial is coming up. Now we have to wait for the strong OS data. I think Dr. Atul, can you answer this? What is the sequencing of chemotherapy and immunocheckpoint inhibitors and why? What is the reason?
So neoadjuvant, if the patient is receiving, then it would be either chemotherapy alone or in combination with Durva. The patient has received chemotherapy earlier, then it would be nivolumab later on, right?
Is there any explanation if you are giving chemotherapy along with immunotherapy? Is the response is that much maintained, or you are thinking that it will be
There
decreased?
is some hypothesis that if you give platinum, there is more exposure of neoantigens which lead to a better immune response rate. That is why the Javelin study in the metastatic setting, where avelumab was given after 4 cycles of gemcis or even carbo, there was a survival benefit where most other things had failed. But now we are seeing that even concurrently with chemotherapy, even with nivolumab in metastatic setting or with durvalumab in perioperative setting. So I don't think that holds true that we cannot give them together. We are giving them together for so many diseases.
Do you think this neoadjuvant cytotoxicity induced by neoadjuvant chemotherapy can elicit an immune effect by activating CD8 positive T cells and decreasing T regulatory cell? Is this the explanation if you are giving?
This is an explanation, but now we are seeing that even when you combine and give concurrently, they are working for most tumors, right? In all, breast cancer,
neoadjuvant followed by
esophageal
immunotherapy
cancer.
could therefore be a more effective approach, whatever we just discussed now. Then Dr. Sanjeev, again for you, what is the role of adjuvant radiotherapy?
So adjuvant radiotherapy, as I have discussed, we take locally advanced node positive or positive margins or any R2 resection by any chance we go for.
Yeah, there are some trials here, but this all the trials only gives us the loco-regional control. And in last trial, SOG NRG Oncology 1806, it is ongoing trial. We are not having any data from that. And again you have to answer how to sequence chemotherapy, immunotherapy with radiation. If you are going to give radiation along with chemotherapy, immunotherapy, how do you sequence it?
With chemotherapy, radiation, I think I use either cisplatin or gemcitabine. And
we will not give a
yes, concurrent.
It would be chemo and then radiation.
And even though there are no trials, I think if you try to follow cervix or
Chemo
lung,
followed by
then different
radiotherapy,
thing.
and in selected patients you are going for. And yes, Jogabhai.
No, I was telling that for this patient.
For this patient?
This patient will give. This is hardly, this is not a high nodal burden nor a. I don't think that there is a very strong role of giving radiation in this case.
This ISMO 2023 has been done in Madrid, Spain. It has been seen here that what this conference has been opined, like cisplatin-based chemotherapy prolongs overall survival, disease-free survival, local control and metastasis-free survival. Immunotherapy improves disease-free survival in 2 trials out of 3, but not OS to date. We discussed now regarding the strong OS data is not available. Hence in chemotherapy, yes, OS, DFS, local control and metastasis-free survival. Definitely we are having all these things. Immunotherapy, OS having no robust data and disease-free survival data you are having, but radiotherapy only local control. And so I can conclude my talk here. You can, this moderation showing you this. Our patients who is having T2B, deep muscular dysplasia, and nodal status, you can see here. This pathological stage is P-T2B, P-N1 and stage 3A. We gave NSCT followed by radical cystectomy and followed by adjuvant CT and RT. I think all the panelists is agreed for the management of this patient, and we conclude here. Our panel discussion, esteemed panelists are very knowledgeable and they gave their opinion, and we accept the management of this patient. Thank you all, ladies and gentlemen. I say
Thank you so much.
1 minute and 22
Yeah, thank you very much for that. Any questions from the house?
Audience, any questions? You can just participate. Yes.
So in neoadjuvant setting for PT2 we are giving neoadjuvant chemotherapy, but if someone underwent directly upfront surgery, you are not advising adjuvant chemo for PT2. In general. Why not?
No data. P2 I think there is a lack of data. In general, adjuvant, the data is very weak.
So then, if someone done the surgery, then
neoadjuvant, the chances are that it is appearing T2, it may actually be a T3 disease, which we are not able to quantify on the imaging part. The chances of recurrence in a PT2 disease are quite low as compared, and we do not have a very strong, robust data to suggest that chemo actually helps. Overall survival benefit is 5% for the overall spectrum of disease.
Right.
And that too in neoadjuvant. Adjuvant, it is still not clear. But T2 is a low risk kind of disease. In neoadjuvant, the reason is different. That we are not able
because
to
we do not
quantify
know
what
the exact
exactly
stage.
the
Yeah,
pathology
yeah,
is.
right. Thank you.
PT2 and YPT2 are different. So
what you will do for N2? Whether you will go for a N2 or N3? Will you go for NACT followed by surgery or NACT followed by CTRT or upfront CTRT?
NACT, if the patient, here NACT followed by surgery followed by immunotherapy, we would end up giving everything and hope against all the odds that he does not.
But I think that question is very fair because the trials didn't include N2.
N3 disease RT also will be given, no? N3 disease RT also will be given.
So how comfortable you are considering a RT, CTRT upfront in a N3 node?
Not comfortable.
So these are the real problem, because we have to face mostly N1, T4, N1. We hardly see T2, T3. So still the benefit of a neoadjuvant approach in a N1, N2 is not very, very defined. So what we do, we give them chemotherapy. If they respond well, and what Atul was saying, that wait for a few months, see if the disease is stable, we can consider for RT or extended surgery up to the para-aortic lymph node in those cases.
Yeah, the situation is like this. It's very clear that whether we have to give the adjuvant treatment in which situations. Only 3 criteria. That is if it is T3, T4 disease and also N1 and N2 disease. There we have to give the adjuvant treatment in form of 3 things. One is chemotherapy, immunotherapy and radiotherapy. Now the question is how to sequence and where to give. If patient has not received the neoadjuvant chemotherapy, subject this patient for the adjuvant chemotherapy. And regarding the immunotherapy, it is very clear because there is no OS advantage. But in N2, let me finish. N2 disease, radiation is a must. Now,
in adjuvant?
Yes.
Must is not
What
the.
is the problem?
It had to be in brackets.
No,
Must
no,
is
no,
not
no,
the.
no, it is standard guideline. Go through, it is a standard guideline.
I think Atul can also comment.
Yes, Atul, I can.
Isn't that robust?
So the Tata,
would
Tata, we have
consider-
done a randomized trial of BART. That data is we just going to just be published. Some early result shows that there is some benefit. Definitely, local treatment has benefited.
Yes.
Local recurrences, but
Yes.
systemic is still not. No, they are
System will take-
analyzing the data.
System will take care by the adjuvant chemotherapy.
So
and we have to, because it's an end-to disease.
In this study, the patient has received either neoadjuvant or adjuvant. So whether the local treatment benefits the overall survival, that is still
That is not yet established. That's not
so
yet
the local
established.
control, how much
No,
is
RT data
local?
isn't that robust.
So
I
N2
would
is still
totally agree.
End-to disease, we have to,
We have to give adjuvant chemotherapy.
we have to
along
go
with
for the
radiotherapy.
adjuvant
The chances of
chemotherapy
recurrence
followed
are
by
high, but the data of role
Yes.
of RT is not that robust.
Yes.
So I agree.
Yes.
Bladder cancer is totally a
We
systemic
cannot
disease.
quote a single randomized trial which showed a clear OS benefit.
See, it is already established, if whatever data also she highlighted, that there is no OS advantage.
Sinha, I think just
but
wait
we
for
have to
the-
control the local disease, so for that we have to go for adjuvant
journal
therapy.
publication which is done recently.
At this point of time, I think we have to just wait. The BART data is our radiation team in analyzing. I think in next 1 month or I think Astro or something is there. They are going to present in that. Then the role of adjuvant radiotherapy in patient era of a new adjuvant or adjuvant chemotherapy gets clear. Whether it's and the end point of the study was not the OS. The sample size was calculated on the basis of the local control.
Yeah.
So still the OS benefit we have to wait.
OS benefit is not there.
So
Local
I think we'll halt it there, and the jury is still out on that, and we'll await for the data on the trial that you've alluded to. I thank the moderator and the speakers for an excellent session. Thank you very much.
Thank you. Thank you so much. Before we leave the stage, can I please request for a group picture?
Thank you so much. Thank you, thank you.
We now proceed.
Yes, it's coming up, but financial toxicity. Financial toxicity.
We now proceed towards our next talk by Dr. Sushant Kumar Paikrai.
Like head
He
and
would
neck
talk
lymphoma
about
node.
optimizing treatment strategies in metastatic urothelial cancer. Dr. Sushant?
Micropapillary, lymphoepithelioma type, plasmacytoid variant we see sometimes, sarcomatoid, giant cell rich, poorly differentiated clear cell, and many others so forth. But these are the most common varieties of variant histology in bladder cancer. So few words about them, like the micropapillary, it is incidence 2 to 5%. Diagnosed as an advanced stage, they are aggressive. And definitely there are higher inter-reporter heterogeneity because there is a difficulty in diagnosis. Treatment part we'll skip, we'll discuss in later. Sarcomatoid 0.3%. Plasmacytoid also is very, very rare. They are treated mostly in the manner of urothelial carcinoma. And there may be cases of squamous and glandular differentiation, that is adenocarcinoma. Squamous is more than the adenocarcinoma. And in adenocarcinoma, we have urachal versus non-urachal. We'll come to that. For the urothelial with a divergent differentiation, it is up to 40% cases. And we frequently see that is a urothelial with a mixed component. That can show the definite exhibit divergent differentiation. Squamous is a predominant, 30 to 40%, followed by a glandular differentiation. And there are other like neuroendocrine, trophoblastic, or MMT differentiation also. carcinosarcomate variant. Now, what is the impact of upfront radical cystectomy? Because these are the newer classification. They are not been diagnosed in 2-3 decades back, and their entity was not clear 2-3 decades back. And they used to undergo majority of the upfront cystectomy because of lack of data of, again, there is not much of neoadjuvant chemotherapy, and there is a lack of data of role of neoadjuvant chemotherapy in them. So what is the data on cystectomy? They have a inferior outcome with the radical cystectomy as compared to the pure urothelial variant. But again, if you see the numbers, 360 the pure urothelial versus 90. So there is a skewed differentiation, but still they are poor prognosis, we know, when you treat only with radical cystectomy. I find one study on adjuvant chemotherapy and survival in patient with histological variant. This is a national cancer database, a very high number of patients, but out of which 9.8% were only with a variant histology. And if you see, mostly the squamous, followed by adenocarcinoma, and neuroendocrine, micropapillary, and sarcomatoid. Plasmacytoid is very, very rare. Now, this is an important table that shows Cox Proson hazard model among the 4,000 patients. What is the advantage outcome of adjuvant chemotherapy in this subgroup? Now, and if you see the p-value and the hazard ratio, only the squamous variant and the micropapillary variant and sarcomatoid variant, these three group has a benefit with adjuvant chemotherapy. But again, these are the subgroup analysis from mostly from the retrospective where the patient level data from various institutes. They has been treated in different manner. But this is the best study so far with a high number of patients. That shows that sarcomatoid, micropapillary, and squamous variety, they get benefit with the adjuvant chemotherapy if not received in a neoadjuvant setting. Now, if you see this, we have the ambassador study. If you see this inclusion criteria, the patient characteristic, 10.7% patient has a variant histology. We have squamous differentiation, pure multiple mixed variant, plasmacytoid, micropapillary, sarcomatoid, mucinous adenocarcinoma, and the nested variant. There's very, very less. But unfortunately, for most of the trial, they did not report the outcome in the variant histology. Even for this adjuvant pembro study, I went through all the supplementary appendix of the NEGM. There is no outcome data reported of benefit of adjuvant pembro in the variant histology. But they were included. Now coming to the few of the variant and what are the literature shows, but those recommendations mostly from the case series retrospective study. There is not a single study, the phase 3 trial that has been done in a variant histology. Now small cell variant we see mostly they are about bladder than the upper tract. They are aggressive, but they do very well respond to chemotherapy. And we all know that any neuroendocrine carcinoma all over the body, they are very chemo responsive. And brain involvement also been reported. So all patients with a variant histology, especially small cell bladder cancer from any tract, if they have diagnosed, should undergo a screening for the brain, for a brain metastasis. And platinum-based doublet with etoposide is a standard of chemotherapy and has been recommended also in neoadjuvant setting, but again, there is no level 1 data. So the neoadjuvant chemotherapy with this EP followed by radical cystectomy has shown some benefit, but again, these are non-randomized data. Any residual small cell cancer at the pathology is associated with worse outcome than any residual. So if you see the match analysis, patient with a residual disease for a pure urothelial cancer versus small cell, definitely they have a poor outcome. And UC with the small cell variant histology has confirmed high TMB and frequent TP53 mutation and RB mutation, as like any small cell from throughout the body shows this TP53 and RB mutation, and they have a unique genes expression profile. And as of now, the UC with small component of any small cell or large cell NEC should be treated like a pure variant of UC so far. Coming to immunotherapy in small cell, the initial study on atezolizumab, all the trial, they did included patient with small cell histology. Advanced stage, there has been a report of case series of treated with pembro EV. There are 3 clinical trials ongoing to evaluate the IO in small cell. One is a neoadjuvant setting with atezo and platinum-based doublet, as I said. Two in advanced setting. One is a first-line extrapulmonary neuroendocrine tumor with atezolizumab, and other one is again lubinectedin plus minus avelumab. So these are all treated in extrapolation from the lung cancer data. So these are the three trial only pure in the small cell variant of bladder cancer. Now coming to the sarcomatoid variant, again this can be a urothelial with a mix with some component of sarcomatoid differentiation. There are very, very rare cases of pure sarcomatoid variant of bladder cancer. The retrospective studies generally do not show any significant benefit from NSE, but the pool analysis, as I showed, shown some benefit. And there are mixed regimen along with GMCs and docetaxel also been tried. These are the pathologic and oncology outcome patient undergoing sarcomatoid variant of undergoing cystectomy. So they has been treated like similar manner, and they do have some benefit. Squamous cell, they are aggressive, mostly found in upper tract with a prior history. Mostly the patient has shown some stone, and that caused chronic irritation followed by squamous cell carcinoma. And there are PFS and OS benefit with taxane-based chemotherapy. There are response to EV and Pembro or combinations. Micropapillary, most characterized by HER2 overexpression. And in the Destiny pan-tumor study, there are patients with a micropapillary variant shown some activity, mostly who has a HER2 3 and HER2 2 plus and 3 plus. So TDX may be one of the upcoming therapy in micropapillary variant of bladder cancer. Urothelial carcinoma is again very rare. There are mostly data from the retrospective case series, and they are treated in a colonic protocol. So there are one study from Andy Anderson with the FOLFOX. Response rate as high as overall response was 60%. Median PFS was 9.3 months with FOLFOX. Median OS was 20 months. There are lots of data on studies of EV that enrolled variant histology, but unfortunately none of the response data or the outcome data has been reported so far, including the EV302. There's a large retrospective data on a UNITE study, 70 patients with variant histology with the EV monotherapy. Response rate was 42%. Median OS was 14 months. But this is not from the clinical trial data. And updated data also show there are some activity of EV, either as a monotherapy or in combination with pembrolizumab. Again, Checkmate 901 study, if you see, there were patients with variant histology, but no subgroup data was published for Checkmate 901 with nivolumab. So how to treat them for an advanced setting? They have to have a customized manner. Currently, they can be treated like immunotherapy, chemoimmunotherapy like Nivo, GemCis or Pembro EV, or if they have any genetic signature like FGF or HER2, they can be treated. And there are data on ADC with a sacituzumab govitecan also for those group, including TDX for HER2 positive group. So for MIBC, should be treated similar to the urothelial carcinoma, neoadjuvant chemo followed by surgery. Small cell, if there is a patient doesn't willing for surgery, they can be supplemented with a radical RT because these are radiosensitive tumor. But for advanced stage disease, they should be treated just like all pure urothelial carcinoma, and except there are some target therapy if someone showing some genetic signature like HER2 positivity or some other mutation. So prospective trial face challenges in funding, accrual and requiring larger sample size. Reporting practice of variant histology for the large study, none of the study has published data for so far. So biomarker selected therapy, and for unselected agent, they can be treated with chemotherapy plus minus chemoimmunotherapy or Pembro EV so far. So it is a very exhaustive topic because this is a very different histology, and most of the data from the retrospective study, there is no level of evidence, and there are lots of doubt and confusion exist. So it has to be treated in a patient-to-patient manner. Thank you. So you can share your comments or experience if you have treated any patient with variant histology. Thank you, sir.
So it was a difficult topic, so that's why you were selected to present. I think you have done the... So there are 2 or 3 things regarding the percentage. Can we... percentage in a turbidity specimen, the 95% you have to, it's for a whole specimen or for a TURBT?
I think this was from the resected specimen because they are used to undergo radical cystectomy.
So in a TURBT specimen, can we able to say that it's a pure small cell variant, or so how
I
you,
can pathologists can comment. Yeah.
So the percentage is relative to the tumor. Yeah, so the denominator is the total volume of the tumor. And we don't really do a rocket science here and kind of, we just basically eyeballing the tumor.
Yes.
Give a percentage. Now, when it comes to, let me just go back here, based on your data, and I think the challenge that we're having here is besides that we're dealing with a rare or uncommon entity, is that most of the previous studies that you cited had pretty much lumped everything as one group of tumors,
yes,
when the truth is biologically and even clinically and the way they behave, these are different tumors. That's what now that we know. And we made a big advancement, as the way you showed there, in plasmacytoid, variant, sarcomatoid, and micropapillary of this upfront cystectomy. And it's pretty now, the upfront cystectomy for micropapillary is considered standard now. Now, going back to the percentage, and this is the problem that before we kind of put them together as one group, there's really no strong study as a group. The only study I could cite is micropapillary. In MD Anderson, in TURBT, they have a cutoff of 25%. And yes, 25% to be aggressive or not to be aggressive. And they say that it's less than 25% is not to be aggressive in TURBT. And when it comes to estimating, as I said, this is just percent of the micropapillary in the overall tumor volume. But for the others, I'm not sure about the cutoff.
Yeah, like neuroendocrine, even if there is 30 or 40% NEC or small cell, that is very high. That has to be aggressive.
For a NEC, I think any component, if I think you can correct me if I'm wrong, what I have read about that, any component of a small cell in a urothelial to be treated like a small cell. It's an aggressive variant, like a lung cancer. If you see adenocarcinoma with a any percentage of small cell, we treat like a small cell. So that what I do, if the pathologist has reported a small cell with the urothelial, I take it as a urothelial.
So let's say, sir, there is only 10% component. So which way to go? That is a question.
So for a small cell, what I do, I take it as an aggressive variant. Any percentage of a small cell with the urothelial, I take it as aggressive variant and treat it like a
so what neoadjuvant you will give? That is a question.
So in this scenario, if the small cell component is there or a high-grade neuroendocrine differentiation is there, EP, yes. So neoadjuvant followed by, we generally do not prefer surgery because so we generally consider for consolidating with the CTRT rather than surgery because the survival. So what I can pursue from my practice that for a small cell, even T1, what you talked about, even T1 if it is not T2, treat as a systemic disease and give them the neoadjuvant even in a CT1 stage. Second is that micropapillary, even in T1 micropapillary, go for a surgery upfront. For the point of discussion is if it comes out to be T2 or T3 with predominantly micropapillary, do you want to go upfront surgery or do you want to consider neoadjuvant followed by surgery? So that's a little bit tricky area. Any component of sarcomatoid, so if there is a sarcomatoid, I somehow try to give some sort of a neoadjuvant immuno with a combination because we know that this may help in there. For micropapillary, I'm not very sure because one way we are saying there's a very aggressive tumor. Second way we are advocating that give them the neoadjuvant chemotherapy. So in our DMG, we generally consider for upfront surgery and then after that some sort of adjuvant chemotherapy if HER2 is positive. And so we prefer early surgery even in a T2 or T3, although the data is not that clear in that.
So are variant histologies predominantly non-tobacco related?
Sir?
Non-tobacco related.
Non-tobacco related, this variant histology?
So I have not went through that, but I think small cell maybe there may be some tobacco association, but for squamous cell, no. Squamous, adenosarcomatoid, there is no separate that it is. Yes, sir.
Let me clarify, because I think in your data there you put squamous as a subtype, but specifically for us in pathology, we made a distinction of urothelial carcinoma with squamous differentiation versus the pure squamous cell, as you know. And I think as far as so squamous, we know that cystosoma is a complex related for that, but not only squamous but also urothelial. Now going back to the management, I think you saw a data there that it has a benefit of neoadjuvant in squamous.
Yes.
But I think I'm not sure of that, to be honest, because right now in the guidelines, we don't recommend neoadjuvant or even adjuvant for pure squamous cell carcinoma. And what I'm worried about is because these are old data.
Old data,
This
right.
may be conflated by urothelial carcinoma with squamous differentiation, which biologically,
Possible.
it's more like on the urothelial side. It would probably, theoretically, it should respond to neoadjuvant.
Yes, if someone come with a PS commerce, we will also undergo directly surgery, not neoadjuvant, right?
I think they are unexplored areas and more studies need to be done. And thank you for your excellent deliberation on such a difficult topic. I think everybody has a doubt in his mind what to do in such kind of varied histologies, be it anywhere. So more studies, probably more. Yeah, sure.
One question, sir. What happens if the pre-op biopsy shows only urothelial and then the residual in the cystectomy specimen, if there is a different histology, like small cell, you've already given NACT, do you give adjuvant or do you consider some extra thing? Like if the initial biopsy comes as urothelial,
It can happen.
and then the residual cystectomy, when the pathologist looks at the entire specimen, they report some other variants.
So I think the difficult question will be that if the residual shows a small cell, so then you are not very sure what to do. So if it is node positive saying, then I may consider for adjuvant CTRT like a lung. If you operated a lung and then on final histopathology it turned out to be a small cell, then we have to supplement with CTRT. For a sarcomatite, then we will definitely want to add some sort of a immuno in this condition. So that happens. You are right that sometimes you may get a different pathology in a specimen than the initial TURBT.
Okay, just wanted to make 2 points. The first about classification, the WHO 2022. So the way we classify it is that if you got any small cell carcinoma with urothelial, we call it a small cell carcinoma as the diagnosis. While urothelial, if you got urothelial and squamous, etc., it will be urothelial with squamous differentiation. So that's for that reason. This pure squamous carcinoma is extremely problematic. And the reason it's so problematic is in pathology, if there's any urothelial component, even CIS. So if you get a squamous cell carcinoma with urothelial CIS, we call it a urothelial carcinoma with extensive squamous differentiation. So it's almost a diagnosis of exclusion. So you can make our diagnosis of pure squamous cell carcinoma really only after cystectomy. Finally, if I could just make one last point. I think clinically there's another reason why these variants are important is because they can have very atypical metastasis. Yes. So like, for example, micropapillary, they can present with peritoneal metastasis. Yes. So if the oncologist is not aware of that, he might start thinking of a new tumor. And same way the pathologist who is faced with a metastatic, if he's not aware that the primary was a micropapillary or a plasmacytoid, he may not think of a bladder cancer. He might start going down a totally different path.
So the only question from the pathologic perspective, sometimes we get the report of a urothelial carcinoma with neuroendocrine differentiation.
Not the small cell one.
Yes. So is it a right terminology to use a urothelial carcinoma with the neuroendocrine differentiation versus a small cell carcinoma? When we have to treat like a small cell, then why this confusion of a urothelial with neuroendocrine differentiation?
So I think the problem here comes, small cell carcinoma is when we see morphologically, when we see the morphological features of small cell carcinoma, that's straightforward. Now, sometimes somebody somewhere does what they shouldn't do, which is basically has an ordinary urothelial carcinoma and decides to do immunohistochemistry. And then finds neuroendocrine positivity. And then the question is, you got what morphologically looks like a urothelial carcinoma, and you got a significant proportion of the cells are neuroendocrine positive. So that's the situation where we end up calling it urothelial carcinoma with neuroendocrine differentiation. Those probably should be treated just like urothelial carcinoma.
Will you use any Ki67 cutoff here? Ki67 index cutoff to call it?
No. Generally, because obviously the small cell carcinomas usually have almost 100% Ki67 positivity. So that the urothelial carcinomas are variable. They can also have a very high Ki67. So the fact that you got something that's got high Ki67, I would not call it small cell carcinoma based on that. I would still call it urothelial carcinoma with neuroendocrine differentiation if, as I said, it's much better not to do the immuno.
That's a very good point. If I may add just a little bit, I agree with all what Morales said. When we use the word small cell from the pathological perspective, we're referring to traditionally in the old days, they used to have this oat cell carcinoma.
Yes.
So we look for that morphology, and that kind of, for our thinking, that's the small cell. Now, in the bladder, we try to extrapolate what we know in the lungs, right? Put it in the bladder and apply the same criteria. But the small cell in the bladder is not as small cell as in the lungs, some of them. So pathologists kind of hesitant. You have everything there. You have neuroendocrine markers positivity, but the morphology is not the classic old cell. In fact, there's large cell neuroendocrine carcinoma in the bladder. It's well accepted. So that's the reason also why that they try to use other terminology and avoid the word small cell.
So I can share an IC which turned out to be a DLBCL, and that young man is surviving for 12 years now. So that turned out to be a pure DLBCL of the urinary bladder, and that got diagnosed on IC only.
Yes.
So there are chances that you might have lesions.
And sometimes they report as a PD carcinoma, then again the confusion starts.
So Vivas, sir, suppose it's a metastatic disease. So which chemotherapy regimens? I mean, suppose it's a squamous cell carcinoma, it's an adenocarcinoma. So how do you, which regimens?
So for small cell, we know it's EP. For adenocarcinoma, if it is a non-urachal, for urachal they use this capox or Colfax bed. Non-urachal, mainly the people have used taxane base or the combination JMCs with, I think, paclitaxel also. There's a weekly regimen from the MD Anderson.
If there is urothelial along with that,
Then we treat like urothelial primary with the JMCs Nivo or Pembro EV or whatever we have.
I think there's a bit of, okay, I'll finish what I'm saying. There's a little bit of controversy everywhere, I think, as to whether we should treat a tumor from where it came from or where it is now. So if you got something that is, it started off as a urothelial carcinoma, but it's now showing predominantly squamous differentiation, should you treat it like a squamous carcinoma? We've got the same problem in the colorectal. In the esophagus, when you get an enteric type adenocarcinoma, should you give it colorectal type chemotherapy, or should you treat it because it came from the esophagus as an esophageal? So that's one issue that really nobody knows really. But generally, I think there's a feeling now that differentiation is probably more important than histogenesis.
I think this one is louder. So yeah, thanks. That's a very important question. And regarding urothelial carcinoma with glandular differentiation and adenocarcinoma. And I think for adenocarcinoma, for the pure adenocarcinoma, again, there's no data that, so the recommendation, as far as I know, is to treat it like colonic cancer. They have this FOLFOX regimen, and I think going back to the molecular basis of pure adenocarcinoma of the bladder, they actually have similarities more with colonic adenocarcinoma.
Yes.
They have these mutations in KRAS, MAD, MYC, and they don't have the high mutational burden or TERT mutation that just like you see in urothelial. So basically, they are a different beast. So clinically, and then also biologically, pure adenocarcinoma of the bladder is different from urothelial carcinoma with adenocarcinoma component. In fact, 2 years ago, we have a consensus. The paper is still in process right now. That our suggestion from the pathologist perspective is that we should officially call mixed urothelial and adenocarcinoma as urothelial carcinoma with glandular differentiation. Avoid the word adenocarcinoma there.
Yes.
When we say something as adenocarcinoma, we mean it's pure. Because from the treatment perspective, it matters. So there will be no confusion.
I think that will clarify this. That clarifies it.
Thank you so much, Dr. Bishwas, and all the esteemed chairs. It was really a good discussion. Clinically intriguing and interesting cases also discussed. Since Sir's flight is there, I would request the chair, can we take up the next session and then we'll call it back? Thank you so much. And photograph with Sir, please, to the center. Yeah. Vivash, sir. And for the talk, we have Dr. Ajay S. Alva. He is an international speaker all the way from Michigan. He will talk on the metastatic urothelial carcinoma, New Horizons, with emphasis on the antibody drug conjugates.
Thank you for this opportunity and organizing this fabulous conference. So I graduated out of Tumors, so it's good to be back home, and icing on the cake is that my wife is Oriya, Sambalpuri to be honest, and my mother-in-law is here. So it's always a pleasure to come to Bhubaneswar. So I was not given a topic. They said you can talk about whatever you want. So in urothelial cancer, there is one class which was alluded to by some of the earlier speakers, a new class, relatively speaking, antibody drug conjugates. So we've been using that as part of trials. We were part of 103 EV301 and the upfront trial too. So these are my research funding disclosures. I will not be discussing any off-label or investigational indications today. So a brief outline, a simple introduction, talk not in depth of the data per se. So antibody drug conjugates is a new way of targeting the chemo to the cancer cell, mainly by using antibodies which are relatively specific for one tumor type. No antibody is 100% specific, as pathologists will tell us. So it is a matter of relativity. Ideally, your antibody has to have long half-life, low immunogenicity, meaning doesn't provoke antibodies to itself, and it has to be internalized efficiently so that it can stimulate the next steps. There is a critical part of the molecule called linker, which links, as the word indicates, between the payload, which is usually a cytotoxic chemotherapy drug, but not always, and the antibody. So Dr. Mehra, who is not here today, Dr. Rohit Mehra, but works with me at Michigan, he is a master of antibodies, and we often come up with antibodies as putative ADCs. So this is a table showing commonly used payloads today. And you can see the initial payloads were monomethyl auristatin, which is a microtubule inhibitor and causes cell division to be halted. But there are a variety of other options too, and including in a drug called sacituzumab, which has now been pulled from the market. Its indication was reversed. SN38, which is the active moiety in irinotecan, was used as a payload. So the first generation was traditional chemotherapy drugs like MMAE, and second as well. And now we have some DNA damage payloads as well. So the quest is to make them least toxic and more selective, and more specific to the tumor cells. So the early ones were common older chemo generation drugs like doxorubicin and vinca alkaloids. So the second generation used better chemistry drugs. So brentuximab, which is in heme malignancies, and adotrastuzumab, which is used in breast cancer, are a very narrow therapeutic window. But they have not found use in GU oncology as much. Now we have third generation ADC drugs, which are more site-specific binding rather than reckless binding to multiple targets, which will of course lead to off-target effects. One of the prime examples is enfortumab, which is approved of course in urothelial cancer. So the DAR refers to the drug-antibody ratio, how many cytotoxic drugs are loaded on each molecule of the antibody. In general, enfortumab and other third generation drugs have a DAR of 2 to 4. So interestingly enough, in 1987, these were isolated, the dolastatin, the precursor of the monomethyl auristatins. And now we have 11 plus and counting and ADCs. The linkers are not inert. They are not just a stick connecting the two pieces. They are actually got properties of cleavability, and sometimes they are non-cleavable with their unique aspects. The cleavability is important so that the payload is released in the right milieu. And the most common ones are cleaved by either proteases or acid-based linkers. So the steps in the process of how these ADCs work is, of course, binding of the ADC with the corresponding antigen. And second step is internalization through endocytosis, phagocytosis, which is a natural reaction of the cell to antibody binding. This is, of course, mediated by vesicle molecules like lathrins. And the third step is degradation internally by the lysosomal mediated process and release of the payload. There is also some bystander effect Some of the payload can be released in circulation as well. These linkers are not 100% resistant to serum proteases, so there is some leakage. Thankfully, with enfortumab, not too much, but with some other older generation ones, there was some off-target toxicity based on non-specific cleavage of the linkers. In addition to direct cytotoxic actions, there is some ADCC, so antibody cell-mediated cell cytotoxicity. So that also contributes in a minor fashion to the effect of the ADCs. So these two, sacituzumab and enfortumab, at some point were approved for urothelial cancer, but now the sacituzumab has been pulled because a phase 3 study did not show any benefit over standard of care chemotherapy drugs. I won't go too much into manufacturing, but there are multiple steps to synthesize these molecules. And one company, Seattle Genetics, has patented this process and has a slew of drugs candidates which have been brought to the market. There are multiple chemistry considerations to take care of when you are making a ADC. Not every antibody is apt for ADC conjugation. But as you can see from this figure, there is a need to avoid free drug release without binding, as well as considerations to be specific in the binding. These are some other manufacturing considerations which chemists can go into more detail. So the most common site of conjugation is to lysine sites in the antibody, and this includes enfortumab as well. But there are other possible amino acids that can also be used for conjugation. So there are additional high-quality ADCs that are being developed, and target proteins range from Nectin-4 as in enfortumab, which is, of course, meeting the criteria of specificity of the expression, TROP2, which was the antibody target in sacituzumab, and tissue factor and CD79, 8. So there are multiple other targets that can be used, including the BCMA, membrane antigen. So antibody drug conjugates are just getting started. So obviously their biggest advantage is a high specificity of their toxicity effect on the tumor cells while potentially theoretically sparing the normal cells. But there are some toxicities that happen on normal cells too. For example, salivary glands express Nectin-4, and there is some toxicity with dry saliva, dry mouth being a common toxicity of enfortumab. I'll skip over that. So these are again some of the properties. The different components of the ADCs have to satisfy to be optimal ADCs. So the linker, as I said, has to be stable in circulation so that there is no release in the circulation before target acquire and match. The drug has to be, payload has to be highly potent and amenable to modifications, chemical modifications, so that it can be customized into a drug. I won't go into antibody structure, but the one that is most relevant to GU oncology is enfortumab vedotin. As you can see, it is derived from a precursor molecule, and there is a PABC, which is aminobenzene alcohol carbamate moiety there. And as ADC's purported mechanism of action, it's internalized upon binding to Nectin-4, its target, and then its lysosomal enzymes break it down and release it intracellularly, most of it. So there have been multiple trials exploring this in urothelial cancer. It started off with some non-specific phase 1 trials, But now there are phase 3 trials in upfront as well as in cis-ineligible metastatic urothelial cancer, where it has also been approved. It got approved first in cis-ineligible in combination with pembrolizumab. So there was a lot of discussion about variant urothelial cancer. So will enfortumab work in variant urothelial cancer? And preliminary data suggests there is some Nectin-4 expression in non-urothelial too. And squamous adenosarcomatoid is less, but there is some. Plasmacytoid, always difficult to treat, and so even small cell has some expression, but it is not as high as urothelial. So the actual expression will depend on the mix of urothelial versus this non-urothelial variant differentiation. So we have to be careful in extrapolating these studies from urothelial. For the most part, they only included predominantly urothelial or pure urothelial to those with non-urothelial differentiation. And the expression of Nectin-4, I want to make this point for the residents perhaps, is we don't test for Nectin-4 expression before choosing enfortumab as a treatment option because the expression is more than 90%. So that in the early trials we did check for Nectin-4 expression, but once we saw that uniformly it was expressed across the tissue types with this cancer, then it was not required anymore. So EV103 had a cohort K, which is EV103 is multiple cohorts cancer. That's how Seattle Genetics likes to do their trials. They open multiple cohorts in the same trial, so they don't have to go through the regulatory process again and again. So this primary endpoint was confirmed ORR, objective response rate, which makes sense for a phase 1 expansion cohort. And this then was combined with pembrolizumab too in another cohort, and this was published separately as well. You can see the objective response was 73.3% in cis-ineligible patients with locally advanced or metastatic urothelial cancer. That is phenomenally high. For comparison, the previous standard of care used to be carbo-based doublets, carbo-gem for example, which has never shown an overall survival advantage. EV203 was a phase 2 study, and this was in combination with pembrolizumab as well. Again, the overall response was 64.5%, amazingly high, and some CRs too. I don't want to emphasize CRs too much. Sometimes it's an artifact of the disease location, but it's still nice to have almost 10% of CRs in these studies. The most recent trial, of course, was EV302, and previously untreated, first line that is, locally advanced or metastatic urothelial cancer. And this has been presented at ESMO and as a press release, which shows that its co-primary endpoints were positive, PFS as well as overall survival, leading to its FDA approval in the United States. So for a long time we were doing different combinations of chemotherapy in first-line urothelial, but we could not extend the overall survival, median overall survival beyond 18 months in Keynote 361 as well. Whereas in this study, EV plus P, that's pembrolizumab, showed a median overall survival of 31.5 months, almost doubling it. And that was a real breakthrough after 30 years of doing different combinations of chemotherapy, second-line immunotherapy, maintenance immunotherapy. We did EV plus P. So EV seems to be a better cytotoxic drug than straight-up chemotherapy drugs of the platinum kind. So FDA has now approved EV plus pembro in first-line treatment. So I think this vacates the maintenance and second-line spaces and moves it up front. We have already started using this first line, and I have seen some great responses anecdotally, because it's still only a couple of dozen patients I've treated off trial. We were part of this trial too. So this should be considered as the new standard of care in primary metastatic untreated urothelial cancer. There is however, another standard of care, as you know, in cis-eligible patients, cis-gem-nivo is also approved. And these two regimens, EV plus P and cis-gem-nivo, have not been compared in the cis-eligible population head-to-head. So one other caveat of mine always when I'm talking to fellows or residents is not to overstretch the data. I know our data is always too little for all the clinical questions we come up with while seeing patients, but we have to resist the temptation to extrapolate the data to a point where it no longer resembles any scientifically backed evidence. So for example, some colleagues, we have a consortium we are part of, have tried to find in a retrospective real-world evidence whether there are some patient subsets who would benefit more from EV plus P or conversely from cis-gem-nivo. And I think still the best evidence is a prospectively done, adequately powered phase 3 trial. So until that comes, these two will coexist for a while as not competing but coexisting standards of care, at least for the cis-eligible patients. That slide got butchered in formatting. So by itself, when we used EV as third line originally after platinums and after immunotherapy, we saw objective overall response of around 40%, which is not bad because the previous standard of care was like Vinca or taxanes, which far lower overall response. But now bringing it forward has brought also some toxicity issues. Some of these were alluded to by a previous speaker, but I want to emphasize some of these as really limiting our treatment ability. Peripheral sensory neuropathy, which usually starts in the feet or sometimes moves on to the fingers and hands and can extend proximally with a motor component as well later on. This limits. I am really nervous about sensory neuropathy when I see it even grade 1, which is just numbness, tingling. Is this an indication to stop talking? So I either dose reduce, give them a holiday, just continue with the pembrolizumab alone, because it can lead to foot drops and other deficits, which can be quite detrimental to quality of life. The other one is maculopapular rash. In studies, it's a little lower, the incidence of it, as you can see. Grade 3 is rare, but I have seen rashes from EV alone which have required admission to the burns unit because it covered so much of the surface area, and as you know, CTCAE grades rash by the body surface area covered. So prompt cessation of the EV treatment and start of steroids, topical, but for grade 3 and above, systemic steroids too is very essential. And someone mentioned hyperglycemia. That's a very important side effect as well, especially in diabetic patients. A lot of these patients are diabetic. So this is some alopecia too, because of its chemotherapy kind of effect is important. The cytopenias are less of a problem to treat, but there is some anemia, some less common thrombocytopenia, neutropenia. Dose reduction usually does the job. 1.25 milligrams per kilogram is generally the dose to start with. So I skip day 1, day 8, it is given, so I skip day 8 sometimes, which is a form of dose reduction, or go straight to 1 and then 0.75. And that usually can manage these side effects, except neuropathy, which I said. These are some of the rashes that have been described. As you can see, it's no different from many other drug reactions. There is really no way of differentiating except temporal associations. And this was a punch biopsy done in one of those patients. You can see that there is a sharply demarcated bulle, and blistering is a common manifestation of these rashes. Thank you to everybody who's organized this. It has been fascinating discussion, really good points. I'm happy to answer any questions.
Thank you so much, Dr. Alva, for the wonderful talk. Expert comments and questions.
Hello, test. It's a very good talk, Dr. Alba. And this is something new, I mean, for me. The way I see it is that the way I conceptualize the approach is something like a homing pigeon, you know. So basically the homing pigeon is flying, and then it's carrying drugs. And then the homing pigeon represents the antibodies that you said, and then the drug is what you called as the payload. If that's the way I see it.
Yeah,
So
like the message tied to the feet of the pigeon.
Yes, exactly. So to make this work, to make this effective, you have to have two components here: how good the antibody is, and how good the drugs, the payload is. Now I noticed there were a lot of antigens there that you showed, and I think one glaring that you point out is nectin. Nectin, I think, is the antigen that you're using in the bladder.
Yeah.
So
Nectin-4.
And you said that it's you don't test it because it's specific enough, highly expressed. So you used the word there, site-specific, in the beginning, and I just a little bit not clear on that. So when you say site-specific, you're referring to the payload.
Yeah, where the payload binds to the antibody. That site-specific binding is in the manufacturing process. So that is a different context than site-specific of the nectin-4 expression, for example.
Okay.
So salivary glands express a lot of nectin-4, unfortunately.
Yes.
So dry mouth is a common side effect of EV therapy.
Yeah, so exactly. So that's my follow-up question, because here we're talking about urologic cancers, but this is more like kind of a broader cancer, right? It's not only for bladder. So
right.
Yeah. Okay.
Yeah, that's a good point. Yeah, yes, it is definitely expressed in.
It's not site-specific. Then, like salivary gland is you are not expecting it.
Right.
You have no choice, so you are eating less as a marker. Am I right?
That is correct. Adult tissues generally don't express nectin-4. Yeah, embryonic tissues do, as they do many more. But the salivary glands and the urothelium express nectin-4. Yeah, right.
This must be the target of all other tissues. Like some differentiate tumors must be expressing more of certain genes with which you can hit the antidote. Am I getting this?
Yes, at some point I expect that the other variants too will identify some antigens which we can hopefully potentially target in the future.
Yeah, because in this one the small cell was the lowest, I guess.
That is true, and that is exploratory data too. So I would definitely not recommend using EV in a small cell predominant urothelial cancer.
You stopped using because it was already.
Right.
You stopped using it earlier in initial stages. You might have done nectin-4 on maybe a cohort of 100 or 200 urothelial cancer, I guess.
I guess, yeah.
Then you stopped it because it was already there.
More than 90%. Yes, it was not expressed at a high level in variant tumors. But in regular garden variety urothelial cancer, nectin-4 is expressed almost ubiquitously, and more than 95% actually. So it makes it redundant to test for it.
And I think the side effects, if I am gathering it right, must be because this payload is going out of the cell.
Yeah, in the circulation sometimes it doesn't stay bound, it is released and it's just flowing. Thankfully it doesn't happen a lot, because we would have had a lot more side effects if it was just disintegrating all the time. The chemistry is good enough that it's locked in, for the most part, less than 5% disintegration in the serum.
I think regarding the toxicity, because that is going to be challenge, like a skin toxicity which you have shown, sometimes there may be overlapping, because the pembro can also cause skin toxicity, EV is also, so that will be a challenge, how to decide whether it's a EV related or PEM, then whether to start the steroid or not. The management is going to be a little bit different than re-challenge of the...
Yeah, that's a great point. Definitely there is overlap. In some ways it reminds me of TKI and IO toxicity. You get diarrhea, you don't know whether it's IO colitis or just a TKI diarrhea, or hepatitis for that matter. But thankfully the dermatologists have solved it for us. Whatever the problem, they give steroids. So that's
But it's about re-challenging which drug
Yes.
do you re-challenge them one by one, which one do you challenge
Yeah.
first?
Yeah.
Those are the questions.
Right. No, the frequency-wise, if you go by odds probability, EV has 80% plus all-grade frequency of rash. So I stop the EV and continue with the Pembro.
How long do you stop?
I stop one cycle at least. That's 2 infusions. In the combination, it's day 1, day 8. And if there is some improvement, we get a hint that it is probably from the EV. But it does get worse when you re-challenge them, unless you dose reduce it. It is a dose-related toxicity.
Will the biopsy help in deciding it's a EV related or Pembro?
Yeah, although I showed you a punch biopsy, that's a classical finding. I don't expect every EV rash to have the same classic findings.
Some sort of a T-cell infiltrate more in a immune toxicity compared to the EV, will that helps us in deciding the...
I would want to...
I think that he's referring to maybe a graft versus host disease kind of a situation, yeah. But I don't think so. I see few organs and I see some of the skin also. It's, pathologically it's very difficult to tell. Even, I think if you ask me on that slide, I'll put erythema multiforme on top of my differential, yeah.
So I think D-squamation, does it happen with pembrolizumab? I mean, D-squamation is something which we have seen with EV.
Right, not so much with Pembro.
Yeah, something like that.
Even bullous lesions are known with IO, not very common.
So one patient we had EV, we had given D-squamation happened, entire back got peeled up. These sort of toxicities usually with
But we have seen with IO as well such, the almost like 90% of the skin involved with bullous lesions, and then Steven Johnson like picture in other cancers.
So it's more common toxicity with
but
EV.
if it is that common with, and is the
EV is-
timeline, what is the timeline of development of rash with EV would also be?
3-4 doses of
So it's
EV.
exactly similar to what we would expect with
Exactly,
IO
so
as
that
well.
cannot really
So
differentiate.
other thing, Ajay, is that about use of EV in the population of patients. Many of these patients have jaundice. So I had used it in a patient with jaundice, and the patient actually responded. Although EV doesn't have data in setting of jaundice or with renal failure. What do you think?
What was the jaundice from?
So it was due to the multiple liver metastasis. So it was studied with metastasis. So with initiation of EV, initially although the bilirubin started to rise, but subsequent with dose
So you
reduction.
basically responded. Yeah.
So it responded, so it could be used. But in renal failure, the patient actually, one patient who had single kidney, although EV was given, after a couple of cycles developed a lot of toxicity. So
Right, but all these trials exclude
Exactly,
the kinds
exactly.
of patients you are suggesting. But obviously there's nothing preventing them from responding either. But I would be careful using those patients with drugs that don't have primary evidence in it.
So
For example, GFR less than 30, almost always excluded from clinical trials, so no drug really has evidence in those. But in a patient, you cannot say there is no evidence, so we can't treat you. So we extrapolate, carefully move ahead.
So other thing is the HER2. Now HER2, unfortunately, HER2 is although expressed in 20% of the patients, none of the anti-HER2 agents have worked. Now we have a very sensitive agent, TDXD. Do you think there is a chance for this drug, and what is...
Yeah, they are doing phase 3 trials now with the DS molecule, Daiichi Sankyo's molecule. So it is going to come, but as you said, it's not uniformly expressed, HER2, so we will have to profile the tumor. So we do a lot of next generation sequencing starting the first line because one, we can identify FGFR mutations and aberrations like fusions, as someone mentioned, because there is a approved drug for that, erdafitinib. So in the same NGS panel, we get IHC as well as IHC for HER2 should be enough for this process, ADC targeting. But as you said, other molecules targeting the slivers. So we would probably see slicing of the urothelial cancer into multiple segments, with each segment being treated differently based on what they express and what drivers they have.
Do you...
So there will be a drug for HER2 in urinary bladder from the Pfizer. I'm just doing the SIV.
Yeah, HER2 is actually lucky for urothelial cancer because it's been worked up extensively in breast cancer. All we have to do is copy and try it out in trials.
But the initial all trastuzumab, TDM1 and all those had failed. So I think the only positive data is coming from it. Nevertheless, do you still have patients who would be treated in a checkmate or a javelin manner, or all patients would go in a EV Pembro?
So that's a good point. We probably poring over some of the data when a new standard arrives. But I would rather take the best data now and run with it, and later on, second or third line, when we have to go fishing for other targets and other drugs, then we will kick the can down the road, as we say.
So most would be EV Pembro as a first line.
Unless there is a contraindication. We do EV Pembro.
And is cisplatin a problem in second line because of the neuropathy that comes up with EV?
And as such, it's a tough drug in the first line itself. Second line, the patients are more beat up. Yes, definitely.
I think I saw PSMA there in one of the list of the antigen. I'm just curious. So you're also trying this in prostate cancer, I assume, with a different payload.
PSMAs are a good target, except not in urothelial cancer. That slide was more general slide. But as you know, PSMA lutetium 177 is already approved in prostate cancer.
So you're using it for prostate cancer?
Yes, but not EV, of course. Yeah.
Very interesting. When is this trial going to the results will be out? It's approved recently, right?
The EV 302? Yeah, the results have been presented in a press release form, top-line results, without going into the specifics. I suspect at GU ASCO they may have coming up next month, this end of this month, early next month, there will be some data presented.
A wonderful talk by Dr. Alva.
Thank you.
Thank you so much. A big round of applause for our speaker. Dr. Alva, can I please request you, can I please request you to, all of you, to come center stage for a photograph, please? So over here, Dr. Ghanshyam Biswas. Thank you so much. Thank you so much for a wonderful session here. Yeah, I'm requesting you to stay. I will quickly move to the next session. To chair the next final session for the day, I request Dr. Sushma Patra, Dr. Ranjan Arora, who is already seated here, Dr. Mohini Rao, Dr. Indranil Chakrabarti. The next talk is on troubleshooting and QC in IHC. It's by Mr. Kamal Pedinti. Dr. Sushma Patra? We'll start this.
Very good evening all, and thank you for the session given to the Path Institute. This is Kamal Pedinti, and the Director of Path Institute Biotechnologies. So today we'll be discussing about the troubleshooting of immunohistochemistry. From last couple of days, we have seen so many beautiful slides of HNDs and also immunohistochemistry slides. They are very good because they have done extensive optimization and validation of the immunohistochemistry in manual as well as into the automation level. So most of times we find there are three different stages of where we see the troubleshooting. One is the pre-analytical phase errors. The second is analytical phase errors. The third one is post-analytical phase errors. The specimen collection, labeling, specimen accession and transportation from the operating room to the pathology lab is very essential. If it is not being used non-neutral buffered formalin as a fixative, there is a tremendous of antigen loss will be there. That is one of the reasons. Second thing is analytical phase errors, the grossing, histological tissue processing, sectioning, staining and microscopic interpretation. We'll be discussing more detail about these, what are the points that we are discussing here. The post-analytical phase errors are the reporting of the pathology test results and clinical interpretation. Many times without proper clinical findings, it is very difficult to a pathologist to give a proper diagnosis into the report. A study carried out in Pennsylvania in teaching hospital identified 491 errors, in which 88% are in the pre-analytical phase errors, which is labeling or could be fixation levels, and 20% is like analytical errors during the tissue processing and also tissue sectioning level, and 39% is like post-analytical phase errors. The basic immunohistochemistry, it's antigen antibody binding. Once we have once we have an antigen into the tissue, the antigen will bind to the primary antibody, which is a target specific. Then we add like secondary antibody, which is conjugated with the HRP enzyme, and then followed by the chromogen, followed by the counter strain of the staining. So the immunohistochemistry is an important evaluation tool that falls under the umbrella of immunostaining techniques, analytical phase. Owing the versatility and simplicity of affordability of this technique, IHC is a new indispensable in the field of histology and pathology and cancer biology. IHC is a multi-step protocol, as I said, like primary and secondary and enzyme, and also the chromogen, and after that like counter stain. IHC is like, since like there are multi-step protocols, there is like a high chance of human error. So a well-trained technician should be is a paramount into the performing the procedure. Why troubleshooting? When an appropriate diagnosis is not possible to conclude the accurate results. And this is like, I think like it's a daily, pathologists will find like a lot of errors every day. So it is like very difficult to have like proper diagnosis when it is not being done. So troubleshooting is very well required over here. The common issues in immunohistochemistry, the first is like tissue lift-off, and second is the weak staining, and third one is the overstain or background stain, and the fourth one is the no stain. We'll get into the details of these four elements. The tissue lift-off before troubleshoot and after troubleshoot, you can see the area there, the tissue is intact with the slide, and second, the first slide doesn't have a tissue lift-off is there. The tissue lift-off can have like improper fixation. In generally, it has been recommended to have like use the 4%, 10% neutral buffer formalin, and it has to be fixed for 4 to 72 hours of the timeline. According to the CAP guidelines, it has been recommended 4 to 72 hours, and depending on the sample size. And not use like positive charge slides. When we use immunohistochemistry, we have to use the positively charged slides. Otherwise, the tissue will not interact with the slide, the glass slide. During antigen retrieval, it may be a loss of the tissue. Uneven coating of positive charge slides. A lot of laboratories, mainly in like India and like small, economically backward countries, they are using like in-house coated slides. So it has to be coated properly, the APES or polyolefin slides. The improper tissue processor, if the tissue is not been processed using like alcohols or graded alcohols, xylenes, and also the paraffin wax, there's a high chance of losing the tissue. So the tissue processing has to be done properly, and also the solutions in tissue processing has to be like changed periodically according to the like the laboratory specifications and the instrumentation what they are using it. Excess fat on tissues, this is very common problem, but in general, like into the immunohistochemistry, the fat, not many markers represent the fat, so which is still okay, but still like if you do a proper coating and tissue fixation processing, this also can be eliminated. And lack of baking. Before we go to the IHC, on automation mainly, what happens is like a lot of people, a lot of technicians, soon after cutting that section, they directly take into the automation and do the baking on the automation itself. Before baking on, instead of baking directly on automation, if at all you bake on the like regular oven and do the 20 minutes baking, then after you take to the automation, there is a low chance of like getting tissue lift off. The thicknesses of sections are very high. In general, we recommend to have like 2 to 4 microns of tissue sections, but sometimes people like the lymph node. If you cut the lymph node at 4 microns, kept setting up the microtome, there's a high chance like in the lymph node may cut it 5 to 6 microns. So in that case, there's a high chance like the tissue will be lifted off. So tissue specific, these are high cellular tissues. Then high temperature of antigen retrieval buffers or buffer pH imbalance. So in general, recommended to have the antigen retrieval to be done at like somewhere 98 degrees to 104 degrees centigrade. If it is beyond that, or like even maximum 108 can be okay, but if it is beyond that, there's a high chance of losing the tissues because of the bubbling of the buffer. Second thing is like pH imbalance. In general, the pH has been used 6.0 or 8.0 or 9.0, depending on the buffer that we use it. But most of the times what happens, like if the pH is not being checked daily basis and every day, if the pH is in acidic condition, there's a high chance of losing the tissues. The weak staining, you can clearly see that like the left side one is a weak and the other one is the right side one is the like properly stained, optimal staining. This is very common problem into the immunohistochemistry. The overfixation kills the antigenicity. As I said, like the fixation has to be done to the 4 to 72 hours, and also the fixative that you use, it cannot be 100% concentrated fixative. You always have to use the 10% neutral buffered formalin. And effect of formaldehyde vapors. So what happens is like, many labs, they have a common room for staining and as IHC staining as well as the grossing. If the grossing vapors are coming into the IHC laboratory, there is a chance of again remasking the again antigenic sites. So that way again we'll have like the weaker staining. So the binding of antibodies cannot be proper. That could be one of the reason. Thin sections I do not really call as a weak staining, but what happens like if at all you take a kidney cutting in 1 micron, 2 microns will look like a weak staining. But at the same time, lymph node, if at all you're cutting into like 3 microns, that become a thick section. So the technician should really understand like what they are cutting and what thickness they have to do the section cutting on this one. The next is improper deparaffination. In general, what happens is like during deparaffinization, if the wax is not being removed completely, at the end of the staining, the antibodies will not bind properly. After the staining, again we go with the dehydration process. There the wax has been removed. Under the microscope, we really do not understand like, hey, the wax has been removed. I don't see wax. The wax has been removed at the later stage, not at the beginning stage. So use 3 changes of xylene, fresh xylenes and alcohols for 2 minutes and each for the proper deparaffination. Improper antigen retrieval. So if the timing of temperature is not been maintained or not been optimized, there will be a weak staining. Think of like the antigen retrieval should be done at 98 to 104 or 108 degrees centigrade. If it is not been maintained below 98 degrees, there will be weak staining because the epitopes will not get open. The cross-linkage of formalin methyl bonds, those will not be broken. That's what like you have to maintain the proper optimal temperature for the antigen retrieval system. And wrong choice of antigen retrieval buffer or buffer pH imbalance. Think of synaptophysin antibody. When we do synaptophysin antibody, it is recommended to use the citrate buffer than the TRICDTA. Likewise, there are many antibodies will have like recommended antigen retrieval buffer, the pH. So when we use that one, then we'll not have any other problems. The uneven spreading of reagents. So if at all the thing is done in manually, the manual staining will have uneven surface of the place, so it will be find like weak staining. The low antibody concentration, insufficient antibody incubation. So the low antibodies has been not been, if somebody is using concentrated antibodies, if it is not been optimized for the concentration, there's a high chance of getting the weak staining. And insufficient antibody incubation. Think of like you are incubating only for like 20 minutes or 15 minutes, then there's a high chance of weak staining. The pH imbalance of the immunowash buffer. The pH of immunowash buffer should be maintained around 7.4. If it is not been, if it has been acidic conditions, there will be high weak staining will be observed. The improper proportion of mixing of DAB substrate and chromogen. In general, the working solution of the substrate buffer, the DAB substrate buffer, is maintained like 1 ml and 1 drop. But many of the technicians, what they do, they add like, if I add more chromogen, I get more color. It's actually wrong concept. Because the chromogen is again 2.5 pH and the buffer is 7.4 pH. You're adding more acid to the base, which kills the activity that is bound on the slide. The low room temperature, if the temperature of the room is below 16 degrees, you have to go for longer incubation. If you are still maintaining only half an hour incubation, 1 hour incubation, there's a high chance of again getting the weak staining. And uneven workstations. Improper mixing of antibodies and secondary before application on the slide. So if it is not been properly mixed, the antibodies, because the protein is again, it gets settled at the bottom of the vial. If it is not mixed properly And if you put only the supernatant of this vial, then there's a high chance of having low number of molecules for binding sites. Overstrain and background strain. The type of tissue, think of having the colloidal, like thyroid tissue, having it colloidal. It is not background, but it is again the sticky material. The DAB will go and bind to the colloidal material. And thick sections, the thick sections will, it is not actually like a background staining or something, but again overlapping of cells will have a over binding of the antigenic sites. That's what we feel as a background stain. The wrong selection of antigen buffer, instead of using citrate buffer pH 6.0, if at all you use a pH 9.0, then it is going to be a overstaining. Should I cut down? Many. Should I continue? There are few more sites, are there?
Just summarize, please.
Okay, yeah. Okay, yeah. So, I take it to how to maintain optimal conditions of the pathology, the immunohistochemistry laboratory. What is quality control? Aggregation of process and techniques that to detect. To pathologists, the quality is to provide an accurate, on-time and comprehensive reports that assures the patient's gratifications. To a medical laboratory technician, the quality is production of high-quality sections and stains reduce the TAT. To the patient, it is the receiving a proper medication after the reporting has been, proper diagnosis has been done. So you can increase the quality of the IHC is control on the fixation and processing and use fresh dehydration solutions and the buffers. And use positive tissue specific negative controls and positive controls that need to be done, and use Vimentin in a quality control, which when you do complete your histopathology lab, IHC laboratory, and use 2 to 4 microns of sections always, and use the proper adhesive on slides, the positive charge coating or commercially available slides. The pH of both wash and AR buffers should be maintained, and it should be checked every day. Dryness should not take the place during the procedure. Use humid chambers for that. Follow manufacturer recommendations for the protocol and antibody when you purchase. And also use the factory specific calibrated instrument, consistent optimal strain results. This is kind of important thing. A lot of people, they think that on immunohistochemistry can be done in normal domestic microwave and we can optimize. But there are so many factors will affect that instrumentation. So always maintain the laboratory specific instrumentation. Use of automated tissue embedded slide strainers and slide labelers saves time, reduce the errors. Thank you very much.
Thank you so much. The next talk of the day is by Dr. Sachin Shekhar Biswal. He will be talking on the role of denosumab in prostate cancer, preventive and therapeutic approaches. Dr. Sachin. No, sir, you took the chair for the entire session. This is the last session.
A very good afternoon, good evening to everyone. I'll be talking about the management of bone metastasis in prostate cancer. As far as prostate cancer is concerned, as per the Globocan 2022 data, it stands globally at the rank 4 as far as incidence is concerned. And as far as mortality is concerned, it ranks at the 8th number. As far as Indian data is concerned, prostate cancer ranks 12 in incidence and ranks 14 in mortality. As per report from National Cancer Registry Program, India cumulative risk of developing cancer at 0 to 74 years of age is 1 in 125. So prostate cancer and bone metastasis, the underlying mechanisms, the prostate cancer has a strong predilection to spread to the bone, promoting osteolytic or osteoblastic metastatic lesions. The disease manifestation is driven by the interaction between tumor cells, the osteoblasts and osteoclast. The increased level of the osteoclast activating factor is believed to induce the bone resorption by upregulating the rank ligand and the release of various growth factors into the bone microenvironment that enhances the growth of cancer cell. So the bone metastasis in prostate cancer, it is a complex process. this is supported by the inflammation process that is undergoing in the tumor microenvironment. The hormones that are responsible for regulation of bone mineral density, and mostly the rank ligand and osteoproteogerin system. The biochemical markers of bone resorption are found to be elevated in osteolytic metastasis. Both osteolytic response and osteoblastic response are there to develop bone metastasis in prostate cancer. So this diagram essentially depicts the interaction between rank and rank ligand, and this is a cycle that leads to osteoclast activation and degradation of the bone matrix. So inflammation also has an important part to play in the metastasis and reaching the metastatic cell into the bone environment. Interaction of the cells in malignant cells to extravasation and reaching the lymph node and finally colonizing in the bone microenvironment. So usually the prostate cancer is treated with LHRH agonist or antagonist. These called medical castration. There is castration-induced bone loss. The loss or the activation of osteoclasts has also been shown to be promoting the bone metastasis. Up to 90% men with metastatic castration-resistant prostate cancer develop bone metastasis, and majority of these men have received ADT or androgen deprivation therapy that is known to cause bone loss. So in this diagram we can see the effect of androgen synthesis inhibitors or ADT. This decreases the androgen activity, which in turn leads to bone resorption and increased risk for fracture. So how we can treat and prevent this bone loss? This is by awareness and education, lifestyle modification like being more active and adopting exercises that increase the bone density, and bone protective agents. Like in the last flowchart we saw, the glucocorticoids, they decrease osteoblast activity, which again leads to more bone resorption, and denosumab, which binds to the rank ligand and inhibits the RANKL and OPG pathway, which further leads to decrease in bone resorption and decrease in fracture risk. Bisphosphonates, they mostly accumulate in the bone and they inhibit the osteoclast. They simultaneously decrease the osteoclast number and the activity of the osteoclast, resulting in increase in the bone density and decrease in bone resorption. So this is a graph. It is showing the denosumab versus zoledronic acid for treatment of bone metastasis in CRPC. The left side Kaplan-Meier curve is showing that the blue curve, which represents denosumab, it started separating from the red one from 3 months onward. It started separating very early. So this is the rank ligand and OPG pathway showing osteoblasts releasing rank ligand, denosumab binding and inactivating the rank ligand. This is a vicious cycle where rank ligand goes on and binds to rank, and this ultimately leads to bone resorption. Bisphosphonates accumulate in the bone and inhibit the osteoclast, while denosumab, it binds to the rank ligand and inhibits the process of bone resorption. So now comparing the efficacy and safety of denosumab versus bisphosphonate in increasing bone mineral density in prostate cancer patients on ADT. So denosumab and zoledronate, they have a very different mechanism of actions. Denosumab is a highly specific inhibitor of the rank ligand. It acts as a regulator of osteoclastic bone resorption and is a strong bone resolving cytokine. Patient adherence and compliance is better with denosumab. In renal failure patients, denosumab is definitely superior to zoledronate. The adverse effects and safety of denosumab and zoledronate are more or less similar, except the renal failure part. Bisphosphonates are nephrotoxic and require regular monitoring of renal functions. This is more important because in prostate cancer, there might be some underlying renal dysfunction arising from obstructive uropathy or other comorbidities due to advanced age. So this is an interesting study. The researchers, they wanted to know whether this denosumab can decrease the denosumab can postpone the development of bone metastasis. So this is a phase 3 trial including 1400 plus patients. The parameters for high risk for developing bone metastasis was baseline PSA more than 8 and PSA doubling time less than 10 months. The randomized patients, they received 120 mg of denosumab every 4 weeks versus placebo. The primary endpoint was a bone metastasis free survival. So this showed that the median increase in bone metastasis free survival was 4.2 months. Of course, this needs to be validated in larger number of trials before this can come into practice, but nevertheless this gives an interesting perspective. Coming to the side effects, the hypocalcemia is a known side effect of both denosumab and zoldonate, and among the patients with prostate cancer who are receiving bisphosphonate or denosumab, hypocalcemia occurs in mostly in those patients those who do not receive any calcium supplementation or vitamin D supplementation. There is this data to support this with use of vitamin D and calcium supplementation with both in denosumab and zoldonate group, there was a significant decrease in the incidence of hypocalcemia. These are the graphs which represent the bone targeting agents in hormone sensitive prostate cancer. As we can see, most of the graphs, they do not separate or separate at a very later time. So that as such, there is not much of benefit that has been shown with bone resorption, anti-bone resorption agents in hormone sensitive prostate cancer. So this is another point. In men receiving ADT for prostate cancer, these men are usually older population and might have some underlying bone loss at the presentation. So this is denosumab. In this study, denosumab was associated with increased bone mineral density at all sites and reduction in the incidence of new vertebral fractures among men receiving ADT for non-metastatic prostate cancer. So zoldonate acid versus denosumab in improving bone health. The prospective randomized trials have shown that denosumab is superior in prevention of skeletal-related events. There is no role of zoldonate or denosumab in the prevention of bone metastasis. Bone targeting agent should be commenced at the time of diagnosis of metastatic bone disease in men with castrate-resistant prostate cancer. The role of radium-223 or PSMA targeted agents is still to come, although radium-223 has shown improved overall survival. The efficacy and safety of denosumab in the treatment of bone loss in non-metastatic prostate cancer receiving androgen deprivation therapy. It was shown in a 1:1 double-blind placebo-controlled study. The overall result was there was significant reduction in the relative risk and the absolute risk reduction in men receiving denosumab or zoldonate. Thank you.
So just a minute, you're not audible.
In patients with non-metastatic setting also it's useful?
Definitely, sir. In patients receiving ADT, even in the non-metastatic setting, we usually do a bone densitometry or DEXA scan at the baseline, and it is useful in preventing osteoporosis. As we start ADT, there is gradual bone loss, and over 6 months or 1 year, and we follow them up with denosumab. The dose there is less. It is 60 mg every 6 months, to treat osteoporosis.
Thank you.
Are there any side effects of this?
Yes, so the most common side effect that we see in clinical setting is hypocalcemia. Apart from that, the text mentioned osteoradionecrosis of jaw. As far as ONJ is concerned, I have not seen a case, but hypocalcemia is very common.
That should be with biphosphonates, osteonecrosis of the jaw, right? Denosumab also causes?
Yes, sir. Denosumab also causes.
It's a hypothetical question. Androgen receptor blockers doesn't act on rank L directly. It is through estrogen. So
Yes.
why you are not giving supplement of estrogen rather than we are targeting rank L and osteoblast, osteoclast. First androgen effect is through estrogen. Why you are not targeting estrogen first?
I am not sure, ma'am, but the diagram which was represented, it's a complex process as far as I understand. The targeting estrogen will be beneficial or not, that I am not sure, ma'am.
No, I think to hypothetically answer her question, if you increase the estrogen, there are, men can also have breast cancer, so.
Thank you so much. Dr. Sachin, can I please request you to be seated in the dais? We will take a group picture after the session ends. The next talk is by Dr. Safi Gohar. Can I have the speaker, please? He will talk on the liquid biopsy in cancer care, real-world applications and understanding. This is the last talk of the day. So, Dr. Safi, over to you. Dr. Sachin.
Thank you so much for giving this opportunity, and I'll be talking about the liquid biopsy in cancer, some real-world examples, why it is important and how tissue biopsy...
Dr. Gohar, just a minute. There is a chairperson whom I have to call yet.
Oh, sorry.
Dr. Biren Banerjee, could you please come and co-chair the session? Dr. Sachin, please come to the dais. Thank you so much.
Yeah. So we'll be talking about the tissue biopsy versus liquid biopsy and the technology we use for liquid biopsy and role of liquid biopsy in cancer care, liquid biopsy beyond blood, and some actionability and resistance of NGS. So what we know that today the guidelines mostly advocate tissue biopsy approach, and we know tissue is an issue, and most of the time tissue unavailability are difficult to access the tissue, or sometimes tissue block is very old and may not be giving the recent information, and liquid biopsy has emerged as a powerful alternative to tissue biopsy. There are a lot of studies. This is one of the studies where they have shown a good concordance between tissue and liquid biopsy. And the reason why tissue biopsy is having a problem, it's impacting the success of what we are trying to do is because of tumor heterogeneity. We know that tumor is, a highly heterogeneous, be it a primary site, metastatic site, and may not be sufficient to get a complete picture of the cancer. And possibly liquid biopsy-based molecular profiling can help us to understand this tumor heterogeneity and possibly help us to detect the mutations which may lead resistance. And second problem is tumor is evolving, and as we know that we need to treat cancer at the seat of cancer, and this was one of the study where they have done the concordance between tissue and liquid. The time point between tissue and liquid was within 2 weeks, within 2 months, within 6 months, or more than 6 months. What you see is if tissue biopsy is more than 6 months old, you miss 40% of the information, and that information may be important for you to understand if there is a downstream underlying resistant mechanism. A few years back, ASCO has given a statement, even for patients who are able to undergo a traditional tissue biopsy, a liquid biopsy may be safer, quicker, and perhaps more informative. So when we try to do liquid biopsy, we talk about the ctDNA and often interchangeably used with cell-free DNA. What is the difference between the two? Cell-free DNA is the small DNA fragments in the circulation released in the blood streams due to the cell death, due to apoptosis or necrosis from healthy cells, mostly hematopoietic cells. On the other hand, ctDNA is the cell-free DNA which is released into the blood circulation from the tumor cells, and the size of the ctDNA is about 150 base pair long, and the half-life of the ctDNA is 2 hours, less than 2 hours. And what you see is the pictorial representation of the cell-free DNA and the ctDNA in the bloodstream. The blue dots represent the cell-free DNA coming from the normal cells, and the green dot represents the ctDNA coming from the tumor cells. It becomes literally, needle in the haystack. Thanks to the technology, we have now ability to identify few molecules of circulating tumor DNA from the huge background of the normal cell-free DNA. So why it becomes important, if we look into the 2023, the abstracts published in ASCO, there were about 370 abstracts published in various indications, various biomarkers using ctDNA-based liquid biopsy. A decade ago, in 2012, there were only 10 abstracts. That shows that field is significantly improving. So what does it mean to the one cell? In 2023, we had 9 abstracts in various indications, lung, glioblastoma, and the ctDNA-based, CTC-based work. And in 2024, we had 10 abstracts in ASCO, and 5 we had in AACR, 2 in ESMO, and 4 2 months ago in International Society of Liquid Biopsy. That sounds great, but what does it mean to the doctor like you? What does it mean? Some of the work which we have done with Tata Memorial Hospital, where we have been able to identify comprehensive molecular profiling based on the liquid biopsy to monitor the response to the treatment, and we could capture the progression at least 45 days earlier before it could have been captured by CT PET scan. Not only that, we have been able to identify some resistance signatures which are important to understand the molecular biology of the patients and can help us to decide the treatment strategies. So if you see the data of these patients, at the longitudinally, when we monitor them, at this initiation of the treatment, during the treatment, and the last time point, the patients who had responded and has significantly decreased the ctDNA dynamics, whereas those non-responders, it significantly increased the ctDNA. It shows and suggests that ctDNA is becoming important biomarker to monitor the responders and non-responders. And what does it mean to the patient? At the end, we look for the clinical endpoint. Now, if you see these two, progression-free survival and overall survival, you can see that, the patients who have at the baseline the resistance signatures positive have a worse outcome compared to those who have negative for these resistance signatures, trying to tell us that it becomes important for us to use the ctDNA-based, liquid biopsy-based biomarkers to segregate the patients who could do well or who could not do well. So we have also started the study again with Tata Memorial Hospital, where we are doing the concordance between tissue and liquid. Though it's in lung cancer, but we have started in other cancers, prostate and other cancers as well. But to showing here the data on the lung, at least those actionable markers which are in NCCN guidelines, what we see is if you do the tissue alone, you have about 84% of detection rate. It's not a sensitivity, it's a detection. And if you do the liquid biopsy, you have about 86% of detection rate. But if you combine the both, it increases the detection, those important biomarkers, to 97%. So that increases the possibility of targeted therapies for these patients very well. And as we know, there are a lot of guidelines talking about how to do, when to do tissue biopsy, when to do liquid biopsy, or possibly when to do both together. So this is one such guidelines, and in fact NCCN guidelines also recommends plasma, that's a liquid biopsy and tissue biopsy testing together, as we have seen now that both have shown some concordance and both have some false positives, and therefore complementary approach is better. And now we see the liquid biopsy based approach is having quick turnaround time that also helps us to treat patients immediately. And we have a number of data where they have shown that if you do the combination of both, and you have a higher chance chances of identifying the target, and therefore targeted therapies can be given, and have shown that patients who have got both tissue and liquid together have a better outcome compared to those who have tissue or liquid alone. And there was a study on that, the quality of life. Again, we have seen the patients who have given the liquid biopsy have a better quality of life compared to those who are doing tissue alone. And this is the meta-analysis of several studies. If you see here that the tissue biopsy is definitely proving nowadays more important. It has capturing more actionable mutations, therefore helping to decide the treatment options much better. There was one of the important studies that does this molecular testing timing matters. So the nutshell of this study was, if the test was ordered and if patient was treated after the report was received, and if patient was treated and then switched to the targeted therapy after the report has come, which say, the patient was treated and this treatment was not changed based on the molecular report. And you can see that overall survival in the patients where you have waited and then treated once the report has come, compared to those where you have treated and then switched, or you have not treated the treatment. So this is one of the case. Again, it's a tissue biopsy which was driver mutation negative non-small cell lung cancer, and in the liquid where we found the PTEN mutation, and there was an tumor mutation burden high. PD-L1 was positive on the tissue, planning for the immunotherapy, but as we know that PTEN is the negative regulator of immunotherapy, it leads resistance as it activates IDO, it activates T regulatory cells, therefore the possibility of a less response to immune therapy. So another example is, how these days we get variant of unknown clinical significance interpretation plays an important role. Dual EGFR positive patients was shown resistance to afatinib, wanted to know if there is a T790M or any other resistance mechanism. What we see is PIK3CA and MAP3 kinase and MET. So very importantly, when we try to understand, this is not a classical exon 14 mutation, but it's very close to that and possibly have a similar impact on the treatment resistance. And therefore, recommendation was done. EGFR inhibitors can be combined with MET inhibitors, and in fact, the resistance to EGFR tyrosine kinase inhibitors was avoided in their case. Another case, we normally do this, hotspot testing. This was an EGFR female who had a breast cancer history and adenocarcinoma of right lung, who was, driver mutation negative, and when we found EGFR positive, and after discussing with the doctor who was insisting that it's a negative, but then we asked the older report, we found that those was hotspot testing, and the one which we have found was not part of the testing. Therefore, suggesting, you should not always go for hotspot testing. And as we talk about the beyond lung, now we have, beyond blood, particularly, when we talk about liquid biopsy, we think about the blood alone, but we have other body fluids, like we have saliva, we have CSF, we have urine, we have, peripheral fluid, ascitic fluid, and how it is important now. What we see is, there is one case who was a brain metastatic non-small cell lung cancer who was EGFR positive, received, osimertinib and responded about 20 months, and then showed progression, was put on afatinib 6 months, again benefit of survival, and then what was important post progression, we did both blood as well as CSF. So what we see is, blood is negative, and in CSF we have exon 19 deletion with VAF of 92%, TP53 with VAF of 87%, and HER2 amplification 21 copies. So can that other body fluid, proximally collecting the body fluid, increase the sensitivity of the liquid biopsy? That's what we see is. So when discussing with the doctor, the first question was why we have not detected in the blood. But in CSF. So if we try to understand, if you have the parenchymal space of the blood involved, and the shedding happens in the blood. If you have leptomeningeal space involved, shedding happens in the CSF, and this patient was actually having the leptomeningeal disease, confirming the reason why you found in the CSF, not in the blood. The second question was, should we treat with osimertinib or EGFR inhibitor or trastuzumab? So understanding the molecular components run in parallel, therefore, this patient was put on osimertinib plus intra hypothetical trastuzumab in the month of May until today, patient is doing very well, and we are writing these case studies. And there are some case reports suggesting, how it becomes important. And, there are other parameters, I just want to skip it. To summarize that, it becomes very important to identify intra and intratumor heterogeneity using liquid biopsy. It can help us to identify the rationale for combination of monotherapy, and longitudinal monitoring becomes very important. We often give the bias towards the tissue biopsy, thinking it's a gold standard. The gold is becoming old, and tissue is the liquid is the new solid, and therefore the decision should be based on whether we want to understand tumor biology, tumor evolution, tumor heterogeneity. Thank you so much.
Wonderful talk. Any questions?
Yeah. So fantastic work. Yeah. And how do you manage to make so many papers and to ASCO and ESMO, and must congratulate you for that. When you are monitoring the disease response, okay, and you must be doing multiple liquid biopsies at multiple intervals. And there, did you find when the tumor acquire new mutations? Okay. What's your experience on those cohort of patients? Like when you do that there's a change in mutation pattern?
Absolutely. We have seen in patients, particularly those who are not responding, the new molecular mutations are arising, and if we try to understand them, they are actually the reason why the patients are not responding, are developing resistance. So what I see is, to ensure a long-term response for a treatment, we need to understand those molecular alterations which drive the resistance. So we have seen very frequently, patients getting new mutations there.
And my second thought is, we are in an era of like liquid is the new solid, or NGS is a kind of a reflex testing now. False positivity is not of a challenge. False negativity is a challenge. We are missing most of the mutations because of the tissue, as you mentioned, that it's the tissue degrades or changes its pattern, or from the area from where you have taken the biopsy, that depends. But here, they are the tumor shedding the DNA, and you are getting those ctDNA. Now, once you have the mutation like L858 or V700, here, if you get the positivity, you are sure the mutation exists. But if you don't get, you are not sure whether the mutation is there or we are missing something. So false negativity is a challenge here. Do you agree on that?
No, absolutely. That is the big problem as of now. But to some extent now we are trying to address that. Now when we say it's a negative report, and in fact I will say it's no mutation detected, NMD case, not negative report. Exactly. That's one thing we have to keep in mind. If it is negative, that doesn't mean it is not negative. We might have missed it. Second thing is we have incorporated in our liquid biopsy test called tumor fraction. So at least in lung, we know very well, we have a particular cutoff. If the tumor fraction is like 22% and less, and then there is a higher chance that we have missed the mutation. Absolutely. If tumor fraction is very high, then the possibility of missing is less. But we have to always be careful. If liquid biopsy comes negative, we should either do a reflex fresh tissue biopsy or a repeat liquid biopsy after some time.
What I gather from your talk is I think most of these studies are done on lung cancers.
We have what I showed in lung.
Whatever.
Yes, we have other studies. We have done in breast, we have done in colon, we have done in prostate, but that data is yet to publish. That's why I didn't show it
GU is still on the lower this one. It's not validated yet.
No, it's validated.
But, okay.
We have not published it yet. Okay. That's the reason I have not shown the data here.
Sir, I just wanted to know what is your experience on the fluids? On? NGS on fluids, peritoneal fluids.
Other body fluids. So that's what I'm saying. As of now, what we do is, apart from the blood, we do CSF, we do pleural fluid, we do ascitic fluid. So we are trying to validate urine. I do not know if we are going to be successful, but the other one which I mentioned, we can do it.
It has got a scope. Peritoneal fluid?
Peritoneal fluid also, it has a scope, yes. So in fact, that's why it becomes more, we have seen at least in, one case I showed CSF, blood you didn't find it, but it is there. Similarly, pleural fluid, we have not found in tissue, We have not found in the blood mutation, but we have found in peripheral blood. In fact, just submitted this work to ASCO 2 days before. So where we have seen it, there's a significant difference. You are getting in peripheral fluid, but not in tissue or blood. So that becomes important. Now, as you are the oncologist, you understand disease better where it is. So therefore, the recommendation of the tissue biopsy or a liquid biopsy or which type of liquid biopsy, you know better, and you should talk to lab and so recommend if that is possible, and we should take that sample.
Do you have any idea, any study about third promoter mutation in urine samples?
We are doing right now the validation. First our job is can we capture the ctDNA from the urine sample? Is that sufficient for us to doing the NGS? With respect to, there are some studies, they have shown that you can get it.
Yeah.
But
there are some studies which they say that the mutation is detected way before the cancer comes.
Yes.
Sir, it's a very important urge to repeat a biopsy at every progression. Are we moving towards a scenario where we have to repeat NGS at every progression?
Absolutely. If you ask me, yes, we have to do NGS now, every progression. And in fact, monitoring becomes now more important. If you target a patient, particularly like say immunotherapy, you have put a patient on immunotherapy. A patient is responding, when to stop. So it can help you to see whether you can stop the treatment, immunotherapy, and even not immunotherapy. Even if we talk HER2, 6 months versus 1 month in breast cancer, or in colon cancer, 3 months versus 6 months. So liquid biopsy is going the way that how to decide the treatment, when to escalate the treatment, when to de-escalate the treatment.
So progression or remission, the molecular pattern changes. So the best way to get a snapshot of that molecular pattern at that particular stage is getting an image. And liquid biopsy does.
My question is like, once the tumor is shredded from the parent cancer tissue, then only it will come to the liquid stage. Once it is from the tissue, it is shredded to the fluid. Then only you will get the liquid biopsy, not before that. Do you have a comparison if there is the same mutation is present in the tissue and in the shredded tissue?
Yeah.
Or there is a difference?
Yes, there is a difference. We have comparison. See, first thing is, can you get the same thing what you get in tissue? Because you have to show that it's as good as tissue. But what we have seen, we see the mutations which are not in the tissue, and you have there, and they are more important. So that's where now liquid is becoming more powerful, and possible reason is tumor heterogeneity, which you are inserting a needle, you get a biopsy, and you take some clones of the cancers, not entire tumor of the patient. So then the DNA coming only for those clones. And now the other clones you are not able to. Now if patient is shedding that DNA or CTCs, then you will get it. There is the situation, some patients do not shed at all, and you will not get. That's why it's important if we get a liquid biopsy, no mutation detected, we have to repeat a tissue biopsy, or we have to do a repeat.
We are moving to the era where you showed in one of your slides that 86% versus 82%, and then when you combine this, it becomes 97%. So to answer ma'am's question, we will definitely pick up the parent mutations in the tissue in the liquid biopsy, but we will also get additional mutations which we may not have, we may have missed here because of the heterogeneity of the tissue.
Absolutely.
Here they are very specific tumor DNA, but here we may get lot of normal cells along with the tumor cells.
Yeah, and in fact we have another technology that's only for research where we isolate the circulating tumor cells, and individually at a single cell level, at a one cell level, we do the molecular profiling. So if we get a 10 different circulating tumor cells, and we do 10 different sequencing and see whether they are same or there is a difference in the molecular profile. Yes, that we do with single cell genome. Yeah. Thank you so much.
Thank you. Thank you so much. As we come towards the end of the academic session for the day 2, I request everyone on the stage to please come at the center for a group picture. Thank you so much. Thank you. So we'll start the formal inauguration, followed by cultural program, felicitation, awards, and then the cultural program in a while. A 10 to 15 minutes break by the time we wait. of the International Congress on Frontiers in Urologic Oncology and Uropathology here in this beautiful city of temples, Bhubaneswar, Odisha, India. We have gathered here from across the globe, united by our commitment to advancing the frontiers of science and medicine in uro-oncology and uropathology. I hope you all have witnessed groundbreaking presentations and exchanged ideas that will change some practice in tomorrow. Now, we are moving on to the formal inauguration ceremony. I kindly request everyone to please stand up for the national anthem, a unique rendition created by Grammy Award-winning composer Ricky Cage. But what makes this rendition even more special is the heartfelt contribution of the 14,000 talented students of Kalinga Institute of Social Sciences, creating a Guinness World Record.
Thank you so much. Kindly be seated. This was the national anthem. It is now time to formally invite our distinguished dignitaries on the dais. First, I would like to invite Dr. Urmila Senapati, the organizing chairperson and the senior professor in the Kalinga Institute of Medical Sciences. Dr. Ramachandra Das, AVM, academic dean and principal, Kalinga Institute of Medical Sciences. I would request the dignitaries to kindly come to the dais. Dr. Rajal B. Saha, President of Gynecology Pathology Society, GUPS, from Texas, US. Dr. Sambit Kumar Mahanti, Organizing Secretary of this amazing conference. Dr. Saurav Kumar Mishra, Associate Professor at All India Institute of Medical Sciences, Organizing Secretary of the conference. Dr. Ranjana Giri, Organizing Secretary, Head of the Department of Pathology at KIMS Hospital. Dr. Rudra B. Satpathy, CEO of International Associations of Integrated Oncology. I would request the dignitaries to be seated. We welcome all the dignitaries to the dais. We now will proceed with the lamp lighting of the ceremonial lamp. I invite our esteemed dignitaries on the dais to step forward to light the lamp.
We now move towards the welcome addresses. Can I please call upon Dr. Ramchandra Das to please address the gathering? The principal. Yes, sir. Please. Sir, एक पेज इसमें पीछे से पूरा लिस्ट फर्स्ट पेज में पूरा लिस्ट में ये वाला there is a fresh the sequences are जब मैं 1 2 3 4 7 success Dr. Anjana.
Good evening, ladies and gentlemen. It's indeed a privilege for me to stand before you for inauguration of this meeting. Honorable member on the dais, I thought I will just name because Urmila madam and Ranjana madam, I know both of them. They are heading it. Other members, Dr. Ajal Saha, he is President Genitourinary Pathology Society. Dr. Sambit Mahanti, Dr. Saurabh Misra, Dr. Rudra Satpathy. I think they are the honorable member on the dais. They are probably the crucial people who organize this meeting. And of course, most important people are the delegates and people coming from outside, especially international delegate and of course national delegate. The whole meeting, the conference is meant for you. It's customary on my part as a dean, principal of KIMS to welcome you and speak a few words about our institute and of course to welcoming each one of you for this purpose. Kalinga Institute of Medical Science is a young institute which started sometimes in 2007. It's a 2,600 multi-speciality hospital with 600 ICU SDU beds, 250 undergraduate, 200 postgraduate and 100 DMMCH with 45 PhD students within a period of last 15 years. And we run almost all DMMCH courses, and our 100-bedded cancer center is one of the state-of-art center. Our whole issue is that we try to encourage each department to become functionally independent and grow further. We'll talk about pathology a little later, but before going to, we must see our parent institute. Our parent institute is Kalinga Institute of Industrial Technology called KIIT, popularly known as KIIT. It's an institution, something different. It's located in the heart of Bhubaneswar capital city, 36-acre township, 30 campuses, 30 international food courts for catering the taste bud of all part of the students. And we have got 15 different places of sports and we have got 15, first time in a university, any university in the world, especially Paris Olympic, 15 students of KIT participated in Olympics, Paris Olympics. It is a very unique thing. I think nowhere you can see so much of students participating. And besides that, there is a feather on the cap. I was talking to Dr. Bedi. He was asking me, he's from Amritsar, but he was asking me, he heard something about KISS. This is a jewel in our cap. Kalinga Institute of Social Science is an institute, a university, caters for tribal students from KG to PG, free of cost, free boarding, everything on that. And I request each one of you, if you can get a time, tell us, we'll show you. It's always a pleasure to see KISS students, how do they participate. This is only possible because one man, our honorable founder, Dr. Achyuta Samanta, who had seen his life in a very poor condition, who fights for a meal every day, and he established so many things, thinking that education is the third eye. And he feels that that's the way he can change elevate the poverty. Elevate poverty is not by giving food and money, but providing education, so that empowering them, that will grow up. That's the way that vision comes up. Our KIMS, all of you are there, our KIMS never built on a business model. So many hospitals are built on a business model. As a dean director, I am saying which never asked on a business factor. This is bent on a social bent of mind. Why I am saying? This is probably only the hospital, to best of my, I visited all over India because I am from a defense background, I visited the rest of the countries. But I found this is probably the only corporate hospital where general bed is also air conditioned. There are 1,300 general beds centrally air conditioned with free food. And that is for the BPL patient, below poverty line patients. For super specialty and all that, that's different thing is there. But for a general patient, getting a air conditioned bed and free food is very, very difficult to any place. This is just, that's why I say it's a social bent of mind. If you see a profit, every day we lose 523 rupees per bed. But doesn't matter. But he says, people should not, patients should not feel, मेरे पास पैसा नहीं है तो मैं ऐसे में पढ़ाऊँ, उसके पास पैसा है तो एसी में रह रहा है. If you see a person with a external fixator, orthopedic fracture and all, it's very difficult to see. In a summer, Odisha is 10 months summer, it is very, very difficult to see. So these are the conditions probably we look at a different angle as compared to rest of, that's what our edge over the other part. Besides education, our ranking, that I don't want, it looks that I am glorifying myself. So I am not talking about my ranking and plan, that's everything available, or university ranking. But I just say some edges that how we are little different from other places. Coming to the conferences, I really thank the organization when you have decided to do it at KIMS. Because you are renowned experts and brilliant minds. When you engage, you create wonders. You create innovations. That's the most important. And unless this is what I was told, this is something unique type of conference where oncologist, urologist and pathologist join hand. Probably that is the future line that you must show to the other part of the branches. In our department, our pathology department, we focus people on specialization. People focus on nephro, people focus on liver, people focused on uro, people focused on onco, because that's the future. Because you cannot jack up all trades every time. So our pathology department also making on that line. That way, I feel this conference will take us a long way in planning our empowering our pathology department. I'm sure in this conference, because you all are expert on this field, but what I believe or perceive, most important thing you must be discussing in the future, how uropathology will grow. 2-3 areas that it can grow. One, digitalization. You digital pathology, application of artificial intelligence in diagnosis, creating new biomarkers, and especially looking at certain area where you find a diagnosis is difficult. This is a crossroad, diagnosis is difficult, benign or malignancy. These are certain areas difficult, probably you will create some areas that how you can make a distinction become much easier. Lastly, I must say, any management of patients, you people are on this crossroad, your decision directs the treatment and outcome. Because you are standing on that crossroad between diagnosis and treatment. And your decisions can always detect and plan the patient outcome. So wish you all the success. Enjoy your tenure. I am sure that you are waiting for your banquet. Will not spend much time. And I only say that if you have some time, visit KISS. We will organize for you to visit KISS. Thank you.
Thank you so much, sir. Now I would like to call upon Dr. Rajal B. Shah to share a few words.
Namaste, everybody. Respected Chief Guest, Dr. Ramchandra Das, respected patrons, organizing chairpersons, secretaries, committee members, esteemed faculty, and delegates and friends. On behalf of Genitourinary Pathology Society, it is an immense pleasure and honor for me to welcome you all to this first ever International Congress on Urologic Oncology and Urologic Pathology in this beautiful temple city of Bhubaneswar. I can say that it has been a dream come true for me. This idea was born almost 2 years ago when I was discussing bringing such a CME with Sambit Mohanty, Dr. Sambit Mohanty in USA. And I can say that I think we could have not found a better auspicious place than Bhubaneswar, the abode of Lords, Sri Jagannath. So we are very proud to collaborate with local organization KIMS, AIMS, Odisha Society of Oncology, and International Association of Integrated Oncology to bring this very fruitful exchange of knowledge, cutting research and insights amongst pathologists, urologists, and oncologists. I would like to thank several people, particularly Dr. Sambit Mohanty, Dr. Saurav Mishra, Dr. Anandi Lobo, Dr. Ranjana Giri, and many others who have spent countless hours to making sure that this event becomes a grand success. I would also like to thank faculty, particularly international faculty who has traveled long distance to share their valuable time and knowledge in sharing this knowledge feast. Finally, I would like to thank all the delegates members to make this event a very interactive and successful, and we really hope that we will in future doing more this kind of sharing of knowledge between different part of world. So thank you very much.
Thank you so much, Dr. Shah. Now coming to the inaugural address by the organizing secretaries, our very own. First, I would like to invite Dr. Sambit Mohanty for the inaugural address.
Good evening, everyone, and good evening all the brilliant minds who are gathered here and what we are going over the journey. Particularly, I would invite our own principal, Urmila Madam, who was my first teacher in pathology when I was a little kid. I was basically a toddler in medicine, roaming around and wandering in the SAB Medical College. Ranjana, a dear friend, and my brother Saurav, and a teacher and a visionary, Rajal. So, as Rajal said very correctly, once we are just discussing to do something in India. It was close to 2 years. So we said, why not in Bhubaneswar? He said, do you think it's a good place? I said, yeah, it's a place where I was born, and I haven't done anything for my state so far. Probably I'll do like 2% of what the state has done for me as like a payback. So we decided, Saurav is the main person who helped me immensely throughout this journey, and my very good friend Ghansham, who is sitting there, and all the seniors who basically helped us in very small bits. And I'm particularly thankful to Dr. Amin, because on the side track, I was talking to Dr. Amin, who basically made me a urologic pathology, who was my mentor in the residency and my fellowship time, to guide me through whether I'm doing anything erroneously wrong or I'm in the right track. So this would help us to kind of send email and call the friends who are all over the place, mostly in the US and the UK, and some seniors who immediately said yes, just decide a date, we are going to come over. So we could gather about 17 international faculty. 2 are not here, who are going to come. 2 of us are very dear friends. I always say, like Ankur Sangoi from Stanford, Son Williamson, who is sitting here, Cleveland Clinic, Rohit from Michigan, Mahmood from Harvard, and myself. So we have a small group of kidney tumor lovers. So we love kidney tumors, and we kind of see our future in kidney tumor. Well, a little bit we do. So all of them said yes. So they are going to give their virtual talk tomorrow. So finally, I would say, like this conference hall, which was a room, a lot of conference going on in this venue, has been a combination of innovation, collaboration, and groundbreaking discussion for the last 2 days. So let's this curiosity get into good conversation, and it gathered us not just to hold the power, just to envision better outcomes, but to actually make them happen. I cannot finish my talk without thanking 3 very important people. One is Seema Kaushal, Professor of Pathology and Director of Urologic Pathology at the AIMS. Anandi Lobo, a very vibrant urologic pathology in Raipur, and Ranjana, who kind of helped us throughout, and IO. Rudra is the founder of IO, who basically, I was scolding them every day, right and left, and sometime I call him 2 in the morning, let's just do it and finish it up. And so let's make these 2.5 days, what we have gone through the 2 days, almost unforgettable, with science, collaboration, friendship, and a strong bond for lifetime to help our patients in uro-oncology. And thank you everyone who are present here and who are going to join us for the banquet for this vision and celebration. Thank you very much.
Thank you, sir. I am glad to invite Dr. Saurav Kumar Mishra for his inaugural address to this crowd.
Good evening, everyone. So maybe what I can do is that I can just take you through the journey of where we are today. Now, on the face of it, to conduct a conference where we have pathologists and clinicians, it would sound absurd. None of the conferences do happen like that. You would have clinicians doing a conference, you have pathologists having a conference. So at the onset, the idea of having a conference where we have the pathologist, the molecular oncologist, anyone who is related to genitourinary oncology, it made sense only because we were friends. So myself and Dr. Sambit, we started working together, writing papers. That was the COVID time where it started, and then we have been friends and brothers throughout. So at the face of it, when we discussed about this idea, and it came from Rajal, that yes, we can have such a conference. So that made sense because we had a common vision. Yes, this sort of a conference is definitely possible. I'm really happy today that at the end of the second day, with more than 500 registrations, delegations, faculties from India and abroad, we have definitely been able to make this conference a great success. Leaving aside academics, there were a lot of discussions, scientific discussions. What this event has done to us is that we have made lots and lots of new friends for the rest of our life. Our friends have come from the USA. We had a very good time, and for the rest of our life, we are going to be with everyone, collaborating, having conferences, meeting, everything going on. The most important part, which I would like to emphasize here, is that what here we are seeing is an organization at KIMS. We are having this event. Madam was benevolent enough, the KIMS has been benevolent enough to provide this space. But what has happened behind to make this event, probably very few of us know. There has been immense contribution from a lot of support staff and from the pharma people. So I would like to ask all of you to give a big round of applause for them. They have been tirelessly working for the last almost from 1 year when we conceptualized this concept of this event. Background like from travels, accommodation, scientific programs, there have been lot of people event. So we cannot name everyone, but definitely on this occasion, I would like to thank everyone who has come here and who has contributed in making this event a success. Finally, this is just a beginning. We are going to have many of these events in future. So thank you everyone for coming here.
I now call upon Ma'am Dr. Urmila to please come and share a few words.
A very good evening to all of you. It gives us immense pleasure and has been our proud privilege to organize this academic extravagant International Congress on Frontiers in Uro-Oncologic Pathology. Earlier to this, we have organized many conferences, but still I remember that in 2016, in the month of January, we conducted one APNA, same the 17 international delegates or speakers and 7 national speakers. But that was quite different from this, and Dr. Rajal Saab was one of them also. So from 2016, I knew him. He was a very good person and a very good speaker, and presented to us during that time also one of his book that is on prostate pathology. But this time, I feel that a conference of this magnitude and focus has been really helped in crunching out minds and expanding our thought process while handling our daily practice. It has helped the general practitioner or the practicing pathologist to learn from experts in the fields in just one forum. It has helped us to realize the need of the clinicians and how pathology plays a pivotal role in the multidisciplinary patient management. And I personally feel that without throwing mods at each other, the clinician and the pathologist, we should work in hand to hand, and we should know that what the clinicians need from us, from our report, and so also the clinicians also should understand our limitation. I sincerely thank all the national and the international speakers for coming from such a great distance and sharing their knowledge and expertise and experience with us. I once again thank all. Namaskar.
It is now time to unveil a special highlight of this event, our conference souvenir. This souvenir is a celebration of ideas, efforts, and milestones we have achieved together for this conference. To do the honors, I would invite the esteemed dignitaries. The soft copies of the souvenir will be emailed to all of you.
Now it's time to felicitate our international dignitaries we now move towards the felicitation ceremony. We would like a heartfelt gratitude and welcome again to the international delegates. Can I call upon one by one? Can I please call upon Dr. Mahul B. Amin? I would request Dr. Ramchandra Das and Urmila Senapati ma'am to be on the stage to felicitate. And Dr. Raj. We'll take a mic. Dr. Christine.
Thank you so much, Dr. Amin. I would like to call Dr. Krishina Majai Galuzzi for the next felicitation.
We already have our next international delegate on stage already. It's Dr. Rajal B. Shah to please accept the felicitation.
Thank you, Dr. Shah. I request Dr. Murli Verma to kindly come to the stage. Thank you. Thank you so much, Dr. Murli. Now I please request Dr. Gladale Panay to please come on the stage and accept the felicitation.
कटा हुआ है ना इसके बाद वो इंटरनेशनल लाइफ टाइम अचीवमेंट अवार्ड
Ready. I request Dr. Rohit Mehra to kindly receive the award.
Thank you. Thank you so much. Now we next have Dr. Jasmiran Dhillon. Please come up on the stage.
Next, I request Dr. Sean R. Williamson to kindly grace the stage. He's there.
Thank you. Thank you so much. Now I would like to call upon Dr. Ajay S. Alva to kindly please come on this. Oh, he's left. Sorry. I'm very sorry. He has been felicitated earlier. It's, may I call upon Dr. Sandy Srinivas to please come on the stage.
Second last. Let them take time.
Who's here with his family? उनकी family को भी बुला लेना. Family को बुला लेना.
Next, we have Dr. Andreas M. Acosta
With his beautiful family.
with the beautiful daughter over there who've been looking at.
You can bring him along.
Kindly bring your daughter along. Yeah, your family as well. Your family is also invited to be felicitated, sir.
Oh. Dr. Rajan नहीं तो फिर नहीं बुलाएंगे भाई को जाके बोलो संदीप भाई को राजन
Meanwhile, Dr. Rajan Arora, he's supposed to come. In the meanwhile, I will request all our international faculty and dignitaries to kindly grace the stage for a group photograph. You all are wearing beautiful ethnic Indian attire. Yeah. So, and all of us over here, they have come from all over the world, different countries, and wearing vibrant Indian attire. We have to clap for them. I would also like to request Dr. Anandi Lobo and Shima Kaushal from the organizing committee to be on the dais here. Yeah. Dr. Rajan Arora is here. I would like the committee to will simultaneously do the felicitation for Dr. Arora here. Sir.
Madam.
Thank you. Thank you so much, all of you. It's our absolute pleasure to have all of you here. Yeah, we have to felicitate. So we now move towards Lifetime Achievement Awards section, where we have 14 awardees today. So we start. Can I please call upon Dr. T.S. Ganeshan, medical oncologist, kindly come on the dais to get the award. Dr. Ganeshan has dedicated his service in the field of medical oncology. He has mentored numerous medical oncologists, and some of them are of international repute. Do we have Dr. T.S. Ganeshan here? Okay. I know, yeah. All right, so we can call him later. We have next. So can I please call upon Dr. Mahesh Desai, the urologist, and requesting Dr. Shailesh Soni on his behalf to collect his award. Who doesn't know Dr. Desai, the eminent urologist who has contributed tremendously in the field of endourology and uro-oncology. Can I please call upon Dr. Rohit Mehra to felicitate the award? Okay. So listen. So the next Lifetime Achievement Award is to be given by Dr. Amin. Can you please have you on the stage, please? And the award is being given to Dr. Vijay Kumar Nanda, the renowned pathologist, on behalf of whom Dr. Urmila Senapati will accept the award. Dr. Nanda, who is an efficient person and played multiple leading roles in Indian pathology with Odisha. He has a versatile personality and has been awarded Sahitya Akademi Award and Sangeet Natak Akademi Awards as Best Drama Awards. Dr. Urmila happens to be a student of his, if I'm not mistaken. Okay, yeah. Yeah.
We have Dr. Ganeshan now with us. Can I please invite Dr. Mahul Amin to present the award to Dr. Ganeshan? Dr. T.S. Ganeshan, he's for his dedicated service in the field of medical oncology. He has mentored numerous medical oncologists, and some of them are of international repute. We celebrate your lifetime journey in the field of oncology.
Professor Ganeshan happens to be a mentor. More than that, he was a friend to us at Cancer Institute Adiyar. So this conference would have been incomplete without him. So thank you, sir, for coming down.
Thank you. Thank you so much, sir. Now we have, can we please have Dr. Christina Magji-Galuzzi to present the next Lifetime Award, Achievement Award to Dr. Amit Joshi, medical oncologist, who is a vibrant medical uro-oncologist, currently at the peak of his career, a great teacher, researcher with many, many contributions to the field. Dr. Amit Joshi, please. He's not here.
Professor Joshi is currently with Tata Memorial Hospital, and he has immensely contributed to the uro-oncology in India and in the world over. Thank you, sir.
I would request Dr. Christina Majai Galuzzi to stay back in the stage. The next recipient of the Lifetime Achievement Award is Dr. Gajendranath Mohanty, Gyanendranath Mohanty, I'm so sorry. He's known for his immense interest to take pathology from the state to national level. Sir has a very pleasant personality with dedication dedicated to pathological services. Dr. Gyanendra Mohanty.
Sir has actually made Odisha pathology to the national and international level and is the first one to establish the IAPM headquarters in Cuttack and taught most of us, and not just a teacher, is a friend and a loving personality.
Thank you so much, sir. Thank you. May I please request Dr. Rajan Arora to kindly come up the stage to present our next award. The next Lifetime Achievement Award goes to Dr. Rabi Narayan Malik, pathologist. On his behalf, Dr. Ranjana Giri will accept the award. So Dr. Rabi Malik he may have a very strict demeanor, but at heart he is soft. He has extreme degree of passion and dedication for mentoring and has groomed many pathologists in the room currently. So the award for Dr. Rabi Narayan Malik being accepted by Dr. Ranjana Giri.
So without saying a few words about Sir would not be good if I'm standing here. Sir has a major contribution and dragged me to the field of pathology when is the medicals. And see, he is the single man who basically taught me, and he told me one thing: if you do like an MD student during your medical school, then are good to go to pathology. It caters to all discipline. And he has been mentoring people for over 40 years. He goes to every medical college and teach for free in the state of Odisha. And today he could not come because he is preparing the students for MD Viva exam, which is going to be on Monday. So he said he is going to be awake all night. And there are three people who had pivotal role in my life. One is Dr. Amin, Dr. Senapati, and Dr. Ravi Malik. Thank you.
For the next award, I would like to invite Dr. Andreas M. Acosta to present the Lifetime Achievement Award to Dr. Sangeeta Desai. Dr. Desai is a pioneer in the oncology biobanking in India and has introduced formal uropathology education in the country. She is a loving personality and she is a great academician.
Dr. Desai, to whom I fondly address as Didi, and Didi has basically, we all came late into the picture in uropathology, but she actually started the journey long back at Tata Memorial Hospital, spending relentless hours, and actually we are the followers. Santosh, Shima, Sangeeta, and myself, we kind of follow her path, and she has extreme dedication, and she's just retired from the Department of Pathology at Tata Memorial Hospital, Bombay, as a professor. And still she is getting ready to the next academic journey in the next 2 months, she promised.
Thank you. Thank you so much. Can I please call upon Dr. Murli Verma to present the next Lifetime Achievement Award to our Dr. Surendra Nath Senapati, radiation oncologist. He is the current President of Radiation Oncologist Society of India. He has exceptional brilliance in teaching, clinical practice, and academics. He's a wonderful personality, has been very active over the past 2 days, and we are fortunate to have him here.
So the field of oncology in Odisha owes a lot to Professor Senapati, Acharya Harihara, which is at the helm of affairs in oncology care. Professor Senapati and Madam have been one of the pioneers in establishing that institute into an institute of national repute.
I kindly request Dr. Jasriman Dillon to present the next Lifetime Achievement Award, and the award is to be presented to Dr. Prafullo Kumar Das, Surgical Oncologist. We are fortunate to have Dr. Das with us today. He has tremendous contribution in the field of surgical oncology in the state. He has been very widely famous for his interest in education and research, and he has brought research to the state.
Sir is always enthusiastic. Now academically he is associated with Utkal. He has started the DNB courses there. So he was the president of the Indian Society of Surgical Oncology, and throughout he has been very much instrumental in making these events as a pretty successful event. Thank you, sir.
Thank you so much, sir. Can I please have Dr. Sian S. Williams on the stage to present the next Lifetime Achievement Award? And the next award goes to Dr. Sushil Giri, the gynec oncologist. Dr. Giri is a renowned gynec oncologist who has contributed greatly in various leadership positions in Acharya Harihara Research Cancer Center and in many other eminent institutes. Congratulations, sir.
I next invite Dr. Gladel B. Panair to present the Lifetime Achievement Award, and the next award goes to Dr. Padmalaya Devi. Dr. Padmalaya Devi has over 3 decades of rich experience in oncosurgery. She has held esteemed roles, including being the Dean and Principal of the Regional Cancer Center in Odisha. She has significantly improved the academics and clinical landscape in the Society of Oncology in the state of Odisha.
Dr. Padmala Devi was the first one to brought formal MCH program in surgical oncology in Odisha, and she's one of the pioneers to start this.
Thank you so much. Can I please call upon Dr. Amin to kindly come on the stage to present the next Lifetime Achievement Award to eminent Dr. Kripa Sandhu Panda, sir. He is not here today. On his behalf, I would request Dr. Saurav to take the award. So, Dr. Panda has a long period of commitment to deliver high-quality cancer care. Most importantly, He is the one who introduced the oncology care, the cancer care in particular, to the state. For a long time, he was the only oncologist in the state. Thank you so much, sir.
Dr. Panda basically exposed the state of Odisha to the concept of oncology. The state was not, I mean, they're doing in small pieces, but it was formally introduced by him.
To present the next award, I call upon Dr. Sandy Srinivas. The next Lifetime Achievement Award goes to Dr. Sanjay Bedi. Dr. Bedi is the first pathologist in the country to bring the concept of digital education, e-teaching and bioethics. He has been running Medical Education Institute for close to 2 decades now. Dr. Bedi.
So Dr. Bedi, staying in a small city of the country, but brought us a lot of valuable insight. He tried to give education to the entire country in multiple digital platforms so that MD students, even if they do not have the right resources in their center, they can be exposed to the national and international leaders and all their teachers. And he's one of the person who has encouraged me in 2017 when new to the country to start digital education. Even if you are not in an academic center, you can still teach and help the crowd. He is a great person and we should celebrate his lifetime.
Can I request Dr. Sandy to please stay back on the stage for the next award presentation? The next Lifetime Achievement Award goes to Dr. Ravindra Sabnis. He is an eminent urologist. On his behalf, his daughter, Dr. Shruti Sabnis, will accept the award. Dr. Sabnis is a surgeon who is an enthusiastic teacher and very passionate about advancement in the field of urology, education, and research. He is a true mentor, and we can experience his charisma once he is here in person tomorrow.
Dr. Savnish is another great teacher who is passionate about teaching and writing, and Shruti is a uropathologist, young, vibrant uropathologist. When I told Shruti you have to get the award for your father, then he said, why? Why are you giving? The first reaction, why are you giving the award? I said, why? Do you want to go to US for your training? You better behave now, otherwise. So anyway, Dr. Savnish is a great person, a very humorous personality, and a strong advocate of training, education, and research. And he's going to be here tomorrow.
Thank you so much. I would like everybody to give a huge round of applause for all the awardees of the Lifetime Achievement. They have really contributed immensely to the field of pathology, urology, and definitely oncology. To give away the vote of thanks for the sessions, I would like to call upon Dr. Rudra Bhanu Satpathy, the CEO of IAIO.
Esteemed dignitaries, all revered international faculties, esteemed guests, and all ladies and gentlemen of this evening. As Bhagavad Gita says, Sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani pashyantu ma kaschid dukha bhava bhavet. So as our civilization, customs and beliefs encompasses that our responsibility starts to create valuable insights for future generation. Our country have been believing on the concept of Vasudhaivam Kutumbakam, the entire world is my family. With this concept of Kutumbakam, we work to establish communities. I express my hearty gratitude to each and everyone associated with International Conference in Frontiers in Urologic Oncology and Uropathology today. My heartfelt thanks to all our chairpersons, speakers, faculties, especially our organizing committee members, and all valuable dignitaries. I express my gratitude to people, those who have taken the pain to travel from nook and corner of the globe, long way to Bhubaneswar, in spite of few challenges in logistics because of New Year's, Christmas and Pravasi Bharatiya Divas. I express my gratitude to the organizing team, to the entire campus of Kalinga Institute of Medical Sciences, the operations team, the facility team, everyone involved in this. I express my heartfelt thanks to presenters of oral and poster presentations, those who have been part of this conference and added values and insights to this conference. I express my gratitude to especially our chairpersons, Dr. Sanapati sir, our speakers, valuable people here all, and I feel my heartfelt gratitude on these regards for this valuable conference, and the leadership of Dr. Saurabh Misra, Dr. Samit Mahanti, Dr. Ranjanagiri, our organizing secretaries, and it gave me a lot of opportunity to learn from them. I believe this conference will be ever fresh and live in our memories. Thank you. Now I would request our dignitaries to give us the space to commence the cultural program. We have a valuable event today to be hosted by Ms. Jhanja Das to take over Odisha, which is India's best kept secret. So she will be enlightening all of us about the culture, the tradition, the customs, the valuable insights of this beautiful state. So welcome to you, ma'am.
Before we commence to the next cultural program, Rajala and I were here. We actually very recently lost one of our friends who developed the Society of Kidney Tumor Friends in Czech Republic, Dr. Andres has. And so we should all, I would request all of you to stand up and we should give a prayer for him. And Rajal is going to say a few words about Andra.
Dr. Andra was very dear to all of us, and he is, perhaps many of you know, that has described many entities in kidney tumor pathology that we make diagnosis every day, and it was very unfortunate loss, and we really dearly miss him.
And Saurav and I and Ranjana from the organizing team, we are extremely thankful to Dr. Rudravanu Satpathy. Without him and his wife Sonali, this conference would not have a success. And now we are moving on to introduce Ms. Jhanja Das, and who is going to take us through the heritage of Odisha and through her brilliant talk. She is a storyteller. She has a master degree in science, coming from a master degree in science with a lot of versatile qualities within her. Spent almost 2 decades to raise her kids and take care of her husband and in-laws. She is actually one of my first cousin's daughter-in-law, so my daughter-in-law basically, but we grew up together in the school. So she has a lot of talent, and now she's a professional storyteller of the international fame and a lot of cultural innovations. So she's going to take us in the next 15 minutes to the heritage of Odisha, which is sort of hidden in the history of India. Thank you. Welcome, Jhanja.
Chacha Sasur. So, and I'm taking his name for the first time, otherwise I call him Dada, even though he's younger to me. So when he asked me to speak few lines about Odisha, I'm a storyteller and I narrate stories to young children. So having such, esteemed doctors in front of me, this is my first time that I'm going to speak in front of the doctors, and particularly when I'm scared of doctors, and particularly the branch that you all are from. How many of us sitting over here who are students here in India, they have done their schooling, you had general knowledge, GK as a subject during your school days? How many of us over here? Yes, ma'am is raising her hand. Many of us. But I think now they don't have general knowledge, GK as a subject in the school curriculum. And during those days, there was one question which used to really hurt me, I think every Odia. Which is the state with the lowest per capita income? And the answer was Odisha. So it was really very painful as a school student to know that your state is having the lowest per capita income. But today, here I stand as a proud Odia lady, where my state has gone up the rungs of the ladder on the index of per capita income. And Odisha is now buzzing with technology and infra, and just name any field and Odisha has arrived on the global map. So I proudly want to say that Odisha, with the increasing rate of literacy, has been able to produce such intelligent people who have conquered the world in any field that you can name it. So now, let me take you on a journey to a state which has always been overlooked. But I promise you, it has many incredible secrets of India. That is why Odisha has got the tagline that India's best kept secret. And Odisha is not only rich culturally, but it has amazing, breathtaking landscapes which you all can visit. And I hope within this short stay, you will get to see the unmatched hospitality that Odia people can give you. So it's a treasure trove of culture and heritage. Next. So as I welcomed you all by saying Jai Jagannath, Jagannath, the resident deity of Odisha, whenever I go to any place in India or maybe outside also, if you say that I'm from Odisha, everybody would say, the first thing that they would say, Puri Jagannath. So that's our identity. Every Odia identifies himself or herself with Lord Jagannath. And Lord Jagannath is not worshipped as just God. Every Odia finds him to be a member of his or her family. And instead of calling Prabhu Jagannath, we have n number of nicknames for him. Kaliya, Jaga, Chakadola, many things. So the Jagannath temple, it was built by King Anantavardhan Chudagangadev in the 11th century. It's not only a spiritual and architectural marvel, but also home to the world's largest kitchen. The kitchen, why I said we have unmatched hospitality, because on daily basis, around 100,000 devotees can have meals there. And the cooking and the kitchen, the way the food is cooked there, the prasad is cooked there is very unique, which almost all Odias over here, they know, the Rusoghara has got 752 clay ovens, and the prasad is put on 7 layers. 7 pots are kept on one of the ovens, and the pot on the topmost, it gets cooked first. So a lot needs to be explained scientifically how it is done. But the traditional cooking style continues from the day it has started, and we cannot change that. The recipe, the style of cooking, everything. And you'll be astonished to know that none of the preparation over there can be tasted, whether the salt is perfect or not, and not for a single time that you'll be disappointed with the quality of Mahaprasad that you can enjoy there. So that's how our temple, our deity is so unique. And then we all know that the grand Ratha Jatra that attracts millions of devotees, and this is also very unique to our Lord, because he's the only deity who comes out of his temple and wants to meet all his devotees, and he's not biased. He doesn't discriminate between any caste, color, creed, or religion. So anybody is welcome during the Car Festival. So I must say that you must visit Puri and enjoy our Mahaprasad too. So there's a small story that Samba was the son of Krishna, who was a prankster. And he used to play pranks. So one day he just crossed his limits, and he was cursed by Krishna that you will suffer from leprosy. But later on, Krishna realized that he wasn't to be blamed completely. Lord Muni Narad had something to play with him. But he cannot take back his curse. So he just softened it. And he said that if you pray Surya Devta, the sun god, then maybe you'll be cured of your leprosy. And he sat on penance for 12 long years, and then he was cured from his leprosy. And the Konark temple is built exactly at that same place. This is a UNESCO World Heritage Site, and it was built by King Narasimha Deva of Eastern Ganga dynasty. Now this is dedicated to the sun god, and this architectural marvel is shaped like a giant chariot. It is called as the chariot of the sun god, and I think everybody should be visiting this because it's completely unique. And there are many folk tales related to this also, because 1,200 craftsmen were employed by Lord King Narasimha Deva, but for 12 long years they constructed the temple, and king was irritated, and one final day he said that if by tomorrow the temple crown is not fixed, then you all are going to be executed. And everybody was scared. And then suddenly the chief architect, his son arrived. He was just 12 years old, Dharma. And he heard everything. He just went up and fixed the crown. And all the 1,200 craftsmen, instead of being happy about his achievement, they were very scared that if a 12-year-old boy can fix the crown, we could not do it for 12 years. So as it is, the king is going to execute us. So hearing this, Dharma was very sad. And so he jumped and gave his life, and Dharma was dead. So that's a very sad story behind Konark also. And you will find many memes on Instagram and the social media that Odia people are very, lazy. They eat fermented rice, pokhada, and they love sleeping, and they don't work really hard. But I would like to say that this Dhauli Stupa is proof enough that the Kalinga warriors, they gave a tough fight to Lord Emperor Ashoka, who was the greatest conqueror. And here itself, after the Kalinga warriors gave him a tough time, even though he won the battle, but he was really sad seeing the bloodshed. So he surrendered himself to Buddhism, and from the conqueror, he became the worshipper. As in Hindi and Odia we say, from Chanda Sukha to Dharma Sukha. So this Dhauli Stupa is also worth visiting. This is a peace pagoda. It was built by Kalinga Nipan Buddha Sangha and Japan Buddha Sangha. And you'll have great inscriptions on this about Ashoka's transformation. So if we come to talk about Odisha's natural wealth, then it's truly a gift to India. Odisha's natural beauty is unparalleled. And the serene beaches of Puri and Gopalpur, the lush greenery of Simlipal National Park, and the captivating waterfalls like Bareipani and Duduma make it a nature lover's paradise. For wildlife enthusiasts, Chilika Lake is a must visit because it is Asia's largest coastal lagoon and offers a chance to spot rare migratory birds and Irrawaddy dolphins. I must tell you something that Odisha was the first state in India which was created on the basis of language, not on geographical boundaries. In 1935, on the 1st of April, Odisha or the Utkala was formed, and all the Odia-speaking people were brought together and the state was formed. It was not that based on geographical boundaries the state was created. Hence, Odia is one of the oldest classical languages of India. So we have many luminaries over here, Fakir Mohan Senapati, we have Kuntala Kumari Sabat, we have Sarala Das. He translated the Mahabharata into Odia. Then we have all the Gyanpit Award winners over here, Pratibha Rai. Then we have Sitakant Mahapatra, and he's one of my most favorite authors, Sri Manoj Das. Today I'm a storyteller because I got inspired by him, and he has a treasure of almost 70,000 children literature. He has written stories for little children and in all languages. It has been translated in all languages of India. And this is what I have always been saying, because our deity, Lord Jagannath, is served with 56 variety of foods on a daily basis. Hence, all Odias are foodies, and food is not just for sustenance, it's an experience in Odisha. I think the organizers must give you a taste of Rasagolla and Chenapoda over here. Even though Pakhala would be difficult for you to have now because it's winter time, we normally eat that during summer time. But Chenapoda and Rasagolla for sure, I think Dr. Sambit will arrange for you. And as I say, from being the lowest per capita income state, now we are here where we have best disaster management. And everybody, you will find a different variety of memes on Instagram also, where you say, cyclones visit Odisha. We say cyclones visit Odisha because it is their maternal grandparents' house. Like every child during the summer vacation goes to the maternal grandparents' house. So all cyclones, Hudhud, Dana, then we have Fani, all the cyclones. It's a regular practice that they have to come to Odisha. So even Odisha, the people, resilient people of Odisha, they have learned how to tackle the cyclones and manage the disaster management system is too good, and it's been widely accepted by the Indian government and even outside that how they could do it so nicely. And now let me just tell you also that Odisha, the humility of Odia people, that we don't boast about what we do much. During the COVID pandemic, I think the people coming from outside Odisha must know that our state had sent oxygen cylinders to 8 other states of India, saving thousands of lives. So I believe that Odisha is calling you, and you won't regret answering it. Thank you so much.
Thank you very much, ma'am. That was truly enlightening. Good evening, everyone. With this, we come to the most awaited segment of tonight, the cultural program. So now I would like to welcome on stage a professional Odissi and Sambalpuri dance troupe, the Adrita Children Home. Before that, I would like to request on stage the founder of Adrita Children Home, Professor Aditya Kumar Mohanty, to kindly speak a few words.
Namaskar to all of you. We feel greatly privileged and honored to present before you the Odissi and folk dance performance by inmates of Adrita Children Home. Adrita Children Home is one of its kind in the country. Right from the beginning, we nurture children. We try to nurture them to excellence. Every child is uniquely endowed, so we identify their native talents right from the beginning and give them a supportive ambience so that they grow into excellence. We have 10 centers, 600 children. They join us when they are as old as day one. And by the grace of the divine and the community support, it has grown from strength to strength. Now, the first item that will be presented before you is Mangalacharan. As you know that Odissi, as a classical dance form, is grounded in religiosity. So Odisha is a land of temples and rivers. So the mudras and bhangis, postures, gestures are taken from the temple walls of Lord Jagannath. So the first item, the invocatory deity is Lord Krishna. Krishna means one who attracts. You know, the whole universe is everything moves around a cosmic hub. So it is said that the cosmic hub is not material but conscious. So animate or inanimate, living or non-living, everyone gets attracted to that supreme state. So we have today with us the budding talents, young talents of Adrita, who will be presenting before you the Mangalacharan on Lord Krishna. Thank you.
सुरेन्द्र पादवन्दनं यशोदानन्दनन्दनं सुरेन्द्र पादवन्दनं सुवर्णरत्नमण्डनं सुवर्णरत्नमण्डनं नमामि कृष्ण सुन्दरं नमामि कृष्ण सुन्दरं नमामि कृष्ण सुन्दरं भवाब्धिगणधारकं भयार्तिनाशकारकं भवाब्धिगणधारकं भयार्तिनाशकारकं मुमुक्षुमुक्तिदायकं मुमुक्षुमुक्तिदायकं नमामि कृष्ण सुन्दरं नमामि कृष्ण सुन्दरं नमामि कृष्ण सुन्दरं
ता किट्टि तक धी किट्टि तक गदिगन धातिन्ना तातिन्ना धातिन्ना तातिन्ना धा धा तेरे किट तक तक तेरे किट धा धा तेरे किट तक तक तेरे किट धा धा गदिगन धा 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 गदिगन धा 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 गदिगन धा
विनाश विनाशन मुरली बदन रास मध्ये धेई त्रिगड़ धिंदा किटा ताता त्रिगड़ता जमुनार कूले उभा निप मूले त्रिभंग भंगिरे चाहे त तिनि तिनि ताक तिनि धेयाता धिनि अघा कुमारिण पका कुचिरी गोपे उभा हेल पर्वत धरी धेनुका असुर आसिला करे वृक्ष उपाड़िन पिटिल सिरे घोर दाबानल भक्षण करी गोकुल रखिल कंस कुमारी बंशी को तेजिण चक्र को धरी मही को रखिल असुर मारी दश विध रूप धारकम नमामि कृष्ण सुंदरम नमामि कृष्ण सुंदरम नमामि कृष्ण सुंदरम। कृष्णोऽस्ति पुरुषोत्तमः कृष्णोऽस्ति भगवान् स्वयं कृष्णोऽस्ति पुरुषोत्तमः कृष्णोऽस्ति भगवान् स्वयं गोपीजनवल्लभः कृष्णाय प्रणमाम्यहम् कृष्णोऽस्ति पुरुषोत्तमः कृष्णोऽस्ति भगवान् स्वयं कृष्णोऽस्ति पुरुषोत्तमः। अंतरिक्षे जले स्थले मनसाभिक्लिप्ता चले अंतरिक्षे जले स्थले मनसाभिक्लिप्ता चले वराणं वर्तते वरिष्ठ नारायणोऽस्ति नारायणां कृष्णोऽस्ति पुरुषोत्तमः कृष्णोऽस्ति भगवान् स्वयं कृष्णोऽस्ति पुरुषोत्तमः।
मथुरायां गोलोके च गोलोके त्रिलोकेषु च मथुरायां गोलोके च गोलोके त्रिलोकेषु च भावे भवति ते सोऽस्ति जानाम्यहं तन्मधुरं भावे भवति ते सोऽस्ति जानाम्यहं तन्मधुरं कृष्णोऽस्ति पुरुषोत्तमः कृष्णोऽस्ति भगवान् स्वयं कृष्णोऽस्ति पुरुषोत्तमः कृष्णोऽस्ति भगवान् स्वयं गोपीजन वल्लभश गोपीजन वल्लभश कृष्णाय प्रणमाम्यहं कृष्णोऽस्ति पुरुषोत्तमः कृष्णोऽस्ति भगवान् स्वयं 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 कृष्णोऽस्ति पुरुषोत्तमः
किट्टी तक धे धे किट्टी तक धे धा तिन्ना ता किट्टी तक धे धे किट्टी तक धे धा तिन्ना ना किट्टा किट्टी तक तेरे किट्टे ता दे किट्टी तक तेरे किट्टे ता किट्टे ता किट्टे ता किट्टे ता किट्टे ता दे करतक धे करतक धे करतक धे करतक धे ता दे करतक धे करतक धे करतक धे करतक धे ना किट्टा किट्टी तक तेरे किट्टे ता दे किट्टी तक तेरे किट्टे ता किट्टे ता किट्टे ता किट्टे ता किट्टे ता दे करतक धे करतक धे करतक धे करतक धे ता दे करतक धे करतक धे करतक धे करतक धे धागे धातिंदा तातिंदा तातिंदा ताथिनि थिनक धागे धातिंदा तातिंदा तातिंदा ताथिनि थिना धागे धातिंदा ताके धातिंदा धागे धातिंदा धातिंदा धागे धातिंदा ताके धातिंदा धागे धातिंदा ताके धातिंदा त्रिगड़ थे तीन त्रिगड़ ता गिदिगिनदा त्रिगड़ थे तीन त्रिगड़ ता गिदिगिनदा त्रिगड़ थे तीन त्रिगड़ ता गिदिगिनदा थिन दाग थिन थिना किटा थिन तक थिन थिना किटा थिन थिना किटा थिन तक थिन दाग थिन थिना किटा थिन तक थिन थिना किटा थिन थिना किटा थिन तक किटा तक गिदिगिनदा
Friends, it means that everyone can. It also means that no child is ordinary. Every child is extraordinarily endowed. If you can identify the native knack and disposition of a child right from the beginning, then every child can grow into excellence. Now, during Lent hours, the children are given training in extracurricular pursuits. Nothing is imposed. We try to give them an opportunity so that they can hone their talent. They grow under the tutelage of experts in the field. Those who are in Bhubaneswar, you can visit our children home. It is one of the model homes in the country. Now, the last lyric was composed by Prabhat Ranjan Sarkar and choreographed by Guru Bharat Charan Giri. The next presentation would be on Lord Shiva. As you know that when human society was an array at the inception of human civilization, Lord Shiva introduced rhythm into society. Society doesn't mean living together. Even elephants, sheep, they live together. Society means to live together with shared sense of values and sense of purpose. So he was the one, you know, he was the invented medicine and he was a Nataraj. He also taught the dance. So he's a Nataraj. So this particular item will showcase different feats of Lord Shiva. I think I would relish it very much. You'll be happy to know that these children go overseas also. They have gone to the US, Singapore, and Malaysia performed. And it is sheer grace of the divine that they could We actually brought them. They are inside. I can tell you, we brought them to give them identity. But now we have our identity to them. 2 of our children went to NASA last year. So every child comes with a promise. We have to appreciate the inherent talent of a child and try to give a supportive ambience so that they grow into fullness. So I'm pretty sure that you will enjoy this dance. It's a fast dance on Lord Shiva. Mahesa Ashtakam, 8 different feats of Lord Shiva. Thank you.
शङ्करं चन्द्राचूडं महेशं हरं शङ्करं चन्द्राचूडं गिरिशाशिवं पार्वतीशं सुरेशं त्रैलोक्यपति नौमि आद्य हवज्ञारूपं विरूपं परं मङ्गलं मङ्गलाद्यं स्वरूपम् महादेव देवं परं ज्योतिराद्यं परं धामं पञ्चाननन्तत्वरूपम् परं धामं पञ्चाननन्तत्वरूपं जटाचूटगङ्गं कृतानङ्गभङ्गं जटाचूटगङ्गं कृतानङ्गभङ्गं श्रुतौ नागराजं श्वसन्तं वनन्तम् ध्वंसिनं बिभ्रातं चर्माचेणं बिभ्रातं चर्माचेणं बिभ्रातं चर्माचेणं श्मशाने वसन्तं स्वभूतेन तन्तं चिताभस्मलेपं चलन्मुण्डमालं श्मशाने वसन्तं स्वभूतेन तन्तं चिताभस्मलेपं चलन्मुण्डमालं हृताशं विशेषं दीनेशं निशेषं गणेशं गणेशप्रियं सर्वरूपं गणेशं गणेशप्रियं सर्वरूपं 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 नमस्ते नमस्ते महादेव शंभो नमस्ते नमस्ते सदानंद जोगिनी नमस्ते कृपा पार सिंधो
नमस्ते नमस्ते कृपा पार सिंधो
कुरु त्वत्पदे में सदा भक्ति भावं कुरु त्वत्पदे में सदा भक्ति भावं कुरु त्वत्पदे में सदा भक्ति भावं नमः सर्वस्वरूपाय तुभ्यं नमः शुभ्ररूपाय ते शङ्कराय
नमः सर्वस्वरूपाय तुभ्यं नमः शुभ्ररूपाय ते शङ्कराय
नमस्ते नमस्ते परं गोत्रवासिन्
नमस्ते नमस्ते परम गोत्रवासिन्
परानन्दमाते मोहोषाधिरूढं परानन्दमाते मोहोषाधिरूढम् नमः पार्वती प्राणनाथाय तुभ्यं नमः स्थूलसूक्ष्मस्वरूपाय नित्यम्
नमः पार्वती प्राणनाथाय तुभ्यं नमः स्थूलसूक्ष्मस्वरूपाय
नमस्ते नमस्ते परं शूलपाणे
नमस्ते नमस्ते परम शूलपाणे
नमस्ते नमस्ते भवे भैरवाय नमस्ते नमस्ते भवे भैरवाय क्षमा स्वापराधं कुरु ज्ञानबोधं परं पूतमूर्ते सुधूर्तावतसं
क्षमा स्वापराधं कुरु ज्ञानबोधं परं पूतमूर्ते सुधूर्तावतसं
नमो नागयज्ञो पविताय तुभ्यं
नमो नागजाग्यो पविताय तुभ्यं
जरा मृत्युनाशाय मे त्वं प्रसीद जरा मृत्युनाशाय मे त्वं प्रसीद जरा मृत्युनाशाय मे त्वं प्रसीद
Namaskar. Due to constraint of time, shall not be in a position to present as many items as we could. So we'll try to wrap it up in another. Acha. Odisha, we are proposing to. Huh? Na, habani program. Okay. Folk dance some other time, if Lord so wishes, will be before you. So that will be some other, because by 9 o'clock you are supposed to have your dinner. We are running behind the schedule. So let us respect time, and the whole day you must have been preoccupied. So body and mind has a limit also. The receptive threshold is also limited. So with these words, we thank you all, and we are grateful to you, and we solicit your blessings so that the children will grow from strength to strength. Namaskar.
Hearing, and hopefully you are enjoying this evening. The next performance will be about the traditional instrumental by Pandit Jawahar and his team. So I request Pandit Jawahar and team to deliver their outstanding and memorable performance. Sir, please.
Pranam to all. First, I would like to thank Dr. Saurav Mishra and all teams. We are now presenting Rag Yaman, set to Madhyalaya Tintal, 16 beat. So, Namaskar. Thank you so much. Thank you.